neoplasm of the breast. We have Dr. Kalita and in breast kind of national and national publications. Talk on
Dedi.
Madam, మీరు వినట్లేదా?
Kavita Verma ma'am to take over the session. All right. Good morning, everybody.
उसकी तो थी रोटी। डब्बा रहने दो, उसको भी दवा दें, डब्बा धो दो और रोटी उनको दो, थोड़ी सी दवा देंगे।
Good morning, everybody. So today, first of all,
Hello, Kavita ma'am. Ma'am, can you speak?
oh yeah, can I start now?
Yes, ma'am. Continue, ma'am, please.
Okay, I can continue. Okay, all right. So fine. Okay, finally, thank you everybody for putting so much effort for making this conference a success. So my name is Kavita Verma, and so as a kid, I always wanted to be a part of AIMS. I always wanted to study at AIMS. So this is my closest association so far. So thank you so much to Dr. Jyotsna Nigam for inviting me for this lecture. It's been a pleasure and an honor to be here and presenting. So the topic of my talk today would be breast spindle cell neoplasms with emphasis on metaplastic carcinoma, its approach and recent advances. During the talk, I would be talking briefly about the classification of breast carcinoma, how it evolved from the very first WHO edition, 1968, to the present. Where was metaplastic carcinoma then and now in that classification? The main focus of the talk will be metaplastic carcinoma, the various morphologies of metaplastic carcinoma, from very blunt-looking lesion to a highly malignant spindle cell, as there is a wide differential diagnosis for metaplastic carcinoma, ranging from very low-grade looking spindle cell lesion to high-grade. So I would talk about the differential diagnosis, like what to consider when we are looking at low-grade spindle cell lesion, and what are the things one should consider looking at a high-grade. Having those differential diagnoses is very important because based on those, we can use immunohistochemistry to further diagnose a challenging lesion. In the end, I would briefly touch upon the molecular alterations in these lesions. So this is a table from WHO classification first edition published in 1968. The life was very simple then, not a lot of subtypes. We have in situ carcinoma and infiltrating. In special types, not very many. However, there is like one type which could be a part of metaplastic carcinoma, which was mentioned as squamous cell carcinoma. In the second edition, not a lot of lesions were described. However, metaplastic carcinoma had a different name here. In the second edition, it was called carcinoma with metaplasia. And the metaplastic cells could be squamous, spindle cell, chondroid, osseous, or it could be mixed. And after a couple more editions, this is the most recent classification of WHO. And you can see this is such a big classification, can't even fit into one page. So we have a lot of subtypes now. So I would not touch various subtypes as there's another breast lecture coming upon very soon. But on today's topic, on today's lecture, I would be mainly focusing on metaplastic carcinoma. So in WHO recent classification, metaplastic carcinoma is divided into multiple parts. There are various subtypes like low-grade adenosquamous, high-grade adenosquamous, fibromatosis-like metaplastic carcinoma, spindle cell carcinoma, squamous cell, or metaplastic carcinoma with heterologous elements. Okay, so now let's start with metaplastic carcinoma. Okay, so metaplastic carcinoma accounts for less than 5% of invasive breast carcinomas. Purely mesenchymal metaplastic carcinoma is even rare. Age group, clinical features, and radiological features are same as that of invasive ductal carcinoma NOS type. But what is not same is that metaplastic carcinomas have lower response rate to conventional adjuvant chemotherapy. And as we all know that triple negative carcinomas has bad prognosis, metaplastic carcinomas have even worse prognosis than triple negative cancers. According to WHO classification, morphologically, metaplastic carcinomas are characterized by differentiation of neoplastic epithelium into squamous cells and or mesenchymal appearing components. And these mesenchymal components could be spindle, chondromyxoid, or osseous. And we can have pure spindle cell lesion or like pure spindle cell metaplastic carcinoma, or we can have admixture of spindle cell and other morphologies like carcinomas. And it is important to find DCIS. And when DCIS is not present, immunohistochemistry is really helpful. So metaplastic carcinoma could be pure spindle cell type, or we can have identifiable carcinomatous component. And as I mentioned, there are various morphologies of metaplastic carcinoma, which included low-grade to high-grade adenosquamous, fibromatosis-like, spindle cell carcinoma, squamous cell carcinoma, and metaplastic carcinoma with heterologous elements. And now I'm going to describe all these morphologically one by one. So this is the first one, which shows adenosquamous carcinoma. And as you can see, the adenosquamous carcinoma can be low grade to high grade. And as the name suggests, in low grade, the cytology is very bland. We have irregular infiltrating glands into the stroma. The stroma can be fibrotic, desmoplastic, or cellular. A characteristic feature noted is the sprinkling of these lymphocytes at the periphery of the lesion. So this is a morphology of adenosquamous carcinoma. So I would like you to consider few differential diagnoses when you look at adenosquamous carcinoma. First, the clinical history is very important. So if I have this lesion and it is present superficially near the skin, this could very well be epidermal inclusion cyst. However, if we know that it is a deep-seated mass, then the differential of adenosquamous comes into play. So the location is very important, whether it's superficial or deep. It could be, if it's superficial, EIC or epidermal inclusion cyst or serigmomatous tumor, like skin adnexal tumors are one of the differential. This can also be seen with reactive metaplastic change if there is a history of previous intervention, because squamous metaplasia has been seen in association with medial tract. And then this morphology can be of tubular carcinoma. And we all know that tubular carcinoma is usually strongly positive for ER and PR, while adenosquamous is triple negative. So this is an example of adenosquamous carcinoma. This is metaplastic carcinoma with squamous differentiation. More squamoid pearls here. So again, important to find in situ carcinoma, DCIS. And here is more adenoid, and squamous features. So this is an example of metaplastic carcinoma with squamous differentiation. And here we can see radiologically there is an irregular mass, grossly a white lesion infiltrating with the breast parenchyma. Same we can see microscopically. That irregular mass, very paucicellular pink lesion going into the breast stroma. Again, paucicellular lesion with some stellate cells, not very atypical. But on higher power, we can see some atypical nuclei, plump with high NC ratio. So when we see such kinds of cell, what are the things one should consider? So this could be a reactive atypia or post-radiation changes. So we have to make sure that these are not the stromal cells, these are the epithelial cells to make the diagnosis of fibromatosis carcinoma, fibromatosis-like carcinoma. So these cells are positive for CK, and this is one of the entity, fibromatosis carcinoma is one of the entity where it's almost impossible to make a diagnosis without immunostain. So these atypical spindle cells are positive for cytokeratin. So this is an example of fibromatosis-like carcinoma. And this is very typical high-grade spindle cell lesion, very pleomorphic, a lot of atypical cells, ugly mitosis. So this is high-grade spindle cell, metaplastic carcinoma, spindle cell type. So these are the different morphologies and various morphologies which you can see. One more. Matrix producing, on the left side, we have cells in the background of chondromyxoid matrix. And here, bone formation, which is an example of heterologous elements. So now we have all the examples of metaplastic carcinoma. Let's see how we are doing with the examples. So I'm going to show you a few interesting cases and few lessons to be learned from them. So this is a first picture, again a spindle cell lesion infiltrating with the fat. On high power, again, some ugly looking cells with high NC ratio, prominent nucleoli. So is this a metaplastic carcinoma? Not really. More sections were taken from this lesion, and one of the sections shows a biopsy site cavity. Another section has hemorrhage and inflammation. So this is an example of reactive spindle cell nodule. So my point to show this case is that clinical history is a very important part, whether the lesion was superficial or deep, again, if there is a history of previous intervention. So reactive spindle cell nodule is an exuberant myofibroblastic reaction, usually occurs 2 to 4 weeks after biopsy. Typically, we have hemorrhage, fat necrosis, inflammations, giant cells, and foreign material. And majority are less than 1 centimeter. And such small size would be very unusual for a malignant spindle cell lesion. At the same time, it is highly unlikely that a sarcoma would be clinically and radiologically indolent. So clinical and radiological findings are important clues. Some more examples of biopsy site cavity. You can have hemorrhage, foreign body material, some giant cells, inflammation, and hemosiderin-laden macrophages. Another important thing to rule out when you're looking for spindle cell lesion. So this is also very cellular spindle cell lesion. Some mitosis, extravasated RBCs, some myxoid changes in the background. And if I tell you that there is a history of trauma and this is a very, very rapidly growing lesion, so you would think in terms of nodular fasciitis rather than metaplastic carcinoma. And of course, you do CK or cytokeratin, it would be negative. So this is nodular fasciitis, more fibroblastic-like reaction. So point to remember is history and clinical clinical presentation is very important, whether the mass was incidental or it's a big mass lesion. Is there any history of previous intervention? Now, another lesson. These are two sections from two different cases, and all the other slides are also, they show high-grade spindle cell lesion. And here, in both these, so these are two different cases, both with spindle cell proliferation, and there are areas of malignancies with high mitosis. However, CK was negative. So they performed one CK and it was negative. So because it was a big mass, more sections were taken. And in this first case, more sections showed this squamous differentiation and areas of DCIS. So this was metaplastic carcinoma. And the bottom case, more sections showed this epithelial area, and there were also leaf-like structures, periglandular condensation, and areas which resemble borderline phylloides tumor. So this is an example of phylloides tumor. So second point to remember is gross examination and extensive sampling is very important. And of course, HNE is the gold standard, which I will be touching very shortly. Now, third point to remember. So this is an example of, again, a spindle cell lesion, which has two areas, paucicellular, keloid-like fibrotic area, mixed with hypercellular area. Some normal lobules can also be shown here. Again, fibrotic desmoplastic, keloid-like areas with few cells in the background. Based on this morphology, one would think in terms of scar, fibromatosis, or fibromatosis-like carcinoma. Again, as I mentioned, that this is one of the entities where it is almost impossible to make a diagnosis without IHC. So in this case, IHC was performed, and see, the cells are very, very nicely positive for cytokeratin. So this is an example of fibromatosis-like carcinoma. So, especially in spindle cell lesions, immunohistochemistry can be your best friend. As IHC plays very important part in the workup of spindle cell lesion. So let's discuss some of the immunohistochemical stains which are important and one should perform when dealing with spindle cell lesion. When you have a spindle cell lesion, always start with cytokeratin. The important thing is use a panel, not a single CK, because the staining can be focal or totally absent for one, while it would be present for the other. So when you're using a cytokeratin stain, use a broad spectrum, high molecular weight, low molecular weight, and basal. So a wide spectrum of cytokeratin should be used. And repeat the CKs if it is negative on needle biopsy, repeat on excision. The important thing to remember is focal CK would be positive in malignant PT. So again, gross examination and finding phalloides-like area is very important to differentiate between these two. Another stain is P63. P63 is positive in 90% of metaplastic carcinoma. It is helpful when CK is negative. In 2004, there was a study which says that P63 is very sensitive and highly specific for metaplastic carcinoma. However, 10 years later, it was shown that expression of focal P63, P40, and CK can also be seen in benign or borderline PT in addition to metaplastic carcinoma. Beta-catenin is one important stain, as we all know that nuclear positivity is seen in most fibromatosis. Important point that focal positivity can be seen in spindle cell metaplastic carcinoma, fibromatosis like carcinoma, and even phalloides. Around 20 to 25% of fibromatosis like carcinoma are positive for beta-catenin, but usually the staining is more cytoplasmic, as in contrast to the nuclear staining in fibromatosis. Next stain is CD34. CD34 is important more in the low-grade spindle cell lesion as compared to high-grade lesion. So positive CD34 is seen in myofibroblastoma, spindle cell lipoma, pseudoangiomatous stromal hyperplasia, and phalloides tumor. So as we are discussing the immunostains, I would like to touch briefly a very new stain, which is TRPS1. I remember 2 years back in one of the conferences, USCAP, United States and Canadian Association of Pathologists, this was a hero, and most of the breast posters had something to do with this TRPS1. And so this TRPS1 is, it's called trichophalangeal syndrome 1. So this is a transcription factor from GATA family, and it is involved in breast carcinogenesis and required for breast cancer survival. When it's positive as a strong nuclear staining. It is positive in normal breast epithelium, ERPR positive cancers, and triple negative. So the importance here is that this is positive in triple negative cancers in more than 90% of the time, including metaplastic cancers. And here are some of the pictures which shows strong nuclear positivity in triple negative cancer, positivity in the metaplastic carcinoma, and both epithelial and stromal positivity in the phalloides. So third point to remember is perform IHC based on your differential diagnosis. And fourth point is beware of the mimics. As we say that your eyes will only see what the mind knows. If we do not know these differentials, it is hard to get to the correct diagnosis. So always remember reactive metaplastic changes. Not all spindle cell lesions are metaplastic carcinoma. We can have myofibroblastoma, PASH, and other things in the differential diagnosis. All right. So we all learned our lessons that growth is important, clinical history is important, differential diagnosis, and based on those differential diagnoses, immunohistochemistry is important to reach to the correct diagnosis. So again, this table summarizes it very nicely. So approaching the diagnosis. So clinical history, radiological, gross, HME, differential diagnosis, and based on differential diagnosis, IHC, and if needed, molecular tests are required to reach correct diagnosis in the challenging cases. So now let's talk about the HME. So when I'm looking for on a slide, so this is one of the simplest approach when you have a spindle cell lesion. So first thing is try to look for whether it's a pure lesion, either pure spindle cell lesion, or the lesion is mixed with other components like carcinomatous component, heterologous elements, or chondromyxoid elements in the background? Is there a DCIS or things like that? So first thing is pure lesion, or it's both spindle cell and carcinomatous component. Once we have that, try to find whether it's just categorize whether it's a bland looking lesion or it's a malignant lesion. So this is a table from a very recent published article, which very beautifully describe how to approach these lesions. So again, the same thing. First, so we have a spindle cell lesion. If is it biphasic, it has both epithelial and spindle cell component, or it is monophasic. When it is biphasic, it has both epithelial and spindle cell lesion. So we know fibroadenoma is very common. And then other things are in high grade category, we have borderline or malignant phylloides and biphasic metaplastic carcinoma. And as I mentioned, that with these two differential, extensive sampling is important. If in phylloides tumor, you have leaf-like structure, it's very glandular condensation, then you can have area which is more like phylloides or borderline phylloides, like different area. And molecular studies of MED12 mutation is important. And in metaplastic carcinoma, DCIS plays a very integral role. However, in monophasic spindle cell lesion, in low grade, always remember fibromatosis like carcinoma and fibromatosis. In high grade lesions, we have metaplastic carcinoma, sarcoma, metastases, and melanoma. So putting those criteria, let's try to do some cases. So this is a lesion. So first, we know that this is monophasic or biphasic. This is mostly like monophasic with some slit-like spaces, low grade, high grade. So this is a low grade spindle cell lesion. And if I tell you that this is positive for CD34 and SMA, this is PASH. So, or pseudoangiomatous hypoplasia, which is a benign myofibroblastic proliferation, and it simulates vascular lesion. However, the vascular markers are negative, and this lesion is positive for CD34. Another example, and putting the same criteria on this one. So is it a monophasic or a biphasic? So we can say this is a monophasic lesion with mostly spindle cell proliferation with some keloid, some fibrotic areas in between. And so based on this differential, based on this morphology, the differential diagnosis include, this could be area around the biopsy site cavity or scar, or fibromatosis like carcinoma and fibromatosis. And if I tell you that this is CK positive, P63 positive, beta-catenin cytoplasmic positive, SMA positive, CD34 negative, and triple negative. So this is very typical of fibromatosis like metaplastic carcinoma. Some more examples of fibromatosis like metaplastic carcinoma: very low grade looking spindle cell lesion and CK positive. Very similar morphology of low grade spindle cell lesion, again infiltrating in the stroma. However, CK negative and nuclear positive for beta-catenin. So this is fibromatosis. Now, another example of a low-grade spindle cell lesion, same criteria, monophasic or biphasic. We know this is monophasic. Low-grade, high-grade. This is a low-grade spindle cell lesion, monophasic. And looking at just the morphology, the differential includes this leiomyoma or nerve sheath tumor like schwannoma and myofibroblastoma. And if I tell you that this lesion is positive for CD34, ER, actin and desmin, and negative for keratin, so this is very typical of myofibroblastic carcinoma. One important thing of myofibroblastic carcinoma is that there is loss of retinoblastoma nuclear expression. So these cells are the normal cells or inflammatory cells. However, the lesion is negative. Just remember, myofibroblastoma is a well-circumscribed lesion, and it comprised of bland-looking spindle cells and dense ropey collagen can be there. It is a part of 13q retinoblastoma family of tumors, as majority show deletion or rearrangement of 13q, which may result in loss of retinoblastoma expression on IHC. One more thing to remember, that this lesion, this is a malignant appearing lesion, however, it is totally benign, is nodular fasciitis and reactive biopsy site changes. And this is a table which summarizes all the lesions which are low-grade spindle cell lesions in the breast, which includes fibrous scar, nodular fasciitis, PASH, myofibroblastoma, fibromatosis metaplastic carcinoma. I don't go into detail, but some of the features which one should remember when dealing with a low-grade metaplastic carcinoma are, in fibrous scar, there is a previous history of injury. Typically, fat necrosis, foamy macrophages, foreign body giant cells, and hemosiderin can be seen. In nodular fasciitis, rapidly growing mass. In PASH, we see slit-like empty spaces lined by bland cells and positive for CD34. Myofibroblastoma is a well-circumscribed lesion similar to fibroadenoma, CD34 positive. You can have thick collagen bundles. In fibromatosis and fibromatosis-like carcinoma, it's sometimes difficult based on morphology. They both can look very similar. However, in fibromatosis-like carcinoma, we might see DCIS or squamous differentiation, and IHC is very, very important. So fibromatosis-like carcinoma are positive for CK or P63, like one of the CKs and P63. Now, coming to high grade, that was the summary of all the low grade spindle cell lesions. Coming to high grade spindle cell lesions, when there is a high grade spindle cell lesion, the first thing to rule out is metaplastic carcinoma and metaplastic carcinoma. So again, this is an example of metaplastic carcinoma, high grade spindle cell type. So we can see very pleomorphic cells. The differential diagnosis based on this is metaplastic carcinoma or metastasizing sarcoma or malignant melanoma. So IHC is very important. But this is an example of metaplastic carcinoma. And this was strongly P63 positive, which confirms our diagnosis. Another example, this is a squamous cell carcinoma, metaplastic carcinoma, squamous cell type. Again, important thing is to find out DCIS. This is an example of metaplastic carcinoma, matrix producing. Here we can see the chondromyxoid areas in the background and also heterologous elements like bone formation here. So in the same category of high-grade spindle cell lesion, first is metaplastic carcinoma. So we always think in terms of metaplastic carcinoma. The second important thing in high-grade spindle cell lesion is malignant or borderline phylloides. In phylloides, area of gland or area epithelial component, if we have, is very important. Leaf-like structure, periglandular condensation, and if we have areas which show the transition from benign to borderline to malignant, they are very important factors which can help us. And then MET12 mutations are part of phylloides tumor. So this is an example of malignant phylloides tumor. Another high-grade spindle cell lesion is post-radiation angiosarcoma. This is present in the skin, a high-grade lesion with slit-like spaces and vascular channels. The endothelial cells are plump, atypical with a lot of mitotic activities, and this lesion is typically positive for ERG and MYC. So this is post-radiation angiosarcoma. It's a very rare malignancy, but it is the most common type of memory sarcoma. Malignant vascular neoplasm and usually arises 6 to 7 years after radiation. And this is because this is vascular lesion, it is positive for CD31 and ERG. strongly positive. Now, in the same category, the last lesion in high-grade spindle cell lesion. So this is more like epithelioid than spindle. It actually looks like a lymph node. So based on this morphology, the differential diagnosis, it could be like undifferentiated carcinoma or like metaplastic carcinoma, some sarcoma metastasizing to the breast, malignant melanoma, or even lymphoma, like diffuse large cell B-cell lymphoma can very much look like this. So on IHC, this lesion is positive for MART and melanoma markers. So this is an example of metastatic malignant melanoma. And here is a summary of all high-grade lesions in the breast, so which includes metaplastic carcinoma, spindle cell carcinomas, malignant phylloides tumor, angiosarcoma, and primary and metastatic sarcomas. Based on these, you do the IHCs to help you out. And in the end, these are some molecular studies which are associated with spindle cell lesions of breast. In fibromatosis, we see somatic mutation of beta-catenin gene on 3p21. In nodular fasciitis, there's a translocation with MYH9 USP6 fusion. In myofibroblastoma, there's rearrangement of 13q and 16q, while metaplastic carcinomas are associated with p53 mutations. And if it is sarcoma, it would show the same cytogenetics as that of the soft tissue. So these are some of the board questions which they always ask about the molecular. So in summary, spindle cell lesions of breast comprise of heterogeneous groups of lesions ranging from reactive and benign processes to aggressive malignant tumors. It is important to recognize the different types of metaplastic carcinomas, as the high-risk subtypes have worse clinical outcomes than triple-negative breast cancers, as there is a considerable overlap between low-grade lesions, high-grade lesions, and there are various differential diagnoses. So it is important to have a structured approach and focused IHC panel. Clinical history, immunohistochemistry, and molecular assays are helpful in making a correct diagnosis in morphologically challenging cases. These are some of the references I use for this talk, and thank you so much for your attention. Hello. Is there any questions? Hello? Hello? Hello?
Can you hear me, ma'am?
Yes, I am now. Uh-huh.
Yes, ma'am. My query is, ma'am, in case if we are having a tumor which is poorly differentiated, we don't know whether it's some grade 3 IDC or not. But at the same time, we are having nice squamous differentiation coming in few focal areas.
Mhm.
Is there a need to prove that that poorly differentiated area is a glandular component or it's a poorly differentiated squamous component?
Mhm.
In that case, what IHC we need to use?
So if you have a squamous differentiation, and it's a very typical, it is usually associated with metaplastic breast carcinoma. And as I mentioned that it is important to see whether it's coming from the overlying skin. It is not the squamous cell carcinoma. It is important to rule out squamous cell carcinoma from like skin or from like if there is a history of another metastasis from like lungs or somewhere. But it's important if you find DCIS, then you know you're dealing with the breast, but it's important to rule out that it is not coming from the skin, that or there is no insight to in the skin. Then you can and if it's a deep seated mass and then you can confidently make a diagnosis of metaplastic carcinoma.
Ma'am, we had a case and we had no skin involvement, and we have excluded the mets also, and it is quite deep seated. So in such cases, just a CK will do, or should we prove that that poorly differentiated area is of glandular origin? That's what my question, ma'am.
So if it's deep seated and you
No,
ruled out, hello.
No DCI is a component also, ma'am.
Yeah. So any so like CK would be positive from outside, like squamous cell carcinoma from outside and from breast. But there is a recent marker which I mentioned, TRPS1. It could be it if it is coming from breast, it is usually positive in breast. So which is a very recent immunomarker and which can be used for breast primaries. So that is one of the helpful thing. But if it's deep seated and you have ruled out other metastases, the possibility with squamous differentiation is it's metaplastic carcinoma.
Thank you, ma'am. Thank you so much.
You're welcome.
Thank you, ma'am.
Yeah, thank you.
Ma'am, we request you to accept our token of gratitude, which will be sent to you by the postman.
Oh, that's very sweet. Thank you. So should I stop sharing my screen now?
Yes, ma'am. Please stop sharing the screen.
All right. Thank you. I will.
Thank you, ma'am.
Thank you.
Dr. Josna, ma'am, Organizing Secretary, HOD, Department of Pathology, AIMS, Mangalagiri, to felicitate the chairpersons. Thank you, ma'am. And thank you, the chairpersons, for sparing your time. The next session is about genomic and molecular updates in gastric adenocarcinoma. For this session, I feel privileged to introduce our chairperson, Dr. Aparna Chinnam, ma'am, Professor and HOD of Pathology Department, Guntur Medical College, Andhra Pradesh. Ma'am has 23 years of working experience in the field of pathology, and she also completed postdoctoral fellowship in genetics. Ma'am has published 34 articles in various journals. We welcome you, ma'am. Now I call upon the next chairperson, Dr. Renuka ma'am, Professor and HOD of Pathology Department, NRI Medical College, Andhra Pradesh. Ma'am has more than 90 publications in various national and international journals and one national patent. Ma'am has received several awards such as State Award for Meritorious Teacher in 2013 by the Government of Andhra Pradesh, Tumala Ramabrahma Memorial Endowment Fund Award in 2012 from Guntur Medical College, Vocational Excellence Award by Rotary Adarsh of Guntur in 2014. Ma'am has also worked as a secretary and president of IAPM. Welcome you, ma'am. Now I request our chairpersons to introduce about our next renowned speaker.
Dr. Supriya Srivastava is PhD in pathology and FRC path. She's present designation is Senior Research Fellow in Singapore. She has many awards like Chang Heng Leong Research Award in Singapore NUS University. She has multiple publications on national and international journals. She has held some key positions like Research Fellow in Singapore and Research Fellow Cancer Institute NUS Singapore Institute, Research Pathologist at Cancer Science Institute in Singapore.
I request Dr. Supriya ma'am to take over the session.
Good morning, everyone. First of all, I would like to thank the organizing committee for inviting me here today. Yeah, good morning, everyone. First of all, I would like to thank the organizing committee, especially Dr. Jyotsna and Dr. Jyoti, for inviting me here. So today I'm going to present some genomic and molecular updates in the gastric adenocarcinoma. The outline of my talk would be, firstly, I would briefly touch the background of the gastric cancer. followed by the WHO update on the gastric cancer. Then I would briefly introduce the gastric cancer epidemiology program that we are running in Singapore and some of the genomic research that we are pursuing there. And in the last segment, I would just briefly introduce the various management strategies for the patients in gastric cancer. For the technical issue. So, gastric cancer, as we all know, is the fifth most common cancer worldwide. The annual incidence of this cancer is around 1 million patients worldwide. It is commonly seen in the areas of South America, Asia, and some parts of South Africa. And the mortality rate of gastric cancer is around 800,000 cancer deaths in the year 2020, as reported. So this high rate of mortality is mainly because this cancer is diagnosed at a very late stage, stage 3 or 4, where very less options are available for the treatment for the patients. Next, we come to the updates on the gastric cancer as released by the WHO Blue Book. So currently we are at the 5th edition, which was released in the year 2019. So these are the salient features that are introduced in this revised edition. First of all, the WHO has recognized that apart from the histological classification that we are using for the gastric cancer, the cancer can also be classified through molecular tests. So this has been added in the revised edition. Then there are certain rare tumor types for which molecular phenotyping is essential for diagnosis. Next, the neuroendocrine neoplasms are now divided into tumors and carcinoma based on their molecular profiles. Then a new chapter or a section has been introduced for the genetic syndromes seen in the digestive tracts. And finally, the WHO has also recognized that most of the gastric cancers are now inflammation-driven, and the most common etiology is H. pylori infection. So in the coming few slides, I would briefly touch each of these salient points. Now, the reason that why treatment of the patients who are having gastric cancer is quite heterogeneous is because one size fits for all approach doesn't work for this cancer. So to address this, the Cancer Genome Atlas, also known as the TCGA, in the year 2014, and the Asian Cancer Research Group in the year 2015, they developed a very robust molecular classification for the gastric cancer. So the TCGA, they utilized 295 gastric cancers who were treatment naive. And then they did an array of genomic tests like the DNA sequencing, the copy number variations, RNA sequencing, and they stratified these tumors into 4 broad groups. The first group is the EBV positive group. That is, it shows Epstein-Barr virus infection. Then these patients are, these type of tumors are prominently seen in the fundus and the body of the stomach. They are showing the EBV type of methylator phenotype, and they are also showing various types of amplifications, especially the PD1 and the PDL1 axis, PIK3CA mutations, mutations in the ARID1A gene, and most important, they are showing the enrichment of immune cell signaling. What this means is that this group of patients are susceptible to the immune checkpoint inhibitor therapy. The next group was the microsatellite unstable group. So this group this type of cancers was prevalent in females, and they showed a gastric type of methylator phenotype. This type of tumors were also very high in showed very high incidence of gene mutations, and also very important that this MSI positive tumors are susceptible for immune checkpoint inhibitor therapy. Next, we come to the genome stable group. So this group of patients, the researchers saw that the diffuse type of histology was very common, and it was diagnosed at a very early stage. These showed a recurrent CDH1 mutation and mutation in the ROA gene. And another important point is that this group of tumors are not very susceptible to the immune checkpoint inhibitor therapy. Lastly, we come to the chromosome unstable group. So this was the most frequent group seen in around 50% of patients. And they had intestinal type of histology, and it was frequently located at the GE junction and the cardia. These tumors also showed amplifications in the ERB2, EGFR, and the PD1, PDL1 axis, and showed the P53 mutation in around 71% of cases. Next, the Asian Cancer Research Group in 2015, they analyzed 300 gastric cancers from Samsung Medical Center in Korea, South Korea, and they classified the tumor. They also ran a variety of genomic tests, and they classified the tumors into 4 groups. The first group was the MSI group, microsatellite unstable group. The second group was the EMT group, that is the epithelial mesenchymal transition group. Then the third group was the group that showed P53 mutation, and the fourth group was the P53 negative group. So each of these groups have their own characteristic features, just like the TCGA group. And the ACRG, they went ahead and then they tried to find out what is the prognostic significance of this molecular classification. So they did the analysis and found that the MSS, the EMT group had the worst prognosis, as you can see here, and they had a high chances of recurrence. And the best prognosis was seen in the MSI positive group, and they had the lowest risk of recurrence. So now the ACRG, they wanted to further validate their findings, and then they tested this molecular classification on 3 independent cohorts. So one was from another cohort from Samsung Medical Center, the other was from Singapore, and the third one was from the TCGA. And they were able to reproduce their findings for this molecular classification, and they found that the EMT group had the worst prognosis as compared to the MSI group. So all these molecular classification, they kind of help the clinicians and the pathologists to decide what kind of personalized treatment could be useful for the patients who are coming with the gastric cancer. Next, we come to the second salient feature, that there are certain rare tumor types for which molecular phenotyping is now necessary for diagnosis. So one of the tumor is a gastroblastoma. It's a rare tumor which is seen in young adults, mostly less than 30 years of age. It's a biphasic tumor in which you can see spindle cell component as well as the epithelial cell component. So for this tumor, the fusion in MALAT1, GLE1, and also in some cases, you can also see the fusion in EWSR1, CTPP1 genes. So the molecular phenotyping is essential, and before the pathologist sign out for this diagnosis, these molecular tests should be run, and then the report can be given out. The second tumor is the gastrointestinal clear cell sarcoma. For this, this is also an aggressive tumor seen in young age group, and it usually presents with metastasis. So for this tumor also, fusion in EWSR1 gene with either ATF1 or CREB1 is essential for diagnosis. Next, we come to the third point about the neuroendocrine neoplasm. So the WHO, they now in the latest edition, they reclassify the neuroendocrine neoplasm into neuroendocrine tumors and neuroendocrine carcinoma based on their genetic difference. So the neuroendocrine carcinomas, they show the mutations in P53 and the retinoblastoma genes, while the neuroendocrine tumors, they show mutation in the MEN1, DAXX, and ATRX genes. So this kind of helps in those cases which are grade 3 neuroendocrine tumors, and under the microscope they look quite similar to the neuroendocrine carcinoma. But then when you run the molecular test, then you get to know that these are actually having mutation in MEN1 or DAXX, and they are not the neuroendocrine carcinoma. Another important update that was made in this edition was that all the neuroendocrine carcinomas are no longer graded. All are considered as high grade by right. Then the WHO also removed the term MANIC, that is mixed adenoneuroendocrine carcinoma, and replaced it with mixed neuroendocrine non-endocrine neoplasm, highlighting the fact that that it is not only the adenocarcinoma that can be seen together with the neuroendocrine tumors, it can also be other non-adenocarcinoma tumors. And by right, it should constitute, both the components should constitute more than 30% of the neoplasm. Then there is another caveat that if the patient is, if the case is showing neuroendocrine carcinoma, then we can ignore the 30% rule, because neuroendocrine carcinoma by itself is quite aggressive and it should always be reported. Then throughout the digestive tract, there are many genetic tumor syndromes. So the WHO has now clumped together all the genetic syndrome in a separate section. And this is stated as chapter 14 in the WHO book. So here I would just touch upon two of the tumors that are seen exclusively in the stomach. One is the GAPS, that is the gastric adenocarcinoma and proximal polyposis of stomach. It was considered a part of the FAP tumor, that is familial adenomatosis polyposis, but it is exclusively seen in the stomach. GAPS is exclusively seen in the stomach and not in the colorectum. It is autosomal dominant, and it has a predilection for body and fundus, and it spares the antrum. Here we can see more than 100 polyps, which are carpeting the proximal stomach. The polyps could be the fundic gland polyps by morphology. And here again, we see a germline point mutation in the APC gene, as we see in the FAP. Next is the hereditary diffuse gastric cancer. This is another autosomal dominant syndrome, and it is caused by the germline mutation in the CDH1 gene. It is associated with the poorly cohesive gastric cancer and also lobular breast cancer. So here again, the importance of genomic testing is there. That according to the latest guidelines, patients who are showing CDH1 variant and with a positive history of diffuse gastric cancer in the family, they are recommended for prophylactic total gastrectomy. And in the cases where the gastrectomy cannot be done, then these are called for annual surveillance. Then there are a subset of patients in whom the CDH1 mutation is not seen, but there's a mutation in the CTNNA1 gene. Those patients are called for surveillance every year, And there is a very weak evidence or almost no evidence for gastrectomy. Then there is a third group of patients who do not show mutation in either of the genes, but histologically the features are those of HDGC. So they are called as HDGC-like tumors, and then they are called for gastroscopic surveillance for at least 2 years. And then there is no evidence that prophylactic gastrectomy can help in such patients. So here again, we see the importance of genomic testing if a patient comes with diffuse gastric cancer. So next we come to the etiology of the gastric cancer. So this is the Korea pathway or the Korea cascade, which was given by Dr. Pelayo Korea in 1960s. So according to him, this is the step-by-step pathogenesis for the intestinal type of gastric cancer. Then according to this pathway, the long-standing chronic inflammation due to H. pylori can change the morphology of the normal epithelium to chronic gastritis, which can further progress to atrophic gastritis and then intestinal metaplasia. So here I would like you all to recall what is intestinal metaplasia. It is a condition where the normal gastric mucosa is replaced by the intestinal type of mucosa. And now it is considered as one of the important precancerous lesions for the gastric cancer. So this intestinal metaplasia, if left untreated, can lead to dysplasia and finally adenocarcinoma. So the importance of this Korea cascade or the Korea pathway is that treatment of long-standing chronic inflammation, that is treatment for the H. pylori infection, and detecting intestinal metaplasia and dysplasia at an early stage can help in preventing the gastric cancer in long term. So now I would come up to the next part of my presentation. So as I alluded in my previous slides, the mortality of gastric cancer is quite high. And this is because most of the cancers, this cancer is detected at a very late stage where very few treatment modalities are left. So there are some countries where, like Japan and South Korea, where they have the government-sponsored surveillance program in which they are calling the patients for endoscopy and biopsy. And these programs have led to a very low rate of mortality as compared to other countries. So showing the importance of such surveillance programs in a country with a high incidence of gastric cancer. So in Singapore, we are running this gastric cancer epidemiology program. It was started in around 2004 and 2005, where we recruited patients from 4 public hospitals. These patients were Chinese in their origin. They were more than 50 years of age, and they presented with the symptoms of dyspepsia or gastritis. And they were called at year 0, that is at the point where they visited the clinician, and then called again at year 3 and year 5. So at each of these time points, the endoscopy was done and their biopsies were taken. So all the endoscopies were videoed and all the biopsies were read by a reference pathologist. And at the same time, we took the blood samples and we did the HP serology, culture and genotyping, and measured the levels of pepsinogen, which is another marker for gastric cancer. The endpoint of this study was that we wanted to diagnose early gastric neoplasia like high-grade dysplasia and adenocarcinoma so that a timely intervention could be done. So we followed the updated Sydney system for classification and grading of gastritis. So for each patient's 5 biopsies were taken, 1 each from the body lesser and greater curve, 1 each from antrum lesser and greater curve, and 1 from the incisura angularis. So this kind of gave a standardized sampling protocol for us. And then the pathologist, he or she graded the gastritis following this visual analog scale, which is again given by the Sydney in the updated Sydney system. So H. pylori, chronic and active inflammation, intestinal metaplasia, and atrophy were graded as mild, moderate, and marked. And then it was like the reports were given to the patients accordingly. So here is just an example of how we do the grading. So in this case, in the chronic gastritis, here you can see this is graded as mild because we are basically seeing the plasma cells and the lymphocytes. Like the normal number of these cells would be around 2 to 5 plasma cells or lymphocytes per high power field. So we called it mild when there are more than 3 to 4 such groups. then moderate chronic gastritis when more than 10 groups of such cells exist, and marked when we cannot see the glandular elements and only a heavy inflammatory infiltrate is seen. Then intestinal metaplasia is also graded as mild, moderate, and marked based on the percentage of the glandular epithelium that is showing metaplasia. So, for example, in this particular case, it was less than 30%. Then this case, it was moderate. It was around between 31 to 60%, and marked when it is more than 60%. So like this, we grade the atrophy, active inflammation, chronic inflammation, and H. pylori. So this is another standardized way to stage the gastritis, known as the operative linked on gastritis assessment. So we can grade the atrophy or intestinal metaplasia. So as I shown in my previous slides, we can grade the IM as grade 1, 2, and 3, mild, moderate, and marked. So we can use this table to calculate the stage of the gastritis. And it has been seen that as the stage increases from stage 1 to 4, the risk of progression to the gastric cancer also increases. So the results of the study were published last year in a very reputed journal. And the conclusion of this study was that, we found that patients with Olgim 3 and 4 were at high risk of early gastric neoplasia. Then patients who were in the stage 2 of Olgim could benefit from endoscopic surveillance. And finally, we also found that patients who had a smoking history of more than 20 pack years, they showed an increased risk of early gastric neoplasia. So these are the international guidelines which are being used globally for the surveillance of patients who are coming with the IM. So according to the regional incidence of the gastric cancer and precancerous lesions, these guidelines can be tailored. So in Singapore, we are following this guideline. So we call the patients every 3 years if he or she has shown Olgim stage 3 and 4. And every 2 years, if they are coming with more than 2 risk factors. These risk factors are smoking, age more than 50 years, incomplete IM, persistent H. pylori infection, or if they have a first-degree family history of gastric cancer. So next, we come to the genomic updates in the gastric cancer. So this slide kind of summarizes all the genomic changes that are seen in the gastric cancer. So most commonly, we see the mutations, and in gastric cancer, the mutations are most commonly seen in P53, and then there are other genes like KRAS and E-cadherin, ARID1A. Then we can see the copy number alterations, amplifications in different genes. Then the latest in the field of genomics is the methylation and epigenomics. So there are some epigenetic changes which can lead to the gastric cancer. Then alternative splicing, microRNA, mRNA changes, which can be seen in the gastric carcinogenesis. So next we come to this study that was done by our group. So here we did the genomic and epigenomic profiling of the high-risk IM cases. What we did was that we took around 150 fresh frozen tissue and FFPE from the cohort that I just mentioned in my few slides back. And then we divided this group into 3 groups. So one was a control group, which had no IM. The other 2 groups were classified as high risk, or the cases which had more moderate to marked IM. And the second group showed mild IM. So the DNA was extracted from these patients, and sequencing was done for the exomes of 766 genes. Then the sequencing results were further validated by Sanger sequencing. Then we did the laser capture microdissection, and we also validated the study by doing the IHC for the genes that were mutated. Then the sequencing results were used to assess the copy number alteration, and confirmation was done by Infinium assay. And lastly, we measured the length of the telomere using the TELSeq software. So it was seen that P53 mutation was seen in very, very few cases in the IM cases in our cohort. And here you can see that there's a nuclear expression of P53 showing that it is mutated. Then ARID1A gene is another gene that is commonly mutated in the gastric cancer, but in our IM, only 2% of the cases showed this mutation. Here you can see the loss of this protein in the IM case. However, for the FBXW7, this is another tumor suppressor gene that is commonly mutated in the gastric cancer. Around 20% of our IM cases showed the loss of expression in the high-risk IM cases.
Then the
We assessed the copy number alterations, and we found that the amplification was most commonly seen in the 8q locus. And this 8q locus actually encompasses the c-MYC gene, and we did the IHC to confirm the results. And here you can see that we can see a very strong cytoplasmic and membranous expression of c-MYC in the high-risk IM case. Some of the cases also showed amplification in the CTNNB1 gene, which encloses the beta-catenin protein. So here you can see some membranous expression of beta-catenin in the high-risk IM cases. So next, we measured the telomere length using the TELSEEK software. And I hope you can appreciate that this is the median telomere length. So the high-risk IM cases had a shortened telomere as compared to the control in our study. Next, what we did is we wanted to find out whether these genomic results could help us in those cases that we can include in our surveillance and we can progress to gastric cancer or not. So we divided the high-risk cases into 3 groups. We followed them up for 2 visits or 2 years. And we tried to assess whether the IM had regressed, that is, whether it had become mild from marked, or it persisted at the same grade, or it progressed to dysplasia. And then after we made these 3 groups, we did some molecular tests, and we found that the progressive group, that is the group that had dysplasia, it had high mutation compared to the positive and the persistent group. Similarly, the median telomere length was shorter in the progressive group as compared to the other 2 groups. And the copy number alterations was also quite high in this group. So the results of the study showed that overall IM exhibits low mutation burden as compared to the gastric cancers. However, some IMs can exhibit FBXW7 mutation, copy number alteration, and shortened telomeres. And genomic alterations can be used to predict eventual transition of the IM to the gastric cancer. So continuing the
15,000 is a total count.
that was published almost, I think, last few weeks.
And DC oxide we did
this spatiotemporal profiling of the IM. And here again, we took around 1,200 biopsies from the same cohort that I showed in the few slides before. And normal control. And we did some DNA sequencing and RNA sequencing and found that around 26 genes, SOX9, these are very prominent in the IM cases. Next, what we did was that we took a gastric cancer case which had IM and the normal, and we used some probes to highlight these areas. So the green color is the pancytokeratin.
She spoke about updates.
The blue color is the smooth muscle actin marking the fibroblast, and the red is the CD45. So we found that within the IM areas also there are 2 lineages of cells. One was the IM stem cell and the other was IM enterocyte. And then we found by the RNA sequencing that this stem cell profile matched quite closely to the gastric cancer RNA expression level. So the results of this study showed that genomic profile that around 26 intestinal IM driver genes can be found, including the SOX9. Then we also found that within the IM also there could be heterogeneity, and stem cell population can be linked to malignancy. We found that these clinical models can help us to improve the identifications of IM at risk of gastric cancer progression. So all these molecular tests and genomic tests because IM is a very common condition, and I'm sure every pathologist must be having such cases diagnosed day in and day out. So how to tell whether this, what is the importance of this IM, whether they are going to progress to gastric cancer or not. So these tests can be done, obviously, when the cost permits. And we can tell the patient that, okay, you are at a high risk and you need to come regularly for surveillance. Or we can tell the patient that, okay, you are not in the high risk, you can just come as and when needed. So next study is the single cell atlas of lineage states, tumor microenvironment in the gastric cancer. So previously I alluded on the molecular classification of gastric cancer. So this classification given by the TCGA and the ACRG, they can help to classify the patient on a molecular profile, but at the level of the treatment, it has not translated so well. So there is a viewpoint that not only the patients show inter-patient heterogeneity, the gastric cancer itself within the same patient can show heterogeneity. That is called the intra-patient heterogeneity. So to address this, single cell RNA sequencing was done. It means that the cells from the gastric cancer were profiled, single cells were profiled. So we took around 30 gastric cancers of different stages and different subtypes, and we did the sequencing, and we profiled more than 200,000 cells and generated a comprehensive single cell landscape of gastric cancer encompassing both the inter and intratumoral heterogeneity. So I will just summarize some of the important results of this study. So first of all, when we compared the diffuse versus intestinal subtypes, we found that the diffuse subtype showed a higher percentage of plasma cells, and we validated this by doing the IHC for this marker IRF4, which is a specific plasma cell marker. And here, as you can see, this is the intestinal tumor. Here you can see very few IRF positive cells, while this is a diffuse cancer where you can see very strong IRF expression. Next, we did the stage-wise accrual of the cancer-associated fibroblast. So as you all know that the tumor microenvironment plays a very strong role in the migration and metastasis of the tumor. So we decided to study this tumor microenvironment, and we found that the tumor microenvironment shows not only a single type of cluster but different clusters. So we termed them as tumor fibroblast cluster STF1 to 3. And as you can see in this box plot, as the stage of the tumor increased, the fibroblast cluster also increased. Next, there are certain cancer-associated fibroblast markers like the FAP and ACTA2, which are upregulated in the gastric cancer. So using the single cell data, we tried to see the upregulation of these markers, and it was seen that in all the tumor fibroblast clusters, we can see this upregulation. Next, because the TGF-beta pathway also plays a very important role in the tumor microenvironment, so the 9 genes which are downstream of the TGF-beta pathway, we tried to study their expression in the fibroblast group, and we found that inhibin A was upregulated in STF2 and 3. And we further plotted the Kaplan-Meier curve to see what is the role of this gene. And we found that patients who had high inhibin A expression, they had an overall poor prognosis and a poor overall survival as compared to the inhibin low expression. So then again, we did the digital spatial profiling. And here, as you can see, the green color is the tumor area. It is marked by the pan-cytokeratin marker. The blue is the smooth muscle actin positive fibroblast area. And the reddish areas in between are the marker marked by the CD45, or which is a lymphoid marker. So within the fibroblast areas, we tried to see the expression of inhibin A and FAP, and we found that both the genes were upregulated. So the results of this study showed that plasma cell proportions has increased in diffuse type of tumors as compared to the intestinal types. Then we could see stage-wise increase in the cancer-associated fibroblast subpopulation. which was marked by again a higher expression of inhibin A and FAP. Inhibin A is a predictor of poor clinical prognosis. And this study helped us to provide insight into the molecular landscape of gastric cancer. And we took a step ahead for deciphering the heterogeneity seen in the gastric cancer. So this is the last part of my presentation. And here I would just briefly touch on the latest molecular tests that are done for the management of the gastric cancer. So in 2010, when trastuzumab, that is an antagonist of the human epidermal growth factor receptor 2, was identified, it kind of changed the management strategies of gastric cancer. So this a very large trial, TOGA trial, it showed a significant benefit in the overall survival in a subset of HER2 positive patients when they were treated with cisplatin fluoropenemab arm, and especially those who had high HER2 expression. So they recommended a repeat assessment of HER2 status for those patients who have unresectable, metastatic, or recurrent gastric cancer when the initial HER2 results were borderline or low. Then again, latest research have also shown that HER2 testing can be done on the blood, because at the level of tissue, there is a lot of heterogeneity. So, but then there is not enough validation data that whether they can be recommended and for routine use. Then apart from the HER2 IHC, the level of HER2 gene amplification can also help us to predict response and overall survival. And finally, after so much of trastuzumab usage, there are cases of resistance coming up, and research is going on to find out how to subvert this resistance to trastuzumab. Next is the microsatellite instability group. So as I alluded in my previous slide, so this group is most common in females, and these show a very high frequency of gene mutation and are very good candidates for the immune checkpoint inhibitors. So one of the MAGIC trial had shown that mismatch repair deficiency could be used as a predictive marker, and it is associated with a positive prognostic effect in patients who are treated with surgery but without chemotherapy, and with a negative prognostic effect in patients treated with perioperative chemotherapy. And in the routine usage, IHC staining has to be performed for all the 4 markers. And here again, I have shown the Kaplan-Meier curve showing that the MSI tumors had a better prognosis as compared to the MSS stable tumor group. Lastly, we come to the PDL1, and it is an immune inhibitory molecule that decreases the stimulation of T cells, leading to the growth of the tumors. So MSI-induced subtypes of gastric cancer, as well as the EBV positive group, have shown to have augmented expression of PDL1 and are potential candidates for the immune checkpoint therapy with PD1 and PDL1 inhibitors. Then IHC should preferentially be used for screening patients potentially suitable for this therapy. And here again in this graph, you can see that the EBV positive and the MSI tumors have a better response to immune checkpoint inhibitors as compared to the genome stable and the chromosome instability group. So lastly, the FDA in 2021 has approved pembrolizumab plus trastuzumab plus chemotherapy for locally advanced unresectable or metastatic HER2 positive gastric cancer, and nivolumab plus chemotherapy for metastatic gastric cancer. And this slide kind of gives a path ahead that what are the emerging targets in the gastric cancer. So here you can see these 4 groups, which the TCGA has used as a molecular classification. So the immune checkpoint inhibitors are mostly relevant for EBV positive.
It's not a normal 2 lakhs
for the genome stable and the SIN. They are still
2 lakhs on the
druggable targets. And then there are other targets that can be for which ongoing research is going on. And for example, the ARID1A, then other ROA mutated tumors. So yeah. So lastly, I would acknowledge my group back in Singapore who has been there. And yeah, I'm open for questions.
Thank you, Supriya Madam, for sharing your insights on gastric cancer. I'm sure most of our delegates and postgraduates, including me, have learned a lot of points from you, especially the molecular classification, the Cancer Atlas group, and then the Asian Cancer Research Group, and the rare types like gastroblastoma, terms we're not very familiar with. And then the genetic syndromes also that you have told us about, the Korea pathway, and your publications are really commendable. I hope you will share some of your information, the publications, so that we can go through your publications. And especially the importance of metaplasia that you have told us. We don't give that much of importance to metaplasia, but your studies show that metaplasia is very, very important. So I think that is what we should take into consideration. And I just have one small question. It is open for questions, but before I ask others, I felt, see, there's so much of importance given to tumor infiltrating lymphocytes. Why is it that you chose plasma cells? Here, plasma cells were given more importance, isn't it? Why not lymphocytes? And why plasma cells?
So actually, we did the analysis for all the cells. We did even for the tumor infiltrating lymphocyte, but there was no difference between the diffuse and the intestinal based on the tumor infiltrating lymphocytes. So the tumor infiltrating lymphocytes are a standalone marker for tumor infiltration and for the immune checkpoint therapy. But for between the intestinal and the diffuse type, the plasma cells was seen as a higher level as compared to the tumor infiltrating lymphocytes. Yeah.
It's open for discussion. Any questions, please? Somebody has a question. Can you give the mic there, please? Mic is available. You can come down. Oh, there's a mic.
Yes, Madam, it was an excellent presentation. I have a few doubts. I just wanted to know whether this PDL1, E-cadherin, MSI, and HER2 can be like routinely used to screen gastric cancer patient, or is there a subcategory where we have to focus?
Okay. So back in Singapore, we are not doing the assessment for all these markers routinely. But if a patient asks for any, like those patients who can afford, because I am sure you must be knowing that these tests are quite expensive. So if the patient is asking for personalized treatment, and then we would go ahead with the MMR group and for the PD1, PDL1. So that is done when the patient is asking. But routinely we are not doing, or if the surgeon comes back to us that they want further analysis for the subgroups, then we would do that. But routinely it is not done.
What about polyposis carcinomas? Do you do it HER2 in that, HER2 and MSI panel in that, or you?
No, we are not doing the HER2 and MSI in the poorly cohesive carcinoma.
Thank you.
Just in continuation to what Madam has asked regarding the tumor infiltrating lymphocytes, Madam, has it got any prognostic significance like how it is in breast and melanomas?
Okay, so again for the PD1 and PDL1, there are trials, and then there is some evidence that they do help in the overall survival. But I think more studies are needed and more different cohorts of patients are needed, because mostly the results are from America or from the UK. So from the Asia, we have one of the clinical trial, we have an ongoing trial for Asian patients. So the results are yet to come out.
Thank you, ma'am.
Any more questions? Madam, any role for KRAS and BRAF?
Okay, so the KRAS and the BRAF are mostly done in the colorectal, not routinely for the gastric. Yeah, not much role. Yeah.
Thank you, madam.
Now I invite Dr. Aparna Chinnam ma'am and Dr. Renuka ma'am to honor our speaker as a token of gratitude for her timely contribution. Thank you, ma'am. I request Dr. Jyoti Verma ma'am, Co-Organizing Secretary and Assistant Professor, Department of Pathology, AIMS Mangalagiri, to felicitate the chairpersons. Thank you, ma'am. The secret of getting ahead is getting started. Now let's begin our inaugural ceremony. Due to unforeseen changes in the schedule of Director AIMS Mangalagiri, Professor Dr. Mukesh Tripathi sir is unable to join us today, but his constant support and encouragement are always with us. It's a great privilege to welcome our Honorable Dean Academics, Professor Dr. Srimanta Kumar Das sir, HOD of Forensic Medicine Department, AIMS Mangalagiri, to occupy his honorable chair on the stage. Welcome you, sir. My privilege to invite Dean Examinations, Professor Dr. Desu Ramohan sir, Head of Hospital Administration Department, AIMS Mangalagiri, onto the stage. Welcome, sir. Next, we look forward to the presence of our MS Dr. Vinit Thomas Abraham sir, Additional Professor, Department of Orthopedics, AIMS Mangalagiri, to grace the stage. Welcome, sir.
And I'm delighted to tell you that this conference will end up with various prizes, and all the candidates will be rendered with certificates for being the linchpin of this conference. I'm sure this conference will genuinely exude a diverse spirit and will be an immense success and boon for all the participants and speakers. The person who acts as a pillar of support and strength with clear
Yes.
vision and passion, entwined with novelty in all the activities of the college is our director, sir. Due to some unavoidable reason, sir could not join with us today. Our Dean Academic, sir, who is the best supporter of all the challenging ventures taken by our institute. A cordial welcome to sir. I cordially welcome our Dean Examination, sir. Thank him for all the administrative help. Feel happy in welcoming MS, sir. I thank him for resolving any queries, for guiding for any valuable feedback. FA, sir, thanks him for guiding us throughout our journey, help us in understand the budget policies and making the budget proceeding in smooth way. I welcome our DDA, sir, for gracing the occasion. I thank him for his guidance and helping throughout our journey. With equal pleasure, I would like to welcome Secretary IAPM AP Chapter, Maruti ma'am on the dais. And APMC Observer ma'am for joining us and gracing the occasion. I acknowledge their timely support and guidance rendered by them. With immense admiration, I offer the most affable welcome to all the delegate and student for their valuable presence in the conference, and we are all grateful that you have taken time from your busy schedule to be the part of academic feast. With that, I wish you all a great day and hope you have a great learning experience at AIMS Mangalgiri. Now I request Honorable Professor Dr. Shriman Kumar Das, Dean Academic Sir, to deliver a keynote address to the delegates. Yes, sir. Okay. Okay. Now we can proceed for the lamp lightening.
Better to illuminate than to merely shine. Light is the symbol of knowledge, which attribute to the enlightenment and also concern a new beginning. To give the new beginning, I request all the dignitaries on the dais to light the lamp for igniting a spark to an auspicious beginning.
महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि महागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिम् महादेवसुतं
Now I request our Honorable Professor Dr. Srimanta Kumar Das sir to deliver the keynote address.
A very good morning to all of you. Welcome to AIMS Mangalgiri. I, on behalf of the family of AIMS Mangalgiri, welcome one and all to this auspicious day that pathology department is organizing a wonderful conference, CME or workshop, whatever you term it. Our respected President, Professor T.S. Ravi Kumar sir, Honorable Director and CEO, Professor Mukesh Tripathi sir. Of course, they are not here because of their busy schedule. They are out of station. Anyhow, the show must run. I'm really happy to say that though we are in a very beginning phase of our journey as AIMS, All India Institute of Medical Sciences, the name itself carries a great value, but we are quite happy, proud to say that with a short span of time, hardly of 5 years, we are capable to organize a conference of this level. I congratulate the Department of Pathology, the head, the team, all the volunteers to come up and to organize this workshop in such a grand manner. Of course, I need not tell what is pathology because the learned gathering here, they're well learned and much better known than me. I belong to forensic medicine. We do look upon to the Department of Pathology as and when it is required.
ને બ્લેન્ક મૂક્યું છે કોઈની સાઈન કોનું રન કર્યું છે કોની સ્લાઇડ માટે કઈ નથી લખવાનું કોને કર્યું છે બતાવો બાર ને સાઈન લ્યો ફટાફટ બતાવી જાઓ નાઇટ નો અર્ધો નતો ને બતાવો ને બતાવીએ ના તો નાઇટ વાળાને તો બતાવવાનું જ હોય ને સ્ટાફને બતાવો એને ડન કરી જો એના કેટલા પ્લેટલેટ્સ છે બતાવો એને કે આમાં કેમ સાઈન નથી લે એની સાઈન બરાબર
हाँ जी, आप वो कल कह रहे थे ना कि मैं कुछ बो दूंगी, आपको बोना आता है ना? तो अपने काम करते हैं। मैंने देखो यहाँ पर ना ये रखे हैं, मेथी, पालक और धनिया। देखो टेबल पे रखा है ना, या ना आंटी इसी टेबल पे। हाँ, यही जो टेबल सामने दिख रही है ना,
হ্যালো,
বলছি ম্যাম ওই সুইগির ছেলেটা না আপনাকে কল করছে, এবার আপনার বোধহয় কোনো নেটওয়ার্ক লাগছে না।
আচ্ছা আচ্ছা, ওকে পৌঁছে গেছে?
হ্যাঁ আপনার বাড়ির কাছেই আছে।
আচ্ছা, আমি কল করে নিচ্ছি। আচ্ছা,
তো আমি আপনাকে ওর নাম্বারটা পাঠিয়ে দিচ্ছি।
হ্যাঁ পাঠিয়ে দাও তো। चल दरवाजा बंद कर देना। थोड़ा अंदर चल। कंटेंट सुने तुम भी सुनो। हम भी सुने हम लोग बता दो।
प्लीज हो जाओ, प्लीज हो जाओ।
Hey, check, check.
Nine seven zero 945.
अभी तो बैकग्राउंड डालना है कंटेंट बैकग्राउंड
एक काम करके
लाइव बोलेगा जीरो दबा राइट साइड में जीरो आ
The next session is on the topic diagnostic updates and molecular advances in thyroid neoplasms. For this session, I'm profusely elated to take an opportunity to introduce our next chairperson, Dr. Amit Kumar Chauhan, sir, Professor, Department of Pathology and Lab Medicine, AIIMS, Raipur. Sir has more than 70 publications in various national and international journals. Sir authored 2 book chapters and acted as reviewer for 26 journals. His area of interest are endocrine pathology, neuro-oncopathology, cytopathology, and renal pathology. Welcome, sir.
Hello? Hello? Ray Pumping. Location. Chanipuri. Sai Baba College. Sai Baba College. I think so. Okay. Okay.
Next, I would like to invite our next chairperson, Dr. Uma Rani ma'am, Professor of Pathology Department, Alluri Sitharama Raju Academy of Medical Sciences, Andhra Pradesh. Ma'am has done numerous publications in various national and international journals. Ma'am has interest over areas such as surgical pathology and hematopathology. We welcome you, ma'am. Now I request our chairpersons to take over the session and introduce the speaker of the event.
Dr. Pampa ma'am has done her MD pathology from Jipmer Institute, Puducherry. She is awarded with DJ Gold Medal, DJ.
परवल आलू में प्याज ना डालिए एकदम फीका फीका क्या देने बोली तुमको ओ अरे 2000 ठीक से देख लीजिएगा
और एक चश्मा लगा के देखें क्या और एक तो चश्मा दोनों का आपको तो है एक चश्मा मेरे बताइए चलिए 2000 रुपये से बता हम ठीक है अच्छा अब हमको देखना होगा अगर आपका आपका मीटिंग होना है कल ना कल काम कल भी रखिए एक मंगल बात नहीं ना अच्छा आप तो हम लोग का अच्छा तुम्हारी रोटी उसमें है कहाँ है टेबल पर हम निकाल दिया जो गर्म है ठंडा हो जाए तो नहीं मछली छोड़ दोगी खाएंगे हम दाल मछली छोड़ हाँ
Arey, what happened that match? Sri Lanka, India.
Again,
India is cheated. What is this?
Pakistan is it?
Pakistan India match कब है?
हो गया खत्म
हो गया.
हो गया इंडिया जीत गई ना
अच्छा.
just
This is again. No, who's there next to India?
इंडिया के साथ साउथ अफ्रीका का मैच संडे कल ही है
What time?
tomorrow at 2 o'clock.
I'll go in the morning, like 11 o'clock in the evening. We'll come here and watch. So it's from 1 will be like 3 hours. 1 hour coming back. And you really wanted to go. It's only for 3 days. Thursday, Friday, Saturday, Sunday.
Movie.
It's like a concert movie. Like Taylor Swift का concert हुआ ना, उसका they made a movie.
Oh.
And they put it in India because India में नहीं है ना.
अच्छा.
The rest who are doing with Aditi Anusha went for the concert like.
कब?
2 महीने पहले.
जी अभी भी.
न्यूयॉर्क का नहीं मैनचेस्टर भाई को भी. न्यूयॉर्क में the went.
Let the fan put.
रोटी के डब्बे में
Even with this invasive form of encapsulated variant of papillary thyroid carcinoma. And papillary thyroid cancer as such is associated with BRAF gene mutation. You have this P10 and PI3K associated with follicular carcinoma, poorly differentiated thyroid carcinoma, and anaplastic carcinoma. And follicular carcinoma is again associated with translocation of PAX8 and PPA-RG. So this I'm showing, especially for the postgraduate students, that this is a very important diagram. It is there in your textbook, and you can always go through this and see. So let us go to the next slide. So in the main diagnostic group of 2022 WHO classification, you can see that, as I've told you earlier, they've been divided separately into benign lesions, low-risk neoplasm, and malignant thyroid neoplasm. So the benign lesions here, they've been divided into thyroid follicular nodular disease, follicular thyroid adenoma with papillary architecture. This is added, okay? And then oncocytic adenoma has been given a very special place. Next, we have the low-risk neoplasm. And in the low-risk neoplasm, we have the NIFT-P, we have the tumor of uncertain malignant potential, and hyalinizing trabecular thyroid tumor. If you remember, this HTT in 2017 was given a separate entity. Now it is combined with low-risk neoplasm. And under malignant thyroid neoplasm, you have follicular thyroid cancer, then invasive encapsulated follicular variant of papillary thyroid carcinoma is not included with papillary thyroid carcinoma. So this has got a special place here in malignant thyroid neoplasm. We will see why. Then you have oncocytic carcinoma of the thyroid, papillary thyroid carcinoma with the different subtypes. You have the differentiated high-grade thyroid carcinoma. You have the poorly differentiated thyroid carcinoma and anaplastic thyroid carcinoma. So this differentiated high-grade thyroid carcinoma is also newly introduced in the 2022 45th edition WHO. So what are the new categories of benign follicular cell lesions? And why are they included in the WHO 5th edition? So when you look at this picture, you can see that there are slices, of the thyroid gland, and you can see that multiple nodules are here. Some cystic spaces are there, okay? And multiple nodules are here. So let us look at the microscopic picture. So what do you see here? You see here, these are different pictures here. You have got these follicles. They are macro follicles distended with colloid. There are some micro follicles very close together like this. Some appear to be encapsulated, partially capsulated, and you have somewhere calcification here. Furthermore, you can have appearance like this, where there's a mixture of the follicles here, and somewhere it looks as if it is a nodule here. So what do we call this type of lesion? What do we call this type of lesion? For the postgraduates who are here, what will you call if you see this microscopically? What is it called when you see these lesions like this, multiple nodules, follicles, capsulated, encapsulated, somewhere calcification, fibrosis, what will you call? Or what was it called earlier? So there's no response. So
मुझे आपका स्टील का जो प्लेट बोले तो मिला कि नहीं आपका प्लेट? मेरा प्लेट है तो फिर ऊपर प्लेट सब जगह टपला भरा गया है। कौन सी प्लेट? वो जो कल हमको बोले मेरा नहीं है, मेरा बड़ा प्लेट दे मिल रहा है। हाँ तो वो तो बिल्किस की दे दी ना, एक दही ढका हुआ था वो हम नहीं गिना था। तो मैंने आपका हो ठीक है। अब जाके नसीला को बोला कि प्लेट ले जाके बड़ा भागे गरम बर्तन पूछिए।
अय्यो
tumor of uncertain malignant potential. They lack the papillary thyroid carcinoma-like nuclear feature, whereas the well-differentiated, they are called well-differentiated because they have got some features or less pronounced nuclear features of PTC. And what is the problem here? The problem here is invasion. So even after giving multiple sections and studying multiple sections, you find that, and if they have given bits from different, properly covering the capsule, the invasion is uncertain. So it is very difficult for invasion. And so these tumors have been given the name of uncertain malignant potential. And so if you see the papillary thyroid carcinoma nuclear score, which is divided into 3 categories, you have here the nuclear score of 0 to 1 only. And here it is 2 to 3. Okay. So because of this is called well differentiated, and this is called, it is just follicular tumor of uncertain malignant potential. So what is the difference between uncertain malignant potential tumor versus adenoma or the NIFT-P? Let us see. So the presence of questionable capsular or vascular invasion after thorough sampling and exhaustive examination is when we should call a tumor as the uncertain tumor of uncertain malignant potential. We should look at the nuclear features and then decide whether it is follicular or it is differentiated. Okay. So just again, this is for the PGs. What do you think is the invasion here? You people are not talking. Where is the invasion here? Okay, let us look at this. We see that this is invasion. If you can recall what I had shown you earlier, this is invasion because this is cross the capsule. This is also invasion. The capsule has gone outside like this, and you have the tumor also pushing through it. This is invasion. It is outside in the extrathyroidal, in the extracapsular tissue. This is again mushrooming, which is invasion, and all these are not yet. So this is the problem that many people face when it comes to questionable invasion. So very quickly, there are so many tumors actually that you see. You have this follicular adenoma, you have this uncertain malignant potential tumor, you have the NIFT-P. Okay, let us look at these actually 4. When you see that all of them do not have a high-grade morphology, they do not have a high-grade morphology. All of them have got RAS mutation. Okay, so, but then why are we calling this as UMP? As I've already told you, that questionable capsular invasion is the one that actually makes them separate from these other entities. So let us look at this. This is another tumor here. You can see the thyroid gland here, and this is the tumor here. And this, as you can see here, it's a trabecular pattern. Okay, lot of hyaline-like material are inside this, and this have got certain PTC-like nuclear features here. This is a peculiar staining with MIB1. Okay, Ki67, the clone is MIB1, and at room temperature, you get this membrane staining only. Okay, so can you tell me what it is? It's not very common. So this is a hyalinizing trabecular tumor. So this hyalinizing trabecular tumor, it is a well-demarcated nodule with PTC-like nuclear changes, arranged in trabecular architecture with hyaline material. Very important here that is not associated with a BRAF or a RAS mutation. It's okay. And here, what is very important is this GLIS gene rearrangement. So once this GLIS gene rearrangement is there, you can see PAX8 GLIS3 and PAX8 GLIS1. This rearrangement actually makes, or when this rearrangement occurs, they cause the increase of this matrix material, release of matrix material and collagen-like material. And these, which I've told you earlier, this hyaline-like material, they are diastase resistance, PS positive, and they are immunoreactive for collagen. So why I'm stressing here is that the treatment for this is thyroid lobectomy, and they are also positive if you do IHC marker, TTF1, thyroglobulin, and PAX8 positive. So no patient with GLIS rearranged thyroid neoplasm developed tumor recurrence or any other adverse events. So we should recognize this entity. It is not very common. And even the malignant counterpart of this does not, no patient have been seen with this GLIS rearrangement, okay? So, so it does not follow, I mean, any adverse event. Even with this, it does not follow any adverse event. So we will, before that, let us just look, okay? Here, NIFT-P, I have said that the molecular testing on preoperative cytology specimen is not possible because NIFT-P shares molecular profile with tumors of the uncertain malignant potential, follicular adenoma and carcinoma, and invasive encapsulated variant of the follicular variant of papillary thyroid carcinoma. So you cannot do any molecular testing on preoperative cytology specimen to give a diagnosis of NIFT-P. Then for the treatment, thyroid lobectomy for both NIFT-P and HTT, and clinical and radiological surveillance is important. They do not require radioiodine therapy. Okay. UMP, close follow-up is important. I told you that, and biological potential is not certain for these tumors of uncertain malignant potential. We do not know. After many years, these patients may present with metastasis and all that. So the close follow-up is very, very important for people with uncertain malignant potential. Next, we come to the malignant neoplasm. So before we go, you should remember these things. The morphological features of differentiated thyroid carcinomas, okay, correlate with, if it is BRAF-like, these tumors will be infiltrative tumor with a lot of or florid nuclear atypia, whereas the RAS-like tumor, they've got an expansile pattern, subtle and less florid atypia. This you should remember about well-differentiated thyroid carcinomas. So the question now is, the follicular variant of PTC is separated from other subtypes, PTC subtypes Y. Do you remember what I told you in the beginning? Which type of follicular variant of PTC is separated? There are two types of follicular variant of PTC. One is the encapsulated. Yes. So you are not saying, okay, we'll go on. Okay. So let us see why there is so much confusion. Okay. So earlier we know that the classification of thyroid carcinoma was based only on architecture, either papillary and follicular pattern. And then what happened is that when the nuclear feature came into consideration, okay, instead of purely just architecture, then it led to the term of follicular variant of papillary thyroid carcinoma. And again, the new system, especially now this 2022 classification, is based on molecular evidence. So follicular thyroid carcinoma, as I've already told you, is mostly RAS driven. They are invasive tumor lacking nuclear cytology of PTC. And the subtypes of both follicular variant of papillary thyroid carcinoma and follicular thyroid carcinoma, you can subtype them based on this, okay, whether it is minimally invasive, that is only capsular invasion, or there is angio invasion. Even a single focus, actually, even a single focus is actually important. And if it is widely invasive, then goes through and through, we should do complete thyroidectomy, and adjuvant therapy is given for these patients, okay? So as I've asked you before, this follicular variant of papillary thyroid carcinoma, infiltrative variant and encapsulated variant is there. Now, this encapsulated invasive variant, this encapsulated variant is the one that is described separately. Okay, it does not come under PTC in the malignant thyroid tumors now. Whereas the infiltrative one comes under the follicular variant of papillary thyroid carcinoma. Is this clear in the new classification now? Why? Because this encapsulated variant, it resembles follicular thyroid carcinoma, less florid nuclear atypia, capsule or vascular invasion is there, and they are RAS-like. Okay. Whereas the infiltrative form, they've got nuclear features of PTC, but they do not have, they lack papillae. That's why they are called follicular variant. florid nucleatypia exhibit perineural and lymphatic invasion. They are BRAF-like tumors. So it is very important to see the type, the form, the degree of invasion. All these are essential for dynamic risk stratification and clinical management of the patient. So this is, again, as I've told you, it's just a picture taken from my articles. So you can see this is an infiltrative follicular PTC, very ill-defined infiltrative margin here. These tumors have well-differentiated PTC nuclear features. This is an invasive encapsulated follicular variant of PTC. This capsule appears that it is invasive here, okay? So this is the one that does not come under PTC. It is the one that is given separately. And then the nuclear features here are less developed. The nuclei are rounder and more uniform. But looking at the pictures, actually somewhere I'm not even seeing the proper PTC features, okay? Anyway, so next we come to this. So I'm sure all of you are familiar with this particular picture, right? What is the histopathology? I mean, what diagnosis would you like to give when you see this feature? Yes. So I can hear papillary thyroid carcinoma. So what are the diagnostic criteria of papillary thyroid carcinoma? So now the WHO 5th edition has also included either papillary growth or invasion along with the nuclear feature, and they were added to the definition of PTC. Okay, in this new classification, the variance term is replaced by subtype. So we don't call them anymore as variants, but we call them a subtype because variants, they actually mean genetic variant, whereas the subtype is to comply with all the other WHO tumors, okay? And PTC microcarcinoma, remember this, it should not be considered as a distinct subtype now, according to this latest classification, because these PTC microcarcinoma, though, they have excellent prognosis, yet they can display aggressive features. Regional and distant metastases have been seen. Rare cases in many studies, they have been found to be fatal. They may progress to high-grade carcinoma. So the term incidental, occult, all these terms should not be used because the term may be misleading for the clinicians. So they say now that we should histologically subtype these tumors. So if you see this tiny microcarcinoma, you see the in tall cell, then we call it, so we should subtype it histologically. They should be told and not given a separate this one, because we are giving a wrong impression to the clinicians that they are occult, they are, nothing. So that is very important. So the classical PTC, we see that they have well-formed papillae lined by tumor cells with specific nuclear feature, lymphatic permeation, and vascular invasion is less common. Then these are I've put this again for the PGs that you'll remember because I cannot, tell everything now. So you should just know the frequently encountered, you have point mutation or gene rearrangements involving the MAPK pathway. BRAF V600 is the common molecular alteration that you see. Then the TERT mutation is common, seen in 10%, and it carries a very bad prognosis if there is TERT mutation. Then red gene rearrangements may be seen, we see rather in classic PTC and other subtypes. Strong association with radiation-induced PTC and PTC that is seen in children. Less common, you see gene fusion in NTRK and other genes, copy number variations, alterations in gene expression, and altered microRNA expression. So all these you can see. So subtypes of PTC, do they even matter? Yes, they do matter. And so let us look. BRAF-driven PTC they've got a worse prognosis, worse patient outcome compared to RAS-driven PTC, and overrepresentation of BRAF driver mutations in specific PTC subtypes and oncogenic BRAF mutations are present in 50% to 60% of all PTCs. Then these mutations, this is specifically overrepresented in the subtypes, the tall cell, the columnar cell, and the Hopnell subtypes. These are aggressive. These tumors actually, they can just present as low-grade tumors. There may not be any metastasis, okay? But if you have this appearance and with BRAF, this BRAF mutation, okay, then these are highly aggressive tumors. Sub-centimeter PTCs should also be histologically subtype, as I've told you the reason. And these small subsets, they can be very aggressive, and the clinical course has been found to be similar to their large size counterparts. So no more PTC microcarcinoma as a separate subset. They should be histologically subtype. So this is a tall cell type of PTC. You see the length is 3 times the width. Then this is a columnar cell variant. This is a hobnail variant. Again, not going into the details of the description, etc. So these are the subtypes of PTC which we should remember, which have got a bad prognosis. The encapsulated variant here, okay? So I've purposefully removed here. Initially, I had put it as subtype, but I've removed it because if you follow the latest WHO 22 or the 5th edition, then the encapsulated variant of follicular variant of papillary thyroid carcinoma, it does not fall under PTC, and it has got an excellent clinical prognosis, whereas the infiltrative type, the tall cell, columnar cell, and hobnail are aggressive. So other highlighted subtypes of PTC, we will not go into the detail. You have this diffuse sclerosing type, you have the solid trabecular PTC here. You should remember that these are associated with chronic lymphocytic thyroiditis. They've got an aggressive clinical course. This is a picture of a diffuse sclerosing PTC. A lot of samoma bodies you see. This is the lymphocytic thyroiditis part. Then you have the solid PTC, solid growth, solid and trabecular pattern growth. So unknown impact on a prognosis, you have the oncocytic classic PTC, Wharton-like PTC, clear cell subtype PTC, less common PTC subtypes, spindle cell PTC, PTC with fibromatosis, fasciitis like desmoid type PTC. So oncocytic thyroid carcinomas, they are invasive malignant follicular cell neoplasm. The nuclear features of PTC and high-grade features are absent, okay? So ultrasound cannot distinguish oncocytic adenoma versus carcinoma. So we have to diagnose it only in histopathology. So this is a picture of a oncocytic carcinoma of the thyroid. What we see here is that there is capsular invasion here, and these cells have abundant granular cytoplasm and prominent nucleoli. Now, this is very important. That's why I'm rushing. So follicular derived carcinomas, high grade. So now they've introduced this new term of differentiated high-grade thyroid carcinoma. Poorly differentiated was already there, and according to the Turin, we will see here, criteria, the poorly differentiated thyroid carcinoma was already there. Okay, so what is this differentiated high-grade thyroid carcinoma? In differentiated high-grade thyroid carcinoma, they can be papillary, follicular, solid, but these tumors have got, along with them, increased mitosis and necrosis. So when there is mitosis and necrosis, mitosis of more than 5 per millimeter square, and tumor necrosis, then we call it as either it can be mitotic count of more than 5 or tumor necrosis. Then we call it as the high grade. And for this poorly differentiated, it is still one of the following 3 features should be there: mitotic count, tumor necrosis, convoluted nuclei. No features of PTC here. No features of PTC. This has got a poorer prognosis compared to a poorly differentiated thyroid carcinoma. And in the recent WHO, they've used this millimeter square. They don't use high power field now because of the difference in the, the field size of different microscope, etc. So they have taken millimeter square now as criteria, and they don't use high power field as it was done earlier. So this is a poorly differentiated carcinoma. You can see here areas of necrosis here, and this is the tumor here. Then we have got here again, it's looking like papillary thyroid carcinoma. Necrosis is there here, which I can make out. And so this is a high-grade papillary thyroid carcinoma. So why it is important to recognize these? Because 50% of high-grade non-anaplastic thyroid carcinomas will not take up radioactive iodine. And there are new treatment modalities available, in particular systemic therapies, focusing on the particular molecular signatures of the tumor, which may be needed to treat these patients. So other than this, you can see this tumor here. It has got a squamoid appearance, and then you can have some spindle cells here. And so this is anaplastic carcinoma with prominent squamous differentiation. This is arising with in a tumor of PTC with Hopnell pattern. This is a spindle cell morphology of anaplastic carcinoma. This is again very, you can see very bizarre cells here, but again, it has got a squamoid morphology. So anaplastic carcinoma has got a very important, again, a change has occurred here. They are follicular cell derived thyroid carcinoma, and they harbor this BRAF mutation. Very important, which is included in this new WHO 5th edition, is that if we suspect anaplastic carcinoma, there should be rapid and prompt testing this for BRAF and mutation, because treatment is available. BRAF and you have this MEK inhibitors, which which is useful for this patient. Then squamous cell carcinoma, do we still call them as squamous cell carcinoma? Therefore, squamous cell carcinoma, the imposter. When squamous cell carcinoma, we see it in the thyroid gland. Either we can see it, they can with or without differentiated thyroid carcinoma component. This has been added to anaplastic carcinoma. So we now squamous cell carcinoma and the thyroid has been included under anaplastic carcinoma, because they also have the same mutation, and PAX8 and TTF1 is positive in 91% and 31% respectively. Morphologically, the pattern, okay, is similar and the prognosis is same. So now squamous cell carcinoma is included with of the thyroid is included with anaplastic carcinoma. Rarely there can be metastasis from somewhere into the thyroid, so that we can do this IHC to find out whether they are from the thyroid or no. So prognostically relevant classification of follicular cell derived carcinoma of the thyroid. So we can see PTC, then follicular thyroid carcinoma, then oncocytic carcinoma. They've got good prognosis when they're papillae follicles, and the grade is usually low, excellent prognosis. Differentiated high-grade carcinoma, as I've told you, papillary follicular oncocytic high grade, and they have got an intermediate risk. And you have this poorly differentiated thyroid carcinoma and anaplastic carcinoma, where the prognosis is very poor. Actually, in many articles, they've said that the differentiated high-grade thyroid carcinoma has got a poorer prognosis compared to the poorly differentiated thyroid carcinoma. So this is a very, I don't know whether I'll have time, but I just want to show you like a summary. So now that we are talking about follicular cell-derived neoplasm, first of all, we look at the nuclei, whether they have got PTC-like nuclei. If yes, then whether it is encapsulated, whether it is circumscribed, and along with it, if there is a follicular pattern, then yes. If it is yes, then look for invasion. If it is a questionable invasion, then it is a uncertain malignant potential tumor. If there is no invasion, then it is a NIFT-P. And if there is invasion, then it is infiltrative encapsulated variant of follicular thyroid carcinoma. Okay. And now we come here to the nuclear score. If it is 2 to 3, then we look here. If there is invasion, then if it is yes, then it is malignant. Then you look for the differentiation. Yes, it's follicle or papillae. Then you do the mitosis, the count, and or whether necrosis is there, then it will go to the differentiated high-grade thyroid carcinoma. And then again, mitosis count more than 5 per this one also. If you look from here, down you come here, then it comes under this differentiated high-grade thyroid carcinoma. And here, if it is a solid or trabecular insular growth pattern, mitotic count of more than 3 per 2 millimeters square, and necrosis or convoluted nuclei, then it is a poorly differentiated thyroid carcinoma. Differentiation we cannot see, then it is anaplastic thyroid carcinoma. Okay, so this is in a nutshell about this one, and I think I won't go into the detail much. Time is also up, so we'll just see. These are the molecular markers of adverse biology in follicular cell-derived thyroid carcinoma. You have the BRAF mutation with the TART, And then you have this PLE, KSH1P. All these are associated with adverse prognosis. Similarly, here you have follicular thyroid carcinoma, where you have the TERT. And then you have TP53 mutation, which accounts for poor prognosis. For oncocytic carcinoma, similarly, TRT and chromosome 5 and 7 duplication associated with poor carcinoma. Similarly, you have this differentiated high-grade thyroid carcinoma and poorly differentiated, where again TRT plays a very important role as a molecular marker of adverse. So we will not go into this detail anymore. We have done. So I would like to conclude. Actually, there was another slide about cribriform molecular variant of, it was earlier. So we can see that IHC can be performed on these thyroid sections. You can perform IHC. Medullary carcinoma is left, just a line about medullary carcinoma. The International Medullary Thyroid Carcinoma Grading Scheme has divided medullary carcinoma into high grade and low grade. And in the high grade, at least 1/3 of the following features should be there: tumor necrosis, mitotic count of more than 5 per 2 millimeter square, or Ki67 proliferation index of more than 5%. So this grading system has no correlation with the RET mutation study, and high-grade tumors have got a poor prognosis. So not going into all this, just this I want to tell you. This cribriform modular thyroid carcinoma was earlier a subtype of papillary carcinoma, but now it is given a separate entity as tumor of uncertain histogenesis. They don't know. So there is a genetic alteration in the WNT bar beta catenin pathway. And IHC, when you do, there is diffuse positivity for beta catenin. Okay. And so we will not go into the details. So just my conclusion. So for pathologists, advances in the molecular pathogenesis of thyroid tumors have improved our understanding of tumor origin and evolution and impacted their diagnostic criteria. Thyroid tumors are now classified based on the tumor cell of origin and molecular profile. Thorough understanding of management-centric histological features, low-grade versus high-grade features, immunohistochemical and molecular characterization are very important now. The concept of low-risk neoplasm and histology-based grading system help guide personalized therapeutic decision for patients at different levels of risk. And pathologists play a very important role as part of the multidisciplinary term in the era of precision medicine. So we should be there in the meetings which are being held and know what exactly is being done. For the clinicians, the introduction of the two-tiered grading system, distinction of high-grade cancers from well-differentiated follicular thyroid carcinomas and medullary thyroid carcinomas. Then we have said that this exhibit more advanced histopathological stages and lower radioactive iodine avidity. The overall prognosis is similar for the differentiated high-grade carcinoma, is similar to the poorly differentiated thyroid carcinoma. And high-grade medullary thyroid carcinoma have got worse prognosis than low-grade thyroid medullary thyroid carcinoma. Differentiated high-grade thyroid carcinoma and high-grade medullary thyroid carcinoma require more intense treatment and should be more closely followed up for recurrence. So all of us, both the clinicians and the pathologists, need to be aware of the new terminologies and the classification schemes that would help us to further give a better diagnosis and better treatment for the patients. Thank you for your patient hearing. These are my references. You can go through the references later.
Excuse me, ma'am, I have a question actually.
That was a very excellent presentation, madam. Thank you for that. Wherein madam has very nicely described all the follicular pattern lesions described in the new WHO classification. And before I open it up for the house, ma'am, I have one question. Like you told that the BRAF-driven PTC has worse prognosis compared to the RAS-driven PTC in the follicular pattern lesions. So is it mandatory to do molecular testing before releasing the report? Is it a diagnostic criteria is like that?
So the most of the tumors that are they've got a papillary features. They're those that do not have a follicular. Follicular features are all RAS mutation. So the BRAF ones are mostly the papillary thyroid carcinoma, the conventional type and the subtype. So looking at the architecture itself, it is actually for us when we do not have, many places we do not have, there's no things available. IHC we may use in case of doubt. Otherwise not.
So it is not mandatory.
No, not mandatory unless you have a doubt in that. But as I've told you, the follicular pattern lesion mostly have got the RAS mutation, whereas the papillary pattern, which are the papillary tumors, basically, they are mostly the BRAF mutation.
So like in every PTC, like earlier it was, so the pattern is follicular, but we have to see the nuclear features.
Yes, sir.
So one of the problem with most of the pathologists we come across, although there are definite criteria to define the nuclear features, but it's still how much is enough to call it as nuclear
actually
features?
it's true. If we show the same slide to 10 pathologists, I'm sure that most of us will not agree about the changes in the nuclear features. So yes, a lot of, I think we'll have to really work up in this, because the nuclear features, however, they've described and whatever has been told, still it is very, very difficult. There will be, the agreement, the level of agreement will not be 100% in these cases. So yes, a lot of work to be done for thyroid cancer.
So in this case, can molecular will help?
We can try, sir. There is no, wherever availability is there, we can. But I mean, the diagnosis as such is first to be given in histopathology, and then to help
So
us in a yes.
It's ancillary.
Yes,
It's not.
It is an ancillary test. So yes, we'll have to work hard and then see.
Maybe we should suggest, madam, because
we can
sometimes it happens that very small lesion, it is later on presenting as
Yes, that's what I've
infiltrative.
told. Yes,
ma'am. Because clinician asks how to follow the patient, we advise them.
Yes.
They say, how long should we follow?
Yes.
So it is like, it is better we advise it.
Yes, definitely.
Yes, so now the session is open for any questions and queries.
Kirsi ma'am, may I go ahead with a question?
Actually, now they say that it is you take 10 high power field, 10 high power field. That is what is being described. If you take 10 high power field, that is
Hello,
millimeter square, which is
Field is 0.5 mm square.
so now they said because different this one, no, different that's
Objectives.
What, I have different objectives are there. So they say instead of 10 high power field, you take 2 millimeter square.
10 high power field as 2 millimeters.
2 millimeter square.
Okay.
So that is what we are saying now.
Ma'am, another question is, ma'am, when we report TBSRTC 3 and 4, do you recommend a cytology, or a molecular study on cytology at that aspirate itself? Because it falls into that follicular neoplasm category, it could be anything.
Now they have changed the criteria, no? The 2023, they are following this based on this new update of Bethesda. So what they will do, I have no idea, because I do more of histopathology.
Yes. Thank you.
Yes, thank you.
Madam, our microscopes, they are giving in horizontal and vertical, there is a scale is there.
Yes, sir.
I think we can use that measurement instead of the field.
Yeah,
You
sir,
said
that's
10
what-
field.
No. Now, yeah, I mean, that is the approximate given in articles, that you can use 10 high power field in the active area to say that it is 2 millimeters square.
Again, it changes with the type of microscope, not 10 high power field.
That, so that is the, if you can, if you can
Yeah.
throw some light.
I'm the IR candidate for the WHO. So I work with Dr. Cree, who has published this paper on mitosis. So you can go through that paper. So basically, in your CAP protocol, you have that chart of yours. So whatever your objective says 0.65, you have to see which is equivalent to your 3 fields. Like in, so 3 fields. So when they say like in this, they were saying 10 fields,
Yeah.
10 fields. So in GIST, in neuroendocrine, they are saying 2 millimeters square. Yeah, so you have to, according to that, you have to measure, and then you have to count double. Like if you want 15, you have to count 30 and then take an average. Don't count only 15. Okay.
So you
like
have
that.
to still look at your objective. You
Yes,
have to
yes.
still-
So yeah.
Okay,
So,
because yeah, that was not very
yeah.
like whatever articles we've gone through.
Because what is happening, ma'am, recently, why I'm asking, because the NCCN guideline is not being updated. So I got a call from my clinician
Okay.
regarding in the case of GIST.
Yes.
But the cap is updated, surprisingly.
Okay.
So in the cap it is given. So you can refer cap and you can refer the paper on mitosis by Dr. Ayn Cree. If you don't have the entire paper, you can just message me. I'll just follow
Thank
it.
you. Thank
Thank
you
you.
for throwing
Sorry,
light.
ma'am.
No, it's okay. Thank you so much.
Again, I have doubts. As per that calculation, the high power field and the multiplication of the, again, whatever we report, as you said, that is the number of the fields. And in the same slide, it will goes to some other pathologist and they will use some other microscope.
Yes.
And how they know you have given this report based on your microscope,
Yes.
unless you mention your microscope, the company or whatever it is. Again, there is a confusion. Can't we count based on my basic knowledge? That is a stage measuring, measurement
we used to-
scale.
yeah, like
That is
we
a
used to-
standard for every microscope. That's horizontal, vertical. You can, maybe it may change a little, maybe 0.1 millimeter, maybe. But approximately 1
suggest to, sir.
millimeter, I think.
We can make suggestion to sir.
Yeah, I'm just
Yes.
Whatever we can, they say you don't follow the guidelines. Whatever is best for us, we have to follow. If you are suggesting this, we can go back and do study on 100 cases,
Yeah.
and we can compare it and publish it. It is as
Yeah,
simple as
that
that.
is what, yeah.
So whatever, that is the take-home message for everybody. So whatever you are saying, don't just blindly follow what the CAP is saying, what the data sets are saying. We have to set ourselves. Like for KI also, in cases of breast, ma'am, they said that median we have to make and like that. So we have to create our median for the KI also. So it stands true for most of the reporting.
Madam, the question two. In the beginning, you said multinodular goiter terminology.
Yes.
When I was in Manipal, my teachers, I was taught by, whenever you see that the multiple nodules, in the maybe 30 years back, there is a literature, is there multiple follicular adenomas. Can we use that terminology instead of this one? If we are sure of these
No, sir, because
follicular adenoma, multiple.
so adenoma now is a neoplastic lesion, no? But in this term which they have used together is both for neoplastic and non-neoplastic thyroid follicular
But the
lesion.
clinician usually they say whether it's a neoplastic or non-neoplastic, they will ask.
Sir,
for-
but
for
we
the-
will, I mean, that's what, no? In
morphologically we give.
And then in order to, the confusion is always there. So that according to this thing is just to remove all this terminology. They've just put one, because if it's a follicular adenoma, then it is separately, follicular adenoma is there under the benign
If it is a
neoplasm.
solitary, if it is a solitary follicular adenoma, no doubt, no one is
sir.
having doubt.
Yes,
But if you are seeing multiple, so the question is whether it's a multinodular goiter, old terminology, or whether it is a thyroid follicular nodules. So once we give the new terminology, they ask whether it is a neoplastic or not, unless they go for the genetics or molecular studies.
Yes, sir.
So morphologically we can't say, and they won't agree. So in that case, what to do? Because every case we get multiple nodules,
Yes.
and usually we follow as literature says, Sacramento or the standard book says, the capsule thickness. Okay, so thin capsule we say, and complete capsule, and then
Sir,
the
but
other
here,
features.
like even in case of multiple nodules that you see, you are not actually sure whether all of them are encapsulated, whether all, and you have to cut so many sections to say that all are actually
Yeah, we have that limitation also,
encapsulated.
cutting so many serial sections at this
So
our
therefore, they have,
setup.
if
That
they
also very
suggest it,
problem.
maybe some change will come after, like there may be people who are having the same problem, and maybe updates may come later, which this term may become obsolete, and then we may follow some other term. But as of now, that is what they said, like that we follow this term for all these particular lesions that are both neoplastic and non-neoplastic, the benign lesions, I mean, under the benign category.
Okay, thank you, madam. One more. In the papillary carcinoma, regularly we get doubt. Sir already mentioned that questionable nuclear features. It varies from subject to subject. But the terminology, what do you call that is a follicular neoplasm with papillary-like features or
Yes.
questionable capsular invasion or
Yes.
questionable nuclear features.
Yes.
So we are using those terms.
Yes, sir.
Now to advising follow-up. Is it sufficient?
I think it is all right, sir.
Okay.
Perfect.
Or definitely we suggest a
Because
molecular.
follow-up is important, sir. No, survey centers and all, you don't, I mean, it's not available. We will not be able to, so regular follow-up is very
Clinician
important.
always have doubt on pathologist. They will send for a second opinion, and then we give one report, nuclear feature questionable, or some other person give
Yes.
definite features and some other diagnosis.
Yes.
They can't differentiate these
Yes.
two as our pathological diagnosis.
Yes.
So they see only malignancy or not. This is only terminology they use. That is because
But in
there is a
yes, sir.
there is
all
always
this,
a second opinion, and they don't believe this pathologist is not good. That pathologist is good.
so in order to avoid over treatment, that is why they've put up all this. So I think we need to work harder and see more slides, more cases. Maybe as an institute, we can, whatever, wherever we are, take out, as he has suggested, take out 100 slides and see
Okay, thank you.
whether we can.
Thank you.
Thank you. Yeah, thank you.
I'm sorry.
I'm sorry, we will close it now. We are running short of time. So you can have a discussion during lunchtime with ma'am, or you can put your question in the chat box. Madam will reply. Okay, thank you, ma'am.
Now I request our chairpersons to honor our speaker as a token of gratitude for her valuable contribution. Now I would like to call upon Dr. Arundhati ma'am, Associate Professor, Department of Pathology, AIIMS Mangalagiri, to felicitate the chairpersons. Thank you, sir, and thank you, ma'am. Thank you, ma'am. The next session is on the topic diagnostic updates and molecular advances in prostate cancer. For this session, I would like to invite Dr. Mohammed Mia Anwar sir, Professor and HOD, Department of Pathology, Government Medical College, Telangana. Sir has published 15 publications in national and international journals. Sir also acted as State General Secretary, IAPM Telangana State Chapter, and State President for Telangana Teaching Government Doctors Association. We welcome you, sir. I request Dr. Mohammed Mia Anwar sir to take over the session and introduce the next speaker.
Good afternoon, all. It's my privilege to introduce the speaker, Dr. B. Vishal Rao. He's a senior consultant pathologist at Basavatarakam Indo-American Hospital. He has done his MD DNB and Deep RC Path, London, UK. He underwent training at postdoctoral fellowship oncopathology at Tata Memorial Center, Kolkata. He has observership as a postdoctoral fellow, John Hopkins Hospital, Baltimore, and USA. His achievements are IARC editor for the WHO Blue Book on Urinary Systems and Male Genital Organs and Pediatric Pathology 2021 and 2022 edition. US CAP ambassador for January 21 from January 2016 to January 2017. Society for Genitourinary Pathologists, India, founder member, joint secretary 2018 till date. Started first PDCC in uro-oncopathology in India under the aegis of Indian College of Pathologists in February 2022. His awards, he got awarded gold medal For paper presentation in scientific Young Scientist Award category, First Indian Association of Pathologists and Microbiologists Conference, Telangana State Chapter 2016, held at Hyderabad. He has more than 35 international publications and national papers published. He is a reviewer for 2 prestigious Indian journals. He is a guide and co-guide for 10 theses for postgraduates. Served as a speaker and specialist panel discussion in various national genitourinary conference. He is an assessor for thesis for DNB candidates. I welcome Dr. Vishal to deliver the lecture. Thank you.
So, thank you, sir, for your kind introduction. And I thank the Department of AIMS Mangalgiri for the putting up the very amazing conference here. So, without further ado, I'll start my presentation. So, my topic is diagnostic updates and molecular advances in prostate cancers. So this is how I will take you through to my talk. So how we diagnose a prostate cancer is with the patient coming to the clinician with abnormal urinary symptoms and with abnormal digital rectal examination, elevated PSA levels and biopsy. And again, clinical information for any pathologist before diagnosis, they should have the clinical information and which should include PSA levels and what is the clinical context and type of specimen which has been sent to you. Is there any prior biopsy or resection specimen done for the case? Or is there any prior treatment such as ADT or radiotherapy given to the patient? So because these features are important.
Kind attention, please. Poster presentation and faculty and senior residents paper presentation will begin after this session. Thank you.
Okay, so continuing that, so why these PSA levels and Gleason score are important along with the clinical stage? They are useful for the risk assessment. These are the NICE guidelines which are used in mostly in UK and Europe population, and this is the NCCN guidelines which are non-European countries are using it, and which and these are the features which try to stratify them into a very low, intermediate and high and very high grade, and the treatment protocols are accordingly the patient are kept in active surveillance with just PSA levels and radiological assessment if the patient have very low type of risk group, and if the patient is in a high intermediate grade or high grade plus minus ABRT radiotherapy and radical prostatectomy with pelvic lymph node dissection has to be done. So starting with this, the Gleason score, this is the schematic diagram by Dr. Gleason's in the late 60s, which he has drawn, which was based on low power architecture, whether they are discrete glands or poorly formed glands or comedonecrosis or solid pattern. Again, Gleason's grade is widely used, as you know, and it is the most powerful prognostic indicator, and it is based on low or intermediate magnifications, and it predicts. It's an independent predictor for biochemical recurrence, mitosis, and prostate cancer specific mortality. So there is a lot of problem with this Gleason score. What there is a inter-observer variability is there, and the problem of reproducibility is there. So some may think it is 3, some may think it is 4. So these are the recent changes. If you can see 2005, 10, 14, and 19, which have occurred. I will go through these changes also and how the Gleason score has been shaped through these years. In this era of artificial intelligence and digitalization, Dr. Epstein from Hopkins says, why you are using the schematic diagrams? So he has made this library. It is free, and you can just download this picture from the internet, and you can just, my students have pasted a picture of this in their room. So accordingly, you can categorize them into grade 3, which are discrete glands, and they may show marked variation in size and shape, but they are well-formed glands, and you can draw a line around it like this, and they will have a well-formed lumen, and though they may show some various the subtypes like pseudo-hyperplastic, atrophic, and microcystic patterns. So this is one of our slides, and you can see that they are very well-formed glands, prominent nucleoli. Nucleoli you have to see in 20x. So because nuclei will be conspicuous in all the tumors and normal epithelium also. So better if you have lots of prostate biopsies, better to buy a 20x. And this is again this picture same showing a prominent nucleoli, well-formed glands with lumen. The major changes which occur was in pattern 4 because there were 4 patterns were identified like mucin, the poorly formed, cribriform, glomeruloid, and fused pattern. So this is a cribriforming, you can see the pattern is cribriform. So these are the 4 patterns, and cribriform has shown to be an independent predictor of poorer outcome. So you have to mention cribriform pattern identified or not if pattern 4 is there in your report. This is given in CAP also, so you have to mention it. Why? Because it has impact on decision making, and it if patient is having 20%, 30% percentage of pattern 4 also you have to include. I will tell you later also. Why? Then because the patient will be excluded for active surveillance. He won't be there in the active surveillance, and independent predictor of clinical outcome and decreased progression-free survival, and there is more biochemical failure, and there is a doubling time of PSA. So pattern 4, easy, solid sheets, comedonecrosis, minimal glandular differentiation. So pattern 3 and 4, 3 and 5, I think you don't have much of a problem, only pattern 4. So pattern 5, again, as I told you, solid sheets or in singly. So what are the updates? As we see that it was very simple in 2005. So what they did, they just said that don't report pattern 1 and 2 because they resemble normal prostatic acini. In biopsies, definitely. And Gleason score is primary or secondary or the worst pattern. Okay. And in tertiary pattern should not be reported in a biopsy. It should be reported in a radical specimen. So this is the, as you can see here, this is the poorly formed glands and the above are the well-formed glands. So 3 plus 4. Again, only one pattern is seen, you double the pattern. Only 4 is seen, so 4 plus 4. If you see 3 pattern, I have just kept 3 pattern also, like pattern 3 you see, pattern 5 you see, or pattern 4 you see. So you avoid the low grade pattern. You just give the which is the commonest and the highest pattern. Okay. Now 2014, the game was little bit difficult, more difficult. So introduction of grade grouping, prognostic grade grouping. So primarily this work is done by Dr. Epstein in Hopkins. So what they told that since Gleason's pattern 6, if you tell that to a patient that you have a Gleason's score of 6, and this is out of 10, so it is more than average. So they don't go for active surveillance. So that is why he has made this prognostic group. So now they are 5, and you say that you are in grade group 1. Out of the 5, definitely patient is more convinced to go for active surveillance. That is a main important thing. You can call it as prognostic grade group, or you can call it as a WHO group. Don't call ICEP group or GUPS group or SGUP group like that. Okay. This is the chart. This is the basis of that grade grouping, that the biochemical risk-free survival, as you can see, was highest in grade group 1 and 96%, and lowest in the grade group 5. So we validated this grade grouping in our institute also. It was published in Urology Annals, and so we found 8% increase in the change in the prognostic grade grouping. And then luckily Dr. Epstein, he counted whatever he published, and then our study was published with him for validating the same. 2019 it became more difficult. Why? Because now there are two bodies have become. One is ICEP, one is GUPS, and the third one is Indian, our SGOP. So 3 bodies were there. So there was some difference because now 2 bodies. Earlier only ICEP was giving us the updates, but now we have 2 bodies. So which body to follow? So what are the recommendations they have given for pattern 4? So both of the associations have told that small cribriform pattern, earlier they were kept in 3, but they are said to keep everything in 4. So only well-formed discrete glands you keep in 3, otherwise everything you keep it in 4. Okay, poorly formed, fused or glomerular pattern or cribriform pattern. So estimation, the same thing he was saying, the percentage of pattern 4 also you have to mention, like you have given adenocarcinoma 3 plus 4. So in that also you have to give pattern 4 percentage is 10% or 20%. Why? Because if it is less than 10%, patient can still go for active surveillance. If it is high, patient will be, he won't modified Gleason score, prognostic grade, the total percentage of the carcinoma in the core, the percentage of 4 in this 20, the patient will or they go for definitive treatment in this case. If it is 5%, definitely patient may go for active surveillance, may opt for if it is an organ confined and PSA levels are normal. Okay. And cribriform pattern identified or not identified, that also you have to mention in your report when pattern 4 is there. Okay. What is the second recommendation? So recommendation for multiple biopsies, you have to score multiple, you have to give multiple Gleason score. And then at the end, you try to give a global Gleason score. Don't leave it to the clinician because he is confused. 3 plus 4, 4 plus 3, multiple things you have given. So he doesn't know what to do. So better is, this is a template we have made it. So when you get a sextant biopsy of 12 core, 6 from each side, so you can just record your findings. And this is how we record our findings, which we include the histology, the grade, the prognostic grade and percentage, same thing, but in a tabular form, which is easy to record and easy to. So again, the biopsy, if it's the core, depending upon the percentage of tumor, you have to do. And then in multiple lymphoma, because now the question if multiple grades are seen. So what will you report? The highest grade, the composite grade, or the global grade? So composite grade is nothing but it defined as a topography, means a dominant nodule. And global is the entire thing, regardless of the topography. So if you see, so very artistic, somebody has drawn this prostate. And you can see the composite grade is definitely the dominant nodule. And this is the global grade and the highest grade. The concept of systemic map, it helps in systemic mapping because a dominant nodule will drive the treatment and the clinical prognosis. So that is why it is important in radical prostatectomy also, but when they have given a systemic core biopsies. So like this is a sextant biopsy, as you can see, we have all noted down all the grades, different grades, and in this we have written the global grade. Here the global and composite are same, but the highest is 4+5. And they recommend in radical prostatectomy also, the both ICEP and GUPS they recommend to grade the largest, highest, and stage nodule. So this is in our institute we use mega blocks. It really saves time and my neck to see 80 slides. So only 10 slides, everything is done. And this is how the slides look like, and better assessment and better quantification of the tumor is there. And the SGUP, Society of Genitourinary Pathology India, we have published this paper recently. It is free of cost in Indian Journal of Cancer. You can download it and just go through it. So this is how a final report we can see in the radical prostatectomy. So these are the points which you have to report, like whatever we have discussed. So and extra prostatic extension, bilateral vesical involvement, and margins also are very important in this case. What is the GUPS recommendation is they don't believe in tertiary pattern. Like as I told you, in radical prostatectomies, you need to write a tertiary pattern. If you have pattern 3, pattern 4, and pattern 5 is less than 5%, so you say that it is 3+4, but there is a tertiary pattern of 5, like that. But the GUPS nullify this. So what to do in this situation? So you have to mention whatever recommendations you are using. Okay, whether you are using GUPS, whether you are using ICEP, so you just put it in the note that I'm using this in coordination with your clinician. The third one is why this intraductal carcinoma of prostate, very extensively researched and and there a lot of going on this part. So basically very rare tumors and not seen very commonly. I have also seen 1 or 2 cases. So basically they are very large glands and they will cover almost 80% of the duct. And the second picture is of the cocktail marker pin 4, in which the red staining is Amacara and the basal staining is your basal cells. So that is why it is intraductal carcinoma of the prostate. And there are minor and major criteria. And for this also there are a lot of recommendation given, whether to score them or not. ICEP says yes, we should score them. Gov says no need to incorporate it. So there is a lot of things going on between them, but we should follow. We should see what is best for our patient, and you should recommend them accordingly, which version you are using. So why there's so much of discussion on head breaking on this IDC? So it is usually associated with high grade score and stages, low progression free or cancer survival is associated with this, and molecular involvement is also there. I will later on tell you. And there may be another problem with this IDC is that it may resemble a high grade pin also. So again, high grade pin will be not as this much large as compared to the intraductal, and ATPA will be less. In that ATPA, definite ATPA will be there. And this is a flow chart where you can get it in which form. If there is a ductal cell, means if there are no ductal cell, definitely it is a grade 4. And if there are ductal cells surrounding these ducts, the epithelial myoepithelial cells, then again you have to see if there are uniform cells, then they become atypical ductal proliferation. This is the new terminology. I will get back to you in this. And then if there are large glands, then it is intraductal. And if they are tall pseudo-stratified columnar cell, then it becomes a ductal adenocarcinoma. Treatment-related changes, mucinous and the subtypes and the treatment-related changes. In that, how you will do Gleason scoring. So whatever the pattern you are seeing, just based on the architecture, you try to do the scoring. Mucinous or pseudo-hyperfoamy glands or pseudo-hyperplastic. So depending upon whatever you are seeing, subtypes, the underlying architecture. If they are forming well-formed glands, you go for 3+3. If they are forming sheets, you go for 5. Again, radiotherapy changes after treatment. Radiotherapy changes may be there, but still they may retain their lobular architecture. So again, depending on the architecture, you have to score them. And in cases of hormonal ablation also, there will be a lot of changes and pseudo changes will be there. So again, it is not recommended to grade these tumors after hormone, ADT or hormone. Other malignancy you have to rule out from the prostate adenocarcinoma. Primary or secondary involvement is there, or urothelial carcinoma and other carcinoma. So ISCs you have to use in that case. And if you see that PSA, prostine, and NKX 3.1 are the most sensitive and most specific tumors, and these ISCs, and they can be prostine and NKX 3.1 can be expressed unrelated to Gleason's grade. And this is one of our students' thesis we have done on prostine, and we found it very helpful in a panel. So this was published in IJPM journal, which is a special edition for GU. And other benign conditions are there, like seminal vesicular ejaculative degenerative changes, or paragangliomas, or treatment related, as I told you, inflammatory process or nephrogenic adenoma, which may be a mimicker of carcinoma. So you have to keep in mind these things and go with that. So going through the routine histopath, now we are coming to the WHO updates. So this is the 4th and 5th. You can see. Can you tell the change? What is the change? It is more blue. So this is the blue book, and I had the opportunity to do the overall editing of the book. I was the IARC editor. So if you have any doubt, you can just call me or message me. So basically, this is how it looks. And what I say that in the 5th edition looks very simple and more precise as compared with the previous editions. So one of the main thing changes, as from the morning you must have been listening, that the changes are these are the few chapters which are common to all the systems. So they have been kept separately of neuroendocrine, mesenchymal, hematolymphoid, melanoma, metastatic, and genetic syndrome. So they have kept separately. However, in prostate, the mesenchymal tumor and the treatment-related neuroendocrine has been retained. And treatment-related neuroendocrine prostate carcinoma is a new entity, new terminology, because they have a distinct biological and clinical level, and they have management challenges also. I'll let you know. Yeah. The second point which was there, that subtypes and variants. So we very commonly use this term interchangeably. It is a subtype, it is a variant. So what they have kept is variant has been kept only reserved for the genomic alteration. So if there is a genomic alteration, then only you say it is a variant, otherwise it is a subtype. So these are the different patterns. These are patterns are like atrophic, pseudohyper. These are patterns. Why they are called patterns? Because there is no specific prognostic significance, and they simulate a benign histological pattern. So that is why they have not called it as subtypes. So why subtypes? Because they are related to differential diagnosis and haven't prognosis. What are the terminology issues? So what terminology were removed and what was the new thing? So LG pin, do not report LG pin. Low grade pin has to be not to be reported, and cribriform high grade pin has been removed. The new terminology is atypical intraductal proliferation, where architecturally and cytologically more complex than high grade pin, but fall short of IDC pin. So the next terminology is the ductal adenocarcinoma. Lot of studies have been done on ductal adenocarcinoma. Actually, Dr. Cree, who is the head of the WHO Blue Book, he said we should remove it. But again, we have to do more studies because it is always found in correlation with the prostatic adenocarcinoma. It shows ERG mutations. So it is very closely related, but they still have some, and you have to call it in a radical assessment if only you see 50%, more than 50% of the ductal morphology. Large ducts you will see. Okay. And in needle biopsies, don't straight away give ductal adenocarcinoma. If you have to say adenocarcinoma or ductal features. Okay. So we have contemplating that it is just a subtype. So we'll see in future, I think in the 6th edition, this will be gone. Another change in the terminology is the basal cell carcinoma is now called as adenoid cystic carcinoma. There was a confusion because basal cell is a skin tumor, and so that is why it has been renamed as adenoid cystic carcinoma. Why? Because it is the same mutation fusion, MIB and NFI gene fusion is there in the same like adenoid cystic carcinoma and elsewhere. This is the new term, treatment-related neuroendocrine prostatic carcinoma, which can be demonstrated complete or partial and usually seen after ADT treatment. And many a times this may be due to transdifferentiation or lineage plasticity, and it doesn't respond to treatment, AR treatment anymore, and the survival is very dismal. And many a times you will see, I'll give you an example like how cases come to us, like is a known case of prostatic carcinoma. Patient has given ADT, and now the patient has presented with a liver mets, and you get a biopsy. The clinician, our clinician just asked if it could be a neuroendocrine differentiation, because morphology is very high grade, AMCAR is very focal. Then you have to do CD56 or other INSM1 or other neuroendocrine marker. Better to do in a prostatic carcinoma in a metastatic setting. These are the other changes, like prostatic adenoma, signet ring cell variant, it was called earlier. Now it is called as signet ring cell like. I will tell you why. And pleomorphic giant cell adenocarcinoma, earlier it was called as carcinoma. Now it is called adenocarcinoma. And pin-like variant is now called as pin-like only, and sarcomatoid carcinoma has been added. So why signet ring like they are saying? Because they are not true signet rings. Because signet rings have mucin in them, they don't have mucin in them. So they are signet ring cell-like. So very rare subtype and intracytoplasmic evacuation, however, can be seen in any Gleason score. Okay. Adenocarcinoma, why it was changed? Because it was showing it can be focal or predominant, and it was mixed with the routine prostatic adenocarcinoma, and it was positive for all these marker of PSA and prostate. That is why the terminology has been changed. It's not a carcinoma, it is a adenocarcinoma, a variant of subtype of prostatic adenocarcinoma. Another pin-like variant we have now kept for genomic alteration, so it is just pin-like. And P63 will be negative. Recently, we got a case similar looking. Sarcomatoid subtypes, again, it can be focal or it can be homogeneous spindle cell sarcoma, or it can be heterogeneous, showing different areas also. So in this, if you see in a radical prostatectomy, you have to gross it properly. Coming to AI, and AI, definitely lot of things are going on in AI, and a lot of annotation. I have been part of part of this as a reviewer, where we annotate and give different color codes to the lesion scale. Like 3 is given yellow and different colors like that. And we train the AI, and then it gives us the diagnosis. And this is how there's a scanner and all. It will definitely, it will AI. The very common question which is asked: will AI replace pathologist? So AI will never replace pathologist. It will just pathologist will be replaced by a pathologist who uses AI. Okay. So again, so WHO, this in May we went to Lyon, France, where this is the new WHO center which has been opened, and this very proud moment for us that we were standing with the best pathologists in the world, most 180 pathologists, and you can see Dr. Ian Cree standing in front, and he is the head of he retired now. So what about the second half of my talk, molecular updates? So why we need a molecular when so much is happening in the histomorphology? So again, biological behavior is different, and definite active surveillance and adjuvant therapy or treatment for recurrence we have to see. And this NGS, what are the panels you have to ask? So these are the panels which are there, and again, I'll discuss this panel in so main mutation is the HRR gene, which has found to be in the pathogenesis of prostate tumors, and it is seen 90% in localized versus metastatic. And these are often they are also associated with germline mutations, and 42% of these metastatic they have BRCA2, BRCA2. And localized is number is 60%, in which that is other gene is the DNA mismatch repair gene, which we use in other tumors also. And patient with Lynch syndrome may have an increased risk of this prostate cancer, and usually MSH2 mutation is associated with these tumors. And the routine ISC we do for MSI, and as you can see in the first two, MSH2 and 6 are retained, and but there is loss in MLH1 and PMS2. So germline mutation, BRCA1 and BRCA2 can be used, and BRCA2 is usually associated with 2 to 6-fold increase in these tumors. And why these tumors are studied so much? Because these tumors occur, patient who have this BRCA2 mutation will occur early. There will be an aggressive phenotype and associated with significantly reduced survival time. And germline mutation testing, when if there is a family history, if there is a personal history of other tumors, definitely go for this. And these are the few points of high risk and ascendancy use, and patients who already have a family history, you have to go for germline testing. Another is a HOX-B12. These are the additional genes to be tested. And why we are testing these genes? Because presence of HRR defect predicts the response to inhibitors or PARP inhibitors. So PARP inhibitors can be given in these patients, and then PDL1 also can be given in these patients. What are the tests? PCA3, very promising gene-based test which can be done, and where PSA levels are low, and it can detect early cancers. And 4K score test, which combines prostatic specific calculins. There are these they calculate, and they can assess the low risk and low risk. If the patient is in low risk, he can go for active surveillance. If the patient is at high risk, they can go for biopsy. Other the prostate health index, which is also help us to differentiate between benign and the malignant condition. So what are the somatics? This cascade of pathogenesis was done in 2012 in Hopkins, and they have already found out what are the genes involved at different steps of development of prostate carcinoma. But how can we use it? So for somatic testing, we can use it. These are the panels which I showed you earlier. You can use at BRCA1, 2, ATM1, all the genes. And then again, you can also use where there is a strong family history. And circulating DNA assay is also now coming up, liquid biopsy. So you can use that also. And there are strong recommendation for histological and evaluating metastatic size, definitely, because the tumor is more aggressive at that time. Yeah, we coming back to the intraductal. I told you why they are breaking their head on in this intraductal carcinoma, which is of no use, but definitely it has mutation in T53 and or again P10. And patient with intraductal histology should go for germline BRCA2 mutation, they are said. Okay. Polaris tests, these are the gene assays which are used. I will tell you 3 gene assays which are recommended by NCCN guidelines also. The Polaris, which assess 46 genes, and it quantitative measurement of the RNA expression of the level of the genes for the progression of the tumor growth. And it tells the 10-year death rates for the prostate cancer, whether patient will be, how the patient will do in 10 years. Decipher, it is also very commonly used, highly recommended by the NCCN guidelines, where they use a 22 RNA biomarker, and it predicts the probability of metastasis 5 years following the radical. So these tests can be used after radical prostatectomies. Oncotype DX can be used in a biopsy specimen level only, where it consists of a 12 cancer gene related genes, and gives a score of 100. So this is just a summary of these 3 tests. Other AR signaling has also been followed. So in future, we may see more tests more done to diagnose AR signaling. New thing is coming, IDH mutated prostate cancer, which is very rare, seen in young patients, which is anteriorly located, and it has got intratumoral samoma calcification is there. So can be confirmed whenever young patient come, you can confirm it with ISC or molecular recommendation. Tumor mutation burden testing may be considered with the metastatic castrate-resistant prostate carcinomas, and multi-gene molecular testing can be also done. And as I told you that the NCCN guidelines recommend the Decipher molecular assay to inform the adjuvant treatment like that. And multi-gene molecular testing also has to be done in a metastatic setting. What are the proposed biomarker? KI can be used. They say that KI can be used and cutoff can be seen. So at this point of time also, we can use our cutoff. We can see in 100 cases in our population. And P10 loss also, P10 and R. So what is the take-home message? It's too fast. Yeah. So clinical radiological finding, you have to see, and course, when you get multiple course, you report multiple separately, and number of cores have to be mentioned, primary, secondary, or worst pattern. In radical, primary, secondary pattern, and if there is a tertiary, the high grade less than 5%, you can call it as tertiary pattern, and include percentage of 4 in grade group 2 and cribiform pattern. And ISC, you can use coordinates with a HNE morpho and subtyping. And for the personalized or precision is a goal for many researchers. So I help to find out the biological behavior, advanced risk stratification recommended. This I got my copy of, and you can see my name IRC editor in the that section. And, so it is just, we have to don't think you are sitting in a small center and you cannot do anything or like that. Whatever case you have, go for publication. That is the key, and make sure all are PubMed index. And I was able to contribute 19 images in this WHO, and one paper was also quoted in that. Thank you. This is the pediatric. This is the Godzilla of WHO. There were 2 edition for the 2 volume for this, and because of this book, all the other WHO got delayed. That is why we are not getting head and neck, hematolymphoid, or endocrine. These are all delayed because of this. Just see the number of pages for reference. We wanted to print a separate book for reference only. So the first time pediatric book has been published, but I strongly recommend you should go through it, and it is very nicely written. Many almost like 180 pathologists, as I told you, were involved in this. So I think you should go for it. And these are my references, and a few updates have been written by Dr. Eva Compret, and I'm part of that study also, and Dr. Barney is there from UK. So they have written these updates. You can go through those papers also. So this is a very good time to be a pathologist. What I feel that don't get belittled by the clinician and bulldozed by them. Try to attend all the MDTs and try to be part of the, as madam told, try to be part of all the multidisciplinary teams, and and super specialty is go. When the clinician is going, why not us? So it is high time you should go for super specialty. There are many courses. So that is why I have started this course, PDCC in Uro-Oncopathology. This is the first course in India. It is under the aegis of Indian College of Pathologists. You get a certificate at the APCON by the Indian College of Pathologists. And the first batch students are in Hopkins. They have got 1 year of research fellowship under Dr. Epstein. And the second batch students are here, Devaditya and Dr. Tejasvi. You can just talk with them, and they are doing very well. And they were able to submit their paper to CAP, US CAP. And so main thing is research is everything. And whatever you are doing, you just publish that thing. Don't belittle yourself. It is a very good time to be in pathology. I feel like there are so many options. There are so many pathways you can go. So the forms I have kept at the registration. So you can just take up the forms from the registration counters for the PDCC. Another announcement I want to make from our department, they have just pushed me to do this, that there is a conference of, I think the IAPM sir is there, Dr. Anwar is there. So this is Telangana IAPM chapter CME in February. So the flyer is there at the reception counter. If anybody is interested, they can take the flyer from there. I thank you, everybody.
Thank you, Vishal sir. Excellent presentation coming from the basics of Gleason's, the evaluation of the Gleason's gradings from their different patterns, and they have updated. And later on, Blue Book, what are the updates of the terminology. Then he spoke about gene 3 and 4 score test, and he also discussed about liquid biopsy, Polaris test for prediction of prognosis, and decipher test. Like that, he has given complete update about the prostatic cancer. Thank you so much, sir. We'll go for a couple of questions. Any questions, please? And I'd like to take the opportunity to inform you that there is a CME on organized Indo-American Baswatara Community in association with Telangana chapter. I think postgraduates can utilize the opportunity and attend the CME.
Dr. Faik also the IR creditor for the hematology book. So we have five from our department. So Dr. Faik Ahmed is an excellent teacher. I think this will be a very good learning experience for all the students and postgraduates.
Thank you, sir.
Any questions? I think everybody is very hungry.
Thank you, sir. I request Dr. Mohammed Mia Anwar, sir, to honor our speaker as a token of gratitude for his valuable contribution. Thank you, sir. Now I would like to call up Godi ma'am, Assistant Professor of Pathology, AIMS Mangalagiri, take the chairperson. Thank you, sir, and thank you, ma'am. Hope you will have enjoyed the session of the conference so far. Now we are breaking the session for lunch. I request all the delegates to resume at 2 p.m. for the next session. Kindly take your coupons to enjoy the delicious lunch. And kind attention, please. Poster presentation for the postgraduates will be conducted at room number 4, Nursing College block from 2 p.m. Poster presenters from the abstract number PGP 13 to 24 are requested to assemble at the arranged venue by 2 p.m. For the faculty and the senior residents with abstract number FP 1 to 10 are requested to assemble at room number 6, Nursing College block. Thank you.
Hello? Hello? Hello?
2008 to render service to the society. Welcome, sir.
Good afternoon. I feel privileged to stand before in this auditorium, as any one of us would have liked to be a part of All India Institute of Medical Sciences. Though I had an experience in AIMS, but as a patient's father, not as a faculty or any status. So this gives me an immense pleasure for getting a chance, and I thank the organizers for giving me a chance to chair a session where Dr. Sharada is going to give us a academic feast after having a wonderful gastronomic feast. Looking at her credentials, I can understand that she is a tall figure in pulmonary pathology. And let me read out her biodata. She's had Dr. Sharada Nagoti had fellowships exclusively in pulmonary and lung pathology, transplant pathology from two premier universities of USA, the Mayo Clinic, Arizona, and University of Washington Medical Center, Seattle. She is consultant thoracic and lung pathologist, currently associated with CPAT Laboratories, Hyderabad. She had been an invited speaker at many conferences, including resident programs like Tunisia and Romania, and she's a national delegate representing India in the pulmonary pathologists in the podcast Fresh Air series. She had hosted Pulmonary Pathology League 2023 conference with the legend lung pathology, Dr. Henry Tazlar from Mayo Clinic, Arizona, hosting first pulmonary pathology workshop in the National Pulmonary Conference, NAPCON, Hyderabad, in November 30th. She had many publications and as a peer reviewer, and she's a member of United States Canadian Academy of Pathologists, Pulmonary Pathology Society, IAPM, IMA Navi Mumbai, and alumni of Osmania Medical College. And she is also the founder of the Association of Thoracic Pathologists. And I don't want to stand between you and her. And I cordially invite Dr. Sharada to come and give her deliberations.
I also request Dr. Adimulam Ganga Ravindra sir to the stage. Sir has completed MD Pulmonary Medicine in JIPMER Pondicherry and now being currently working as Assistant Professor in Department of Pulmonary Medicine, AIMS Mangalagiri. Welcome, sir.
A very good afternoon to everyone, and welcome back after the delicious lunch. Thank you, sir, for your kind introduction. And at the outset, before I start off, I would like to thank the organizing committee of this conference, especially Dr. Jyotsna Madam and Dr. Jyoti. So the topic that I'm going to talk about is lung cancer diagnosis in the current molecular era, recent updates. So in the next 40-45 minutes, I'm going to talk about the WHO classification of lung tumors 2021, the advances, the small diagnostic samples, the overview of recent changes in adenocarcinoma, squamous carcinoma, and neuroendocrine tumors with few case-based scenarios. I don't want this lecture to be monotonous, so I thought I'll put some cases, some of my cases. And I'm going to talk about the new entities in WHO 2021 classification, the recommendations for diagnostic IHC in lung cancer, updates in molecular pathology and biomarker testing, advances in therapy, and finally, the take-home message. So why should lung tumors be classified? What is the reason? Why should we classify them? This is because classification of lung tumors by histologic subtypes provides important pathobiological information. And many decades ago, the lung tumors were simply classified as small cell carcinomas and non-small cell carcinomas. But in 2004, the WHO has revised that this classification, and this 2004 classification now remains the foundation for lung carcinoma nomenclature. But this 2004 classification is based purely on morphology of resection specimens. So coming to the WHO classification, there is this 2015 has has made significant changes in the 2004 classification, and most of these changes have been retained in 2021 classification. So these are changes in morphological subtypes and patterns, use of IHC throughout the classification, new classification for small biopsies and cytology, and they have made emphasis on genetic studies, in particular integration of molecular testing to help personalize treatment strategies. So this is a simple 2015-2021 classification. There is an extensive list, but these are the most common ones. In the non-small cell lung carcinoma category, we have the squamous cell carcinoma, adenocarcinoma, adenosquamous carcinoma, large cell carcinoma, sarcomatoid carcinoma, and other epithelial tumors like nut carcinoma, and SMARCA4 deficient undifferentiated tumor. This is the new entity which has been added in WHO 2021. And then we have the neuroendocrine tumors like carcinoids, typical and atypical carcinoids, small cell carcinoma, large cell neuroendocrine carcinoma, the salivary gland tumors, mesenchymal tumors, and hematolymphoid tumors, and the metastatic tumors. So coming to the WHO classification 2021, what are the advances? So the principles, the basic principles of this lung tumor classification, they remain the same. First, we have to classify them according to the morphology. Then we have to go to the immunohistochemistry and subtype them, and then do the molecular testing. So what are the major features of this 2021 classification? What are the major advances? So they have made broader emphasis on genetic testing in the 2015 classification. In 2015, it was there was particular emphasis on using immunohistochemistry, whereas in 2021, they have put greater emphasis on genetic testing, the molecular testing. And the second one is they have put there is an entire section dedicated to the classification of small diagnostic samples. There is continued recommendation to document percentages of histological patterns in invasive non-mucinous adenocarcinomas, to apply a formal grading system, to use only invasive size for T-factor size determination in invasive lipidic non-mucinous adenocarcinomas. So all these features which I am describing now, I'm going to tell them in detail in my subsequent slides. And then there is a recommendation of stars that is spread through air spaces as a histologic feature with prognostic significance. They have moved lymphoepithelial carcinoma to squamous cell carcinoma. There is an update on evolving concepts in lung neuroendocrine neoplasm classification. There is a recognition of new entities like bronchial adenoma, ciliated mucopapillary muconodular papillary tumor as a new entity within the adenoma subgroup. The other new entities which are added are SMARCA4 deficient undifferentiated tumor and primary pulmonary hyalysing clear cell carcinoma. And they have put, there is an inclusion of essential and desirable diagnostic criteria for each tumor. So coming to the small diagnostic samples, as we all know, 70% of lung carcinomas present in advanced stages, and they are unresectable. So the diagnosis for these patients is based primarily on small biopsy and cytology samples. Therefore, a new classification for lung cancer in small diagnostic samples was introduced in 2011, IASLC, ATS-GRS lung adenocarcinoma classification, and this is adopted in 2015 classification. The same is there in the 2021 classification as well. So this is the table showing the terminologies which has to be used in while reporting small biopsy and cytology samples. So when the morphological pattern is clearly squamous cell, then sign it out as squamous cell carcinoma. If the morphology is clearly of adenocarcinoma, sign it out as adenocarcinoma, and then list the patterns in the diagnosis. If it is an lipidic pattern, then mention it as adenocarcinoma with lipidic pattern or invasive mucinous adenocarcinoma. Or if there are other variants, then sign it out as adenocarcinoma with colloid features, adenocarcinoma with fetal features, adenocarcinoma with enteric features. So if the morphology of squamous cell pattern is not present, but the immunosquamous cell carcinoma like P40 or P63 are positive, then sign it out as non-small cell carcinoma favors squamous cell carcinoma. Similarly, if the morphology of adenocarcinoma is not there on the biopsy, but the immunos for adenocarcinoma like TTF1 and APSIN are positive, then sign it out as non-small cell carcinoma favor adenocarcinoma. And there is no clear-cut adenocarcinoma, squamous carcinoma, neuroendocrine morphology, or even the immunos are negative, then sign it out as non-small cell carcinoma, not otherwise specified. Then coming to the terminology used in neuroendocrines, if the morphology is small cell carcinoma, then sign it out as small cell carcinoma. If there is neuroendocrine morphology and the neuroendocrine markers are positive, but the morphology is that of non-small cell carcinoma with neuroendocrine morphology, then sign it out as non-small cell carcinoma with neuroendocrine morphology and positive neuroendocrine markers, possible large cell neuroendocrine carcinoma. And if the morphology is of both adeno as well as squamous, then it is non-small cell, sign it out as non-small cell carcinoma and not otherwise specified, and put a comment saying that this could represent adenosquamous carcinoma. This is because adenosquamous carcinoma cannot be, the diagnosis of this cannot be made on small biopsy sample. The diagnosis should be made only on a resection specimen. So in small biopsy, sign it out as non-small cell carcinoma and NOS, and just put a comment saying that it could represent adenosquamous carcinoma. And if the morphology is features are not of squamous or not of adenocarcinoma, but immunohistochemistry stains for both squamous and adenocarcinoma components, then sign it out as non-small cell carcinoma, not otherwise specified, and put a comment saying that this could represent adenosquamous carcinoma, but the diagnosis again requires a resection specimen. Similarly, if there are other sarcomatoid features like spindles or giant cells, sign it out as non-small cell carcinoma with spindle and giant cells carcinoma, and put a comment saying that this could represent pleomorphic carcinoma, and the diagnosis again requires a resection specimen. So note that adenosquamous carcinoma, the diagnosis of adenosquamous carcinoma, pleomorphic carcinoma cannot be made on small biopsy samples, but these are the diagnoses which have to be made only on resection specimens. So this is the algorithmic workup for lung cancer diagnosis in small biopsies and cytology samples. As I told you, if the morphology is clear-cut adenocarcinoma, then sign it out as adenocarcinoma. If it is squamous cell carcinoma, then if it is neuroendocrine morphology along with staining for neuroendocrine markers, they are neuroendocrine tumors. And if the morphology is morphologically, it is neither adeno nor squamous, then sign it out as non-small cell carcinoma, not otherwise specified. And further immunohistochemistry has to be done to further subtype this non-small cell carcinoma, not otherwise specified. Then apply immunohistochemistry markers. The most common markers which are recommended are TTF1 and NAPSIN. And so only if these are negative, then we can go for the additional markers. So if the TTF1 adeno markers are positive, it is non-small cell carcinoma favor adeno. If squamous markers are positive, non-small cell carcinoma favors squamous cell. If both are present in two different components of the tumor, then non-small cell carcinoma and possible adenosquamous carcinoma. If all the markers are negative, non-small cell carcinoma, not otherwise specified. So all these three, non-small cell carcinoma favor adeno, then possible adenosquamous, not otherwise specified, all have to be taken for molecular testing. So coming to the small biopsy tissue preservation, we all know that tissue remains the main issue in this era of targeted therapy. So maximum efforts have to be made to preserve the tissue to allow for this biomarker studies. So there are a lot of methods which we can do in our routine clinical practice. But one point which I would like to highlight is immunohistochemistry should be performed only if the morphology requires it. If the morphology is very well differentiated adenocarcinoma, squamous carcinoma, there is no need to go for immunohistochemistry. You can just sign it out. If the morphology is poorly differentiated, then put IHC markers, and the guidelines recommend only two markers, TTF1 and P40, which will allow for precise diagnosis of adenocarcinoma, squamous cell carcinoma. So what are the points which have to be mentioned when reporting a small biopsy or cytology samples? So you have to put the pathological or cytological diagnosis according to the WHO 2021 classification. You have to mention the results of the immunohistochemistry staining or the mucin stains, which we use those. Then put a comment about the differential diagnosis whenever it's appropriate. And put a statement of whether any material has been submitted for molecular testing. And if the results are available, put those results also in your report and specify which block was used for this molecular testing, and also document the percentage of viable tumor cells in that particular block. So these are all the things which have to be mentioned when you're signing out a small biopsy sample or a cytology specimen. So coming to the overview of changes in each of these carcinomas, first adenocarcinoma, the WHO classification 2015, there are not significant changes in the 2021 classification. The same has been retained. The pre-invasive lesions include atypical adenocarcinoma, adenomatous hyperplasia, and adenocarcinoma in situ. And the invasive lesions include minimally invasive adenocarcinoma, non-mucinous or mucinous, invasive non-mucinous adenocarcinoma, invasive mucinous adenocarcinoma, the variants of adenocarcinoma like fetal, colloid, and enteric type. And Please note that the term bronchoalveolar adenocarcinoma, which was once used, is now obsolete. So we should not use this term. This term is no longer used. So invasive non-mucinous adenocarcinoma, these represent more than 90% of resected lung tumors. These are malignant epithelial tumors with glandular differentiation or mucin production or pneumocyte marker expression. So what is the morphological evidence of glandular differentiation? Any of these patterns like lepidic, SNR, papillary, micropapillary growth patterns, this is the morphological evidence of glandular differentiation. And in pure solid tumors, IHC has to be performed. The markers are TTF1 or napsin. Or a mucin stain can be performed for the evidence of carcinomatous differentiation. So coming to the staging, for non-mucinous invasive lipidic adenocarcinomas, non-mucinous invasive lipidic adenocarcinomas, measurement of invasion is very much required for staging purposes. So for this measurement of invasion, the size of the invasive component has to be considered rather than the total size of the tumor. So this is one point which was highlighted in the WHO 2021. And for measurement of invasion, any histological type other than the lipidic type, that is the SNR or papillary or micropapillary or solid types, are less often colloid, enteric, fetal, or invasive mucinous adenocarcinomas. These are foci of tumor cells infiltrating myofibroblastic stroma. These are included in the assessment of the size of the tumors. So coming to the grading of invasive non-mucinous adenocarcinomas, WHO 2021, this grading has been introduced for invasive tumors to provide prognostic information. So this grading is based on a combination of predominant histological pattern plus the worst pattern. The percentage of each histological pattern has to be recorded in the increments of 5 to 10% to determine the predominant histological pattern. So this is the grading. Grade 1, we can see grade 1 is well differentiated. So it includes the lipidic predominant pattern with less than or equal to 20% of high-grade pattern. Grade 2, it is moderately differentiated. And this includes the SNR or papillary predominant pattern with less than or equal to 20% high-grade pattern. And grade 3 is a poorly differentiated adenocarcinoma where there is any tumor with more than 20% high-grade pattern. So what are the high-grade patterns? These high-grade patterns are the solid pattern, micropapillary, cribriform, or complex glandular patterns. So all these are high-grade patterns. So here one point I would like to highlight is this grading is applicable only for invasive non-mucinous adenocarcinomas and not for invasive mucinous adenocarcinomas. So coming to a case, this is the left lower lobectomy specimen of a 48-year-old female with 4.8 centimeter nodule in the left lower lobe. So any residents here, can you say what is this pattern in this picture? What is this pattern? So you find here this complex glands which are infiltrating this desmoplastic stroma. This is the SNR pattern. What is this pattern? The tumor cells are growing along the alveolar septa. So this is the lipidic pattern, yeah. So what is this pattern? The tumor cells are in the form of solid sheets. Solid pattern. So the same tumor is showing all these patterns. So what is this pattern? Tumor cells are growing along the fibrovascular core. This is the papillary pattern, yeah. What is this pattern? So the tumor cells are seen in the form of these papillae, but these papillae do not have any small papillae. They do not have any fibrovascular core. And they are also seen in the form of these ring-like structures as florets. Some of them they have detached from the alveolar septa and they are just floating in the alveolar spaces. So what is this pattern? This is a micropapillary pattern. So the other foci, the tumor is showing this pattern. What is this? Back-to-back glands with the mucin and small bland basally oriented nuclei. And they often show lipidic predominant pattern, but when you do extensive grossing, extensive sampling, foci of invasion are also seen. Typically, these are aggressive and they are often multifocal and they can mimic pneumonia with ground glass changes. And the immunophenotype, there is a lot of overlap between this invasive mucinous adenocarcinoma and the GIT carcinomas. So immunohistochemistry is not useful in identifying, differentiating between these two. And KRAS mutations are the most common mutations which are found in these invasive mucinous adenocarcinomas. So this is a CT-guided biopsy of consolidation in left lower lobe. Clinically, they thought that it is an unresolving pneumonia. And this is how the tumor looks. So this is the normal lung parenchyma. In between these, this is how this invasive mucinous adenocarcinoma looks like. So there is normal lung parenchyma, and then suddenly there is abrupt transition into this tumor. And we can see that these tumor cells are growing along the alveolo-septa, that is the lipidic pattern. And hyper view is showing these cells which have this bland basally oriented nuclei and a lot of apical mucins. So this is how invasive mucinous adenocarcinoma looks like. And then variants of invasive adenocarcinoma, we have the enteric type of adenocarcinoma, and the colloid adenocarcinoma, and the fetal adenocarcinoma. And the enteric type and colloid, in the enteric type, more than 50% should show enteric morphology, that is in the form of this complex papillae and glandular structures with these dirty areas of necrosis. In the colloid adenocarcinoma, there should be more than 50% colloid. These are the tumor cells, they are destroying these. Pulmonary neuroendocrine cell hypoplasia, tumulates, and low grade includes typical carcinoid, intermediate grade, atypical carcinoid, high grade, small cell carcinoma, large cell neuroendocrine carcinoma. So basically the classification in WHO 2021 also remains the same. So the overall nomenclature is essentially unchanged in 2021, but the clinically relevant updates, these relate to the terminology for biopsy, cytology or metastatic specimens, to cell proliferation assessment and role of specific markers, and to the potential role of genetic data in the subtyping of these neuroendocrine categories. So these are the recent updates in 2021 in neuroendocrine tumors. So this is the term which was carcinoid tumor NOS. This is the term which is introduced in this WHO 2021 classification. And this is used in 3 settings where the distinction between a typical carcinoid and an atypical carcinoid may not be possible or appropriate. So in such cases, okay, 1 second. Sure. Sorry, we have a problem in our online connectivity. We are working on that. Regret for the inconvenience caused. Comment that the screen also. We can start now. So I was talking about this carcinoid tumor not otherwise specified. Term which is introduced to be used in 3 settings where the distinction between a typical carcinoid and an atypical carcinoid cannot be is not possible. So in such cases, use this term in the report carcinoid tumor NOS, and then you have to record the mitotic. You have to document the mitotic activity, the presence or absence of necrosis, and if available, even the Ki67 index. So what are these 3 settings? In the first one is in the reporting of small biopsy cytology samples where the distinction is not possible because of the limited sampling of the tumor. The second setting is this term has to be used whenever you are reporting a metastatic carcinoid. And the third is if there are limited slides available for review, so you will not be able to exclude the presence of an increased mitotic activity or necrosis in the slides which are not provided. So in such a scenario also you have to use this term carcinoid tumor, not otherwise specified. So coming to the role of Ki-67, there is no role in classification of neuroendocrine neoplasms of lung, unlike that in GI. So what is the main role then? So its role is to help distinguish carcinoid tumors from large cell neuroendocrine and small cell carcinomas, especially in small biopsies where there is a crushing artifact. And it has a role in reporting a metastatic neuroendocrine tumors, and documenting this Ki-67 in reports is considered a desirable criteria by the WHO, though this is not, as I've already said, it's not diagnostic criteria for the classification. So Ki-67 is a prognostic marker in carcinoids associated with the rate of post-operative recurrence and metastasis.
వీడియో కాన్ఫరెన్స్ లో ఆన్ చేసి ఆగిపోతుంది.
ఏం చేస్తాను ఏం చూస్తాను
So coming to assessing the proliferation, mitotic activity, mitotic count and role of Ki-67, the current WHO recommends that mitosis should be counted only in areas of highest activity, reported as number of figures per 2 millimeter square and not as 10 high power fields. And in tumors with borderline values, 3 2 millimeter square areas should be counted and the mean value has to be reported. And another thing is only definite mitotic figures have to be counted and excluding the questionable. So coming to carcinoid tumors with 5 proliferation. So these are the tumors which are characterized by well-differentiated organoid morphology of carcinoids, but the proliferative activity, that is the mitotic count, is exceeding 10 per 2 millimeter square. So the current recommendation is to label these such tumors as large cell neuroendocrine carcinoma on the basis of the high mitotic activity. But again, a note has to be added specifying that these tumors show carcinoid morphology, and also the Ki67 has to be given if available. So a lot of genomic analysis is available only for few of these cases, and more investigations are going on in these tumors. So coming to another case, this is a right lobar lobectomy of a 33-year-old female with 3.5 centimeter mass in the right lower lobe. This is how the low part looks like. This is the high part. So what is this? Based on this morphology, this is the organoid morphology with the monotonous looking cells with salt and pepper chromatin. What is this? With vascular spaces in between. This is a typical carcinoid. So you should not just leave your report signing it out as only typical carcinoid. You have to mention the mitotic activity. Here it is less than 2 per 2 millimeter square. You have to mention whether there are areas of necrosis and Ki67. So this is another case. It's a CT-guided core needle biopsy in a 57-year-old man with anterior mediastinal mass of size 1.8 centimeter in greatest dimension, accompanied by enlarged mediastinal nodes. And this is how the tumor looks like. This is the Ki67. This is a case of atypical carcinoid. Here there are some oval to spindle shaped cells. There is some increase in mitotic activity, and this is the Ki67 around 8 to 10%. So this is an atypical carcinoid, and this is actually an atypical carcinoid of thymus. When I have done the IHC markers, it was a thymic atypical adenocarcinoma, and this thymic atypical carcinoid, and this I published in Pulmonary Pathology Society as case of the month. So coming to another case, 72-year-old male smoker presents with weight loss and muscular weakness. CT scan showed hilar mass with mediastinal lymphadenopathy and cryobiopsy was done, and this is how the cryo look like. This is the synaptic fibrin positivity, and this is the Ki67, more than 85%. And based on this morphology, what is this? Small cell carcinoma. So this is the table which differentiates the typical, atypical, and the large cell and small cell carcinomas. This is given in WHO classification due to constraint of time. I'm not going in detail. Next, coming to squamous cell carcinomas, in WHO 2004, variants were included like papillary clear cell and small cell. And in 2015 and 2021 classification, these variants have been completely removed, and they are just classified as keratinizing squamous cell carcinoma, non-keratinizing squamous cell carcinoma, and basaloid squamous cell carcinoma. So only a few minor adjustments were made, and note that this classification, unlike that in adenocarcinoma, it doesn't have any clear clinical or prognostic implication. So this is clearly, it's a clear-cut keratinizing squamous cell carcinoma with beautiful keratin pearl in this picture and intercellular bridges. So non-keratinizing squamous cell carcinoma, where we couldn't find any squamous differentiation. So IHC with P40 and TTF1 was done. TTF1 was negative, and this is the P40, which is beautifully highlighting these tumor cells, making it as squamous cell carcinoma. So coming to the lymphoepithelial carcinoma, previously it was called as lymphoepithelioma-like carcinoma in the 4th edition, and it was categorized under other and unclassified carcinomas. But because of the lack of correlation between this lymphoepithelioma-like histology and Eberish, it's now renamed as lymphoepithelial carcinoma, and this has been classified as a type of squamous cell carcinoma. So now lymphoepithelial carcinoma includes both EBV positive as well as EBV negative subtypes. So this is a poorly differentiated squamous cell carcinoma with distinct syncytial growth pattern admixed with variable amount of lymphoplasmacytic infiltrate, and there is diffuse positive staining for the squamous markers CK5/6, P40, and P63. So this is how it looks like. It looks like, so these are all the tumor cells in the form of solid sheets with moderate cytoplasm, vesicular nucleus, and prominent nucleoli. And in the background, you find this lymphoplasmacytic infiltrate. So coming to the molecular categorization of lung squamous cell carcinoma, no major discovery was done in this squamous cell carcinoma, unlike lung adenocarcinoma. And they may benefit from anti-programmed cell death protein, PD-L1 therapy alone or in combination with chemotherapy. EGFR, MET mutations and ALK and ROS1 mutations can occur in lung squamous cell carcinoma, especially among young, never smoking patients with squamous histology. So in this particular high-risk phenotype, only in this particular high-risk phenotype, that is young, never smoking patients with squamous histology, it is recommended to use molecular testing. Otherwise, in pure squamous cell carcinoma, molecular testing is not recommended. So coming to the rare tumors, thoracic SMARCA4 deficient undifferentiated tumor, This is the new added entity in the 5th edition. This is a high-grade malignant neoplasm featuring undifferentiated or rhabdoid phenotype and has a deficiency of SMARCA4, that is BRG1. It's a key member of the BAF chromatin remodeling complex. Previously, it was known as SMARCA4 deficient thoracic sarcoma. It is considered as a distinct entity because it has significant histological, immunohistochemical, clinical and prognostic differences. So clinically, these patients are young smokers. This is an aggressive tumor and it has poor prognosis. And histologically, this lacks epithelial architecture, that is glandular architecture, and it is composed of disc cohesive cells, large cells, round to epithelioid cells with prominent nucleoli with rhabdoid morphology. And coming to the immunohistochemistry, there is loss of SMARCA4, BRG1 expression, and there is weak or focal positivity or negative for cytokeratin. P40 and TTF1 are negative or rarely positive, and other positive markers include 34, SAL4, and SOX2. So this is how this tumor looks like. It is an aggressive tumor. It has rhabdoid morphology with abundant cytoplasm. There's a pleomorphic nucleus and vesicular, and prominent nucleoli. So coming to the other new entity which is added, that is the bronchular adenoma, also called as ciliated muconodular papillary tumor. This is a novel entity in the 2021 WHO classification. It is recognized as a type of pulmonary adenoma. This tumor is composed of nodular proliferations and they grow along the alveolar lung parenchyma and they are bilayered. They have a continuous basal layer which is highlighted by P40 and a second layer of luminal cells. So there is no cytological atypia, there is no mitotic activity, and the composition of these luminal cells is based on the location of the adenoma, whether proximal or distal. In the proximal type, they have papillary architecture with abundant mucinous and ciliated cells, and the term ciliated muconodular papillary tumor corresponds to this proximal type of this bronchular adenoma. Whereas in the distal type, they are typically flat with focal or no papillary architecture, with focal or no mucinous or ciliated cells. So BRAF driver mutations are the most common mutations in this bronchular adenoma, and clinically they present as incidental lesions, as small, solid or ground glass peripheral nodules, and patients are middle-aged to elderly. So this is how this bronchular adenoma looks like. The glandular to papillary structure with this lined by these mucinous cells. So coming to the next entity, new entity, that is primary pulmonary high-lying clear cell carcinoma. This is again a new entity which was added in 2021. This is identical to its salivary gland counterpart. These are found adjacent to the bronchi or maximal or in the proximal bronchioles, and they are composed of bland appearing epithelioid cells with small monomorphic nuclei with prominent clear cytoplasm. And there are distinctive hyalinizing acellular collagen bundles which are found in the background. The proliferative activity is low and cytological atypia is minimal, and they stain for all these stains, and FISH analysis shows this particular gene fusion, that is EWSR1 ATF1 gene fusion. So this is how this looks like: bland cells with clear cytoplasm and bland basally oriented nucleoli with this collagen bundles which are present in between these tumor nests. So coming to the recommendations for diagnostic IHC in lung cancer, these are the guidelines which are published in Journal of Thoracic Oncology. And the best combination markers, as I said, are TTF1 and P40. And TTF1, even if it is focal positive, even if the tumor cells show focal positivity, it is considered as positive. Whereas for P40, more than 50% of the tumor cells should be positive to call it as positive. Then cytokeratin 7, CK7 positivity in the absence of TTF1 and P40 should not be taken as probable adenocarcinoma because this CK7 can be positive even in squamous cell carcinomas. So CK7 cannot be used to differentiate between adeno and squamous cell carcinomas of lung. And neuroendocrine markers, as I've already mentioned, they have to be used only when there is neuroendocrine morphology to support neuroendocrine morphology. Otherwise, neuroendocrine markers should not be used. And coming to the cytological samples, all preparations, cell block, air-dried or ethanol fixed smears can be used for immunohistochemistry. And as I've already mentioned, to differentiate this mucinous carcinomas from the other metastatic mimics, especially from the GI and pancreas, there is no useful marker, and clinical pathological tumor board is crucial to differentiate whether it is a primary mucinous adenocarcinoma of the lung or metastatic adenocarcinoma. So coming to the molecular pathology and biomarker testing, in 2015, EGFR mutations and ALK fusions were the only driver mutations that we required in the routine clinical testing for non-squamous, non-small cell lung carcinomas. Since then, more driver mutations, more driver genes with available drugs have been identified as targeted therapies. or for patients harboring driver mutations in these genes have and targeted therapies for these patients have become available. So these new development have led to an update in the CAP IASLC AMP guidelines. I'm going to show you those guidelines in the next slide. So in addition, testing for PDL1 is now recommended for advanced stage neuroendocrine carcinomas because patients with a PDL1 tumor proportional score more than 50% are eligible for first-line treatment with anti-PDL1 therapy, that is a pembrolizumab. So these are the guideline recommendations, different guideline recommendations for predictive and emerging biomarkers. So these are the different guidelines, ESMO guidelines, NCCN, CAP, ASCO, and Pan-Asian guidelines. So on the left, you find these predictive markers, and you can see that in all these guidelines, 3 markers, that is EGFR, ALK, ROS1, these 3 are unanimously recommended by all these guidelines. So any adenocarcinoma should undergo testing with all these 3 basic panel, that is EGFR, ALK, ROS. Whereas there are these emerging biomarkers like MET, RET, and RB2, and these emerging markers, they are recommended only in the expanded panel and not a single gene analysis. And these markers are recommended by some guidelines where they are not recommended in other guidelines. And coming to this KRAS, the CAP recommends the testing of KRAS in all the adenocarcinomas, whereas in Asian guidelines, it is not recommended. This is because in Caucasian populations, the incidence of KRAS mutations is 30%, whereas in Asian, it is just 10 to 15%. So that is the reason why the Asian guidelines have not recommended testing with KRAS upfront, whereas this CAP says that they have to be, KRAS has to be tested upfront in all adenocarcinomas. So on the basis of mutation and gene expression profiles, carcinoid tumors, they appear to be composed of multiple molecular subgroups. So significantly mutated genes in these carcinoid tumors, they include the MEN1, EIF1AX, and ARID1A. Out of this, MEN1 is the most common. And unlike in small cell and large cell neuroendocrine carcinomas, mutation in TP53 and RB1, these are rare in pulmonary carcinoids. And coming to the small cell carcinomas, whole gene genomic sequence analysis has shown that, revealed that loss of tumor suppressor genes, that is TP53 and RB1, is obligatory in small cell carcinomas. So there's currently great hope in translating this scientific progress into novel therapies in this neuroendocrine, regarding this neuroendocrine tumors. So coming to advances in therapy, the development of NGS, that is next generation sequencing, has accelerated the implementation of genomic sequencing in clinical practice. And based on this biomarker status, a wide variety of targeted therapies are now available. And this has led to a drastic change in the treatment of patients with non-small cell lung carcinomas. Also, there are studies which have going on this immune checkpoint inhibitors. They have completely changed the approach taken to the treatment of advanced stage lung cancers. There is now evidence that the first line setting of the superiority of immunotherapy over cytotoxic chemotherapy, or at least in a subset of patients, the possibility to combine both chemotherapy and there is a possibility to combine both immunotherapy as well as chemotherapy. So with this, I complete my talk, and these are the pictures when I was doing my fellowship in Mayo Clinic and in University of Washington Medical Center. And this is the fresh air CTs, some academic stuff which I do with these great pulmonary pathologists, Dr. Sanjay Mukhopadhyay, Cleveland. This is Irini from Spain, Matt from Western University, and this is Raga from Virginia. And this is the ongoing project of Association of Thoracic Pathology, the season 4. The Diagnostic Pulmonary Pathology web series. So we have these pulmonary pathologists from across different universities of the world. And this is the recent conference which we have organized with Dr. Henry Taslar, the Pulmonary Pathology League, on October 21st in Hyderabad. So with this, thank you all for the patient hearing, and I'm happy to take up any questions.
I think you all agree our topic that has been discussed by Dr. Sharada. She has elucidated all the details of squamous cell carcinoma, there's lung cancers, the histological aspects, the new entities, and the mandatory requirements of certain marker studies, as well as some are desirable, some are need not be done, but can be done. And also she has introduced the new entities like CMPT, and also she has elucidated us on the molecular aspects of lung cancer. And now I think you'll all agree that the topic has been discussed quite thoroughly and more lucidly, and everyone has understood. The topic is now open for questions. If anyone has got any questions, you can directly shoot to her. Madam is ready to answer any questions. If there are no questions, it means that it has gone completely into the head. And definitely I'll say that it has been so lucid and excellent talk. Thank you so much, ma'am.
Thank you so much, sir.
And one small advisory to the PGs and young pathologists. We are on the other side of the practice, and we had our say and we had our way as practicing pathologists, but that is not the case now. We are being questioned by the clinicians and we are on our shortcomings, and which sometimes makes us feel that we are not so equipped with the advances, and that makes us put us to a bit of insult that we should not accept that. So that the young pathologists must always be keeping abreast of the developments so that they will not be wasted. Otherwise, as Dr. Vishal Rao has said, I think one version will be replaced by an advanced version. So that should not happen. So let us be giving ourselves to keep ourselves and keeping abreast of the developments so that we are in the specialty with pride. And I once again thank the organizers for giving me the opportunity to chair this session, especially to both Doctors J&J, not Johnson & Johnson, the multinationals, but Josna and Jyoti for giving me the opportunity. Thank you so much.
Thank you, sir. Now I would like to call upon our chairpersons to honor our speaker as our gratitude for her valuable contribution. Thank you, sir, and thank you, ma'am. I request Dr. Jyoti Verma, ma'am, Assistant Professor, Department of Pathology, AIIMS, Mangalagiri, to felicitate the chairperson. Thank you, sir. Up next is diagnostic updates and molecular advances in urinary bladder cancer. For this, I would like to invite our chairperson, Dr. Seema Dayal, ma'am, Professor and Department of Pathology, Uttar Pradesh University of Medical Sciences, Uttar Pradesh. Ma'am has more than 50 publications, mostly in international journals, and authored various book chapters. Ma'am also acted as reviewer for PubMed indexed journals. Her area of interest are gynec pathology and breast pathology. Welcome, ma'am. I kindly request ma'am to take over the session and introduce about the speaker.
Good afternoon, everyone. It's an honor to invite Vishal sir to deliver his lecture. And
I'm already हो गया.
no, we have to.
No, I'm already done.
So
They will get
we
bored.
are very much eager to know what you are going to teach us.
Yeah.
So, thank you, sir, and with my all the best wishes.
Thank you. Thank you. I'm here again. Don't blame me, blame the organizers. So this is the most difficult session, post lunch second talk. So I will see, I'll try to keep you awake as much as I can. So, okay. So again, coming to the diagnostic update and molecular advances in the bladder tumors. Always try to write urinary bladder, because if you are not a uropathologist, it may imply gallbladder also. So start from here. So this is how I'll go through the presentation. So again, more than 90% of urothelial tumors originate from the urinary bladder, and usually classified into low grade and high grade, depending upon the nuclear anaplasia and the architectural abnormalities. So again, that non-invasive and invasive, they are classified, and non-invasive tumors again can be flat lesions, which include the carcinoma in situ or dysplasia. I will explain the definitions for in my subsequent slides. And other are papillary lesions. So these papillary lesions, again, benign lesions as urothelial papilloma or inverted papillomas, or pannulum, which is tumor of malignant potential, and low grade, high grade, non-invasive. Okay. So the presence of these subtypes has to be documented because they represent an increased risk of progression, reflect different genetic etiology, and subsequently determine whether it's a more aggressive tumor or not. So there is a long list of these tumors which has been said. Again, this is I'll start with the NCCN guidelines, because everything comes, all the diagnosis, whatever you made, is important for the risk assessment of the patient, for the further management of the patient. This risk assessment can be done depending upon the type of the histology, the size, and whether there are multiple tumor or solitary tumors. So this is the latest NCCN guidelines, which was published in September this year. And then again, depending upon the risk stratification, low risk, intermediate risk, as you can see, a patient may undergo mitomycin. Treatment will be according to the risk assessment. So that is why that is very important, what type of tumor it is, what size, location, how number of tumors. So again, those were non-invasive. In muscle, invasive also, low grade, high grade, and accordingly radical cystectomy is the if it is a low grade tumor, low category, risk category, it will only radical cystectomy. If high risk, then patient will have NSCT will be given, neoadjuvant chemotherapy will be given first upfront, and then this radical cystectomy plus minus bilateral lymph node dissection can be done. So coming to the updates, first I will see the updates and then we'll go into the problems in this case. So again, 4th edition, 5th edition. So there are separate chapter for urothelial papilloma and inverted urothelial papillomas. And there are new entities with diverticular carcinomas. And these urethral accessory gland tumors, carcinomas are there. So I will explain these in my subsequent slides. So again, in the 5th edition, they have maintained that histopathology is the gold standard, and the 3-tiered classification of pannulum and low grade and high grade they have maintained. And then special attention for grading and heterogeneous lesion and inverted tumors and substaging has been given. And emphasis on promising stratified for more precision-based treatment approach has been made in this 5th edition. So if we see the summary of changes, the main changes are that those two benign entries, as I told you, that urothelial papilloma, inverted papilloma have a separate chapter. Variants and subtypes, I already told you in prostate updates that now variants are only where there is a genetic abnormalities there. And then grading of bladder, the definition of dysplasia and carcinoma in situ, the staging, divergent differentiation, and its subsequent rare tumors. So grading of non-invasive tumors. So WHO maintains the clinical relevant category of Panlum and low grade, high grade, as I told you. And Panlum has a lower rate of recurrence and progression than the PTA carcinomas. Therefore, these tumors are considered as low grade tumors and do not need to be named as carcinomas. And benign lesions are not to be graded. So if you see how the normal epithelium looks like, where there are uniform and intermediate cells are there, basal cells are there, and superficial umbrella cells will be there. And again, in hyperplasia, the number will increase, and then the dysplasia, and then carcinoma where full thickness dysplasia will be there. The panulum is nothing but a papillary core and are lined by urothelial cells without any cytoplasmic atypia. I'll tell you how to differentiate a panulum with a low-grade urothelial carcinoma. This is a low-grade urothelial carcinoma where there will be atypia will be there. There will be loss of polarity. That is one of the main important point for differentiating panulum with low-grade non-invasive papillary urothelial carcinoma. And high-grade, definitely there will be the more atypia and prominent nucleoli, mitosis, everything will be there. I'll describe these changes later. And invasive carcinomas where the tumor is invaded by thick muscles. This is a high grade image of the high power image of that same. What about grading in heterogeneous lesions? So another important issue which was taken up in this 5th edition was grading in handling heterogeneous tumors. That because 5 to 40% tumors display grade heterogeneity, and then all papillary lesion with more than 5% high grade should be labeled as high grade only. However, less than 5% should be given a comment. At this point, I want to ask, sir, how Dr. Santosh, have you tried giving this? Not so common. I gave in one case. Yeah. 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 So basically, one case we had, sir, we gave, but the surgeons were not happy with it. They said whether you give less than 5 or more than 5, we will take it high grade only. High grade only. So yeah, because but what I suggest you all is whenever you are giving something new or which is updated, try to give the reference also. Okay, you can just write a comment that this is a new thing which has come in the WHO 5th edition, like that, and try to communicate with your clinician that this is the thing. So I tried, but they were not convinced. That is the truth. So flat lesions, the WHO did not include the term hyperplasia or urothelial proliferation of unknown malignant potential, which was previously mentioned in the 3rd and 4th editions. So these lesions corresponding to what were earlier called flat hyperplasia are thought to be benign, so they were not included. What was included was dysplasia and carcinoma in situ. Dysplasia was retained, and because despite problems, but by definition, dysplasia shows changes which are believed to be neoplastic, but they fall short of carcinoma in situ, and carcinoma in situ later being a high-grade lesion. These are the reactive changes. We can say mild enlargement will be there, irregular. It will be there, and however, nuclear contour will be there, maintained, and polarity will be maintained. And dysplasia, definitely there is a, it will be almost a flat lesion with this loss of polarity, and atypia will be there. And carcinoma in situ, definitely marked atypia will be there. So sub-chapters like papilloma, inverted papilloma were included. And papillomas, again, very rare. Luckily we got one case, and this was our case. And you will see these exophytic papillary structures with minimal branching will be there, and urothelium will be normal thickness. Another one of our case, urothelial inverted papilloma, where you will see endophytic growth and overlying epithelium with thin anastomotic uniform trabeculae with peripheral palisading will be there, which will be the key. So what about the subtypes? So So these are the urothelial carcinoma with divergent differentiation, which has squamous, glandular, trophoblastic, or with Mullerian differentiation. Again, variants is more common used for denoting genomic alterations. And these are the subtypes. So lymphoepithelioma like plasmacytoid, giant cell, and likewise. So squamous is very important, and usually when I have seen most of our cases, students also, sometimes me also, we don't search for squamous differentiation. But again, it is a very important thing. You should look for squamous differentiation because it is very common, and it will be seen in the regions where cystosoma is endemic, but in Indian population also we are seeing. And distal third of the urethra is dominated by the squamous epithelium. And these tumor with squamous differentiation are associated with worst cancer-specific survival. And diagnosis is made by the presence of keratinization of these cells. And this usually you cannot differentiate on a biopsy. You cannot differentiate whether it is pure or whether it is differentiation is there. So in biopsy, when you can write possibilities are urothelial carcinoma with squamous differentiation or pure squamous cell carcinoma for the further confirmation on larger specimen. So the variants which are seen are the subtypes which are seen are this verrucous carcinoma and squamous cell papilloma. Again, glandular differentiation and micropapillary pattern, very rare. We got one, and in about 25% cases, HER2 will be positive in micropapillary carcinoma. So you can attempt a HER2 on it, and there you can patient can have that treatment. And then tumor with sarcomatoid differentiation, it is frequently seen admixed with other component, and may vary just from spindle cell to osteosarcoma or chondrosarcoma, etc. And presence of more than one or more heterogeneous components have been suggested to impart a more adverse behavior and associated with poor survival. And tumor with neuroendocrine differentiation, this was one of our case where patient was having multiple biopsies, and it was showing only few spindle cells. Then patient underwent cystectomy. We got the specimen, and we got this morphology, which is very high grade. And then we did more grossing. We got those spindle cells also. So we didn't know what to name this: sarcomatoid carcinoma with neuroendocrine differentiation, neuroendocrine with sarcomatoid differentiation, or what. So then we tried to look at the slides again and gross it. Then we found urothelial carcinoma also, which was positive with the ISC. So we gave it a urothelial carcinoma with divergent differentiation. So again, the new entry is diverticular carcinoma. It is located in the diverticulum in the urinary tract, and common location are the lateral urinary bladder walls and close to the ureteric orifice and the dome. The prognostic significance of these tumors compared to is under debate because it's very rare. So again, in this you will see glandular differentiation with this hypertrophic muscularis nucleus layer. Here you can see. Other one is the litter gland adenocarcinoma of urethra, and it is tumor originating in the periurethral glands of the penile urethra. Diagnosis of exclusion actually. And tubopapillary architecture will be there with atypical gland composed of columnar mucinous cells. Another one is the skin gland adenocarcinoma of urethra, and it is a malignant tumor arising from the female urethral accessory glands. These are very rare tumors, but you should know these are the newer entities and how they look. And copper gland adenocarcinoma. It's also tumor of the periurethral bulbomembranous glands, and where you can see a MIB NFI fusion. So another algorithm has come. So don't you see any peculiarity between bladder tumors and the tumors from the other organs? Other organs, when we call carcinoma? When it is invasive. Otherwise, you don't take into it. But bladder, you are saying low grade, high grade, non-invasive. I don't know. Like this. Okay. So great problem is also there. In 70s, it was three tier, grade 1, grade 2, grade 3 papilloma. And then again, it was in 2004, it was those grade 1 was few were gone to Pallam, few went to low grade, and then, but I don't know. So few of the experts says that if we bada hai to behtar hai. So if we can mix it and we can make a classification, because in my practice, I see many G2 tumors, which I don't want to call it low grade. I don't want to call it high grade. I see. Is the problem you are having? Yes. So I don't know. Maybe again, same thing which I told you in the morning, that we have to look into our cases, go back and do the study, and then we can come up with this new classification. There are many papers on this, but again, we have to see how far it goes. So this is the final impression you will give, what we get URBT for the superficial and deep. So, and for reporting, always mention muscularis propria is identified and free or not identified. Even if it is not identified, mention it. You have to mention it for two reasons. One is for the staging. Another thing is for the completeness of the procedure, whether the surgeon has done a superficial biopsy or done a deep biopsy. So always mention this muscularis propria. And same for the non-invasive and invasive cases. Okay. ISC overview. So again, ISC, don't just, it is, if you don't ask the correct question, you will not get the correct answer. If you blindly throw ISC on your HNE slides, you will not get the answer. Only it should be supportive. For low grade, I want to differentiate from high grade. I want to do something. No, it's not like that. So that is why and do not interpret ISC findings. Always interpret in correlation with clinical, radiological, and morphological in cases of metastasis, when tumor has come from cervix or tumor has come from the colon. And do not use a single marker in isolation. Try to use a panel of ISCs, and must be used with knowledge, with sensitivity and specificity of marker. Like, what are the common ISC you do in bladder tumors? CK7, CK20, P63. Do you know the sensitivity and specificity of these? CK7, CK20, which we use very commonly. They are very less sensitive. 75%, 25%, like that. So again, this is one of our case, and this we had. This is the specimen we got was a radical cystectomy specimen along with the uterus, and there was a mass at the cervix, and this is how it looked. It looks very poorly differentiated, and we did the panel of ISC of GATA. GATA was I think picture C, which is negative, and then P63 is also scatteredly few cells are positive. 7 was negative, 20 was negative. So again, we added, because mass was in the cervix, so we added a P16, which was very much positive in the last image. So this was a primary squamous cell carcinoma of vaginal vault, contagious spread to the bladder. Again, this was again a urothelial carcinoma going spread from bladder to the rectum. So as you can see that colonic mucosa is there, and these tumor cells are going, and which are positive for P63 and GATA also. So again, this is this one paper which was published 10 years before, but I think it still holds good. So best practice recommendation by ICEP, and it recommends these markers. We have done one study from primary DNB where we have seen in the expression of GATA in all the grades of urothelial carcinoma, and another study where we used GATA in poorly differentiated. Both are published in IJSO and JCRT. So after ISC molecular, where to go? So why we need molecular classification when already we are breaking our head in low grade, high grade, panlam? So based on this is just based, the traditional classification is based on grade and stage only, muscle invasive, non-muscle invasive, but it cannot fully reflect the intrinsic characteristic of bladder carcinomas and cannot accurately predict risk of recurrence or progression into a invasive malignancy. So this it does the traditional classification, and this it does not do. So why we need a molecular classification? Because tumors with similar pathology exhibit different biological behaviors. Okay, and some high risk patients do not respond to BCG, while others are sensitive to BCG. And after radical cystectomy, only some muscle invasive show benefit to the neoadjuvant chemotherapy. So this classification, molecular classification, how it helps us to understand the bladder cancer biology, specific genomic alteration enriched in particular molecular subtypes, and response of chemotherapy and immunotherapy enriched in a specific molecular subtypes for a precise patient stratification, and because of the targeted therapy and all, according to the prognosis and therapeutic options. So what is the basic method to do it? So there are two broad approach. One is global gene expression analysis and the pathway specific analysis. And these detect gene expressions in tumor tissue by DNA microarray, RNA sequencing, and other methods. And they also perform cluster analysis of different, we'll see that also, gene based on gene expression levels, and coupled with the statistical testing, and further divide tumor into several molecular subtypes which reflect the intrinsic and the clinical characteristics. So these are the genetic alteration are very known to these bladder tumors, and the most relevant genetic alteration are the CDKN2 and the FGFR3 and PIK3CA and ERB2. So this is the molecular workup has been going on from long time, from 2003 to 2020, and finally WHO has also accepted the this molecular classification. This is there in the 5th edition, and where six independent muscle invasive classification systems has been identified into 6 molecular clusters, which are luminal, are based on papillary, non-specific or unstable, stroma rich, and basal squamous or neuroendocrine like. The neuroendocrine like and basal squamous and luminal have a worse prognosis. These 3 have the worst prognosis. And how they are classified? Basically, if you do an ISC, so Uroplakin 2 or keratin 20, CK20 or GATA3 is usually positive in luminal type, and basal type keratin 4, 5 and 6 and 14, those are positive, and double or negative or these neuroendocrine like are negative for all these molecules. So again, what was the rationale of this luminal and basal squamous? Was they show different type of mutations, like luminal papillary shows FGFR3 mutation fusions, and they are low risk, and they respond to the neoadjuvant chemotherapy. Whether luminal infiltrative type have a PD-L1, the immunotherapy is more helpful in that one, but an unstable one is unresponsive to most of the therapies, but still some platinum-based chemotherapy or PD-L1 can be there. And the basal squamous again is more on immunotherapy and cisplatin-based chemotherapy. Again, neural type will be responding to the etoposide and cisplatin-based chemotherapy. So again, we were talking about that cluster analysis also. It will divide into cluster 1 and 2. Again, cluster 1 is mostly luminal and will show the same treatment and prognosis, and basal squamous and all, they will show a poorer compared to that other one. This is the same showing the same clusters. So again, yeah, these by nanostring analysis also they have same category they have given luminal, basal, and null or double negative type. Again, luminal tumor are non-muscle invasive bladder tumors, and they are papillary morphology, urothelial morphology is there, and they are low PD-L1 expression is there, and they are favorable bladder related survival is there. Whereas negative or the basal type have higher frequency of muscle invasive, and they have high PD-L1 expression and worst bladder cancer related mortality. So these are the therapeutic targets you should also know, because again, like HER2 is there and immune checkpoint are there. We can do those markers in our lab. And a plethora of novel prognostic and predictive biomarkers are rapidly emerging. And many things are there, like long RNA, microRNA, epigenetic changes, and proteomic signatures or immune microenvironment are seen. And many of these markers are being investigated in blood and urine sample for assessing the circulating protein and RNA. And NCCN recommends that molecular and genomic testing to be conducted early, ideally at the diagnosis of advanced, whenever there is advanced bladder tumor where patient has metastasis or locally advanced, to facilitate treatment diagnosis and prevent delay in the administration. And the panel recommend molecular and genomic testing to perform in the stage 4A and 4B tumors, and can be considered in stage 3 tumors also. And molecular testing for FGFR3 and 2 genetic alteration is recommended by the NCCN. A few cases. So this is a 55-year-old male, radical cystectomy specimen post NSAT we got, and there was a residual high-grade papillary urothelial carcinoma, P and P3A, means only microscopic the tumor was going into the fat, perivesical fat, and N1. So this was the morphology where you can see papillae and NS are there. Again, it was positive for GATA, but it was negative for CK57. So what do you want to call it? Basal, luminal, luminal. Another 71-year-old male, radical system. This was the case which I told you before, where we got a residual invasive with the predominant neuroendocrine and sarcomatoid differentiation. And it was stage 2B, N1. And this was the different components. You can see the squamous and you can see the high-grade this neuroendocrine, this one maintenance positive in both the component. And it was negative for all these markers, and then it was null or negative. Okay. So what are the points to take away? So clinical details are very important. Before reporting a bladder tumor, you need to have the clinical details of any prior treatment. What is the location of the tumor? What is the size of the tumor? Extent of the tumor in gross only you have to tell, whether, because that is in the staging. If grossly the tumor is going into the perivesical fat, 3B, and then presence and extent of adjacent carcinoma in situ is very important. We usually avoid it, don't see it. If we get it only, then only we report. But don't do like that. Try to find is there any carcinoma in situ, because patient is prognosis becomes poor and patient will go for some aggressive treatment also. LVI is very important in small biopsies also. In TURBT, if you are getting an LVI, kindly mention it. If you're not getting, you can do it. And molecular subtyping is not without its limitation. Much work is still needed to establish the utility of molecular subtyping and its application in routine practice. And in future, these classification will be complementary to the traditional pathological classifications. These are my references. Thank you.
Thank you, Vishal sir. Your feast on urinary bladder cancer was more than enough, that I feel. But it's a scenario. So now the forum is open for the questionnaire and queries. Sir, I have one query.
Yeah. Okay.
First of all, how many percent of squamous cell carcinoma you have seen in your practice?
It is, I will say in language of Ackerman, not very uncommon. Because means we see it once in a while.
Okay.
So what is your experience? Quite a few. So I will say, we will not say it is rare, but we see.
So what are the predisposing factors that I should keep in my mind? Okay, agar case aata, then I should, oh sir, that given these guidelines, we should keep in mind, ye ho sakta hai, ye ho sakta hai. That's why I am asking. So it's very rare. I have not seen. Yeah. I have not seen in my practice.
Yeah. Usually, what we get in my place, we have seen that extensive squamous differentiation is there. So then I'll give as possibilities of pure squamous or urothelial with squamous differentiation.
Okay.
Needs further confirmation on larger space. So that is the best thing you can give, because you don't know, because this is just a biopsy.
Okay.
Maybe
Okay.
just that part only.
I mean, sir, I'm asking for the predisposing factors. Something in Indian population that, as we know, the schistosomiasis is not common in India.
Common in
Huh.
India.
So anything else
Because
that you have seen,
yeah,
you are
because
a
I work in a
neuropathologist.
cancer hospital.
Okay, sir.
That is blessing in disguise
Hmm.
because patient come very late to us.
Okay.
So we don't have any predisposing. We
Okay,
get very bad. Yes, sir.
Excuse me, sir.
So
So
it,
UTI,
yes.
recurrent UTIs, patient who's catheterized for long, say neurogenic patient who has got paraplegia, who's lying on bed for a long time with a
That's something new, sir. That is known to everyone. That they irritate the mucosa, then it leads to metaplasia, then finally it causes the squamous cell carcinoma.
These are the predisposing.
Okay,
Lesion-
something new, something, sir. Is
lesion near the
I want to know something new that I don't know.
no, ma'am. No update on that. ma'am.
Okay, sir. Okay, thank you. Thank you.
And location also near the trigone.
Okay, okay.
Those lesions if are there.
Okay.
Predisposing won't be there in India because even if they are there, they won't tell us.
Yes,
You know,
that's
they
the
have taken
reason.
full
That's the reason.
chemotherapy and
Ha,
no tumor. There are tumor changes, but he's saying I have not taken anything.
I think the worrisome feature is a pure squamous carcinoma. When you have a lot of urothelial with squamous differentiation, there is no cutoff. So do we call it 10% squamous or 20% squamous or 50% squamous, which they don't behave very differently from a urothelial, but it's a pure squamous.
It's very rare. sir.
Etiologically probably different, which is likely to be muscle invasive at completion. So the clinician is worried when you say something pure squamous, you are probably implying that this is a muscle invasive tumor. It needs a radical cystectomy and not a BCG. And that's,
Of course,
that's the question of very.
There.
Excuse me, sir.
Any question here from anyone, please?
Sir, can you hear me?
One more point.
Yes, sir.
In the IHC, we obviously, Vishal, we don't use IHC routinely. We don't
Yeah.
use GATA 3 and 20 and all every urothelial case.
Yeah.
The very important point where we use IHC in bladder cancer is when it's a poorly differentiated tumor. We need to absolutely make sure it's not a prostate cancer. The prostate cancer treatment is poles apart. So the bladder treatment is North Pole, the prostate cancer is South Pole, that means. So that is absolutely a indication to use a large panel of IHC so that you don't miss out on a prostate cancer. If you have a proper papillary tumor which looks urothelial, there is no need. Generally, we don't do GATA 3s and all this. But if you have a very high grade cancer, it's a bladder tumor, you have to make sure it's not a prostate cancer. That's the absolute necessity of using it.
Complicating this scenario, sir, more, we have few cases where tumor is there in the bladder and the prostate, and morphology is poorly differentiated, and all the ICs are negative. CK7 is negative, 20 is negative, GATA is negative, PSA is negative, MCR negative. And a few other markers I did, but I didn't tell.
720 negative is very, very unlikely to be urothelial actually.
Yes.
720 negative points towards a prostate. Actually.
Prostate, yes.
See, you wouldn't have certain other pointers, probably a PSA level or something. But obviously, if none of the markers come, you are in a major.
Yes,
generally, something would come like an NKX 3.1 or a PSA
Yes.
or a serum PSA, which has been serially done and has shown some reason.
Mhm.
Maybe it's a totally neuroendocrine phenotype. Then
Yes.
you don't know where it is coming from. That can happen.
So in that case, when CK720 are negative, the pointer is towards prostate. And again, you have to go for the clinical parameters, PSA level as sir told. So like that. Any comments from sir? Seniors, please.
Characteristic of a parasitic carcinoma.
You are talking like my clinicians in MDT. We'll wait for metastasis.
Otherwise, as you said, there's no way of differentiating when it is both.
Yes. We face not that I will not say very uncommon, but very rarely. 2-3 cases we have faced where all the markers are negative. So we discussed this case with Dr. Epstein also at that time. So he said a negative, same thing, a negative will. And PSA level is again a very headache, granulomatous inflammation also, it is like 30 and clinician is not willing to accept that thing from us like that. Which one? Corpus. Very, the location. Yeah. Yes, yes, yes. But again, we have to see where is the location of the tumor morphology, how it is there. Tumors at the verumontanum, we have discussed, very papillary and different morphology. It will, morphology will be same, but I said in those cases. Only I think location and morphology we can use at that time. Yeah. Then GOK you have to say. God only knows. Now, if you know, then you will give that diagnosis. That is the problem.
What instructions generally you give the technicians while embedding? Because many times the problem is orientation of the sample, very small biopsies. The flat embedding will lead to missing the invasion if it is properly embedded.
The routine.
Routinely, there is
Yeah.
how to identify the surface actually, because it is a small biopsy.
We don't have, I think the PG, the fellows.
I think they should
they should answer it. Now they are. Yes.
TRBT is multiple
bits. Usually we are not facing that problem. Only problem we are facing is they are submitting entirely and giving 10 slides repeatedly by saying.
General tip is to submit the first 10 grams of a TRBT. Completely submitted. For next every 5 grams, you use one cassette. But if on microscopy you find it's a high-grade cancer, it's a high-grade urothelium, you have to go and embed the whole thing. Because you can't miss out on muscle invasion and such. You have to go back and embed the whole sample if it's a high-grade. If initial 10-15 sections show very low-grade tumor, you can leave away and not submit the test.
In the CAP, they can find these guidelines are there. Yes. How to embed, you can find it in the CAP guidelines.
CAP, RCPath,
all data sets, Australian and all. Any whichever you are following, it will be given 12 grams and 5 grams for the TERP also, for this also, TRBT also. Okay, I think.
Once again, we thank you for taking your time to share your expertise with us, sir. Now, I would like to call upon our chairperson to honor our speaker as a token of gratitude for his contribution. Thank you, sir, and thank you, ma'am. Now I request Dr. Pungodi, ma'am, Assistant Professor, Department of Pathology, AIIMS, Mangalagiri, to felicitate the chairperson. Thank you, ma'am. Next, we move on to the session on the topic recent diagnostic and molecular updates in endometrial carcinoma. I'm honored to invite our chairperson, Dr. G. Neelima, ma'am, Associate Professor, Department of Pathology, ACSR Government Medical College, Nellore, Andhra Pradesh. Ma'am has more than 13 publications in national and international journals. Her area of interest is bone pathology. Welcome to the stage, ma'am. I request ma'am to take over the session and introduce about the speaker. Thank you, ma'am.
Yeah, good afternoon. Thank you for the introduction. Now I take the privilege and honor to introduce Dr. Rachna Kera ma'am. She's the consultant histopathologist. She's presently affiliated at Liverpool Clinical Laboratories, Liverpool University Hospitals, NHS Foundation Trust, UK. Ma'am has many awards. She's awarded by the DJ Reddy Gold Medal for outstanding performance in MD pathology examination by Pondicherry University. And she's also awarded many awards for her paper presentations. She has over 25 publications, and her special interest is in high-grade ambiguous endometrial carcinoma and high-grade ovarian cancers. She's a member of core member of multidisciplinary team meetings at Gynec Oncology at Liverpool University Hospitals, and she's an active member of the British Society of Gynec Pathologists. We welcome you, ma'am, for your presentation.
Okay. Request Dr. Rachna Kera ma'am to share the screen of the PPT.
Hello, everyone. Just give me a minute when I try to share my screen.
Ma'am, your voice is not audible, ma'am.
Is it audible now?
Yes, ma'am.
Can you see my screen now? Is it okay? Audio and video. Can you see the slideshow?
Yes, ma'am.
All right. So good afternoon, everyone. At the very outset, I would like to thank the organizers for this wonderful opportunity to speak in front of you all today on this very important and exciting topic in gynae pathology, recent diagnostic and molecular updates in endometrial carcinoma. And now, of course, this is a huge topic, as there have been tremendous advancement in the field over the last decade. So what I hope to do today is to take you through some key areas.
Interrupt. Sorry to interrupt, ma'am. Ma'am, can you make it full screen?
That's what I asked. You are not able to. Can you see now the slideshow?
Yes, ma'am. Thank you.
Okay, sorry. So, so without further ado, let's start the presentation. Today we'll be, in the next 40 minutes or so, we will be learning about updated WHO classification of endometrial cancer, what has changed in 2020. We'll learn about TCGA groups and molecular subtyping of endometrial cancer, including molecular testing tools available for this. Next, we'll be talking about some new tumor types incorporated at the WHO for the first time and additional nuanced information on already existing histotypes. And lastly, we will briefly touch upon FIGO staging system, which came out earlier this year. So the first subtype classification of endometrial cancer distinguished between type 1 and type 2 as proposed by Dr. Bachman based on clinical and hormonal features. Endometrioid was the prototype for type 1 and serous being prototype for type 2. Although this classification was really interesting from educational and epidemiological purposes, this was not helpful for risk stratification and did not reflect tumor biology, as there are significant overlap on clinical, pathological, and molecular levels. So today, endometrial cancer is classified based on WHO system into various subtypes, endometrioid, serous, clear cell, to name a few common ones. So what has changed in 2020? The most significant change that has happened is the introduction of these 4 molecular subtypes, namely poly ultramutated, MMR deficient, P53 mutant, and no specific molecular profile group. Carcinosarcoma has been recategorized as a pure epithelial malignancy instead of a mixed epithelial mesenchymal tumor that it used to be. Some new tumor types have been introduced, they are mucinous carcinoma of gastric and gastrointestinal type, mesonephric and mesonephric-like adenocarcinoma, and squamous cell carcinoma, NOS. Now, we know squamous cell carcinoma is not a new entity, is rather well established, but it was inadvertently removed from 2014 classification and has been included here again. Mucinous carcinoma is no longer a separate entity and is included with endometrioid type now, irrespective of extent of mucinous differentiation. So let's dig into molecular classification of endometrial cancer. First of all, why do we need molecular classification? Because our current histology-based classification system has some limitation. First of all, it has very little to offer in the way of risk stratification, and is further hampered by significant inter-observer variability. The 2 papers I've quoted here have nicely demonstrated that a consensus among even expert gynae pathologists is at best only 60%, especially in high-grade endometrial carcinomas. So all this leads to inconsistent categorization of endometrial cancer that not only impacts adjuvant treatment, but also clinical trial heterogeneity. So clearly there is a need for molecular tools to aid in accurate and reproducible diagnosis of endometrial cancer. So around 2012, 2013, there was an explosion of articles looking at mutation profile and molecular pathology of endometrial carcinoma. But the hallmark study came out in 2013 was by the Cancer Genome Atlas Network that performed a comprehensive genomic analysis on over 300 endometrial carcinomas and grouped them into 4 main categories that appear to have prognostic and therapeutic significance. The first division in TCGA was to look at somatic copy number alterations. It was found that cases with very few additional chromosomes did very well. Those that began to accumulate few more fell into intermediate categories, and those the ones which had very high copy number alteration had really poor outcome. Now, I know this is a very busy slide, but I think there is important information to draw from this. So upper panel here shows you the TCGA groups as identified as a result of analysis. They were poly ultramutated, MSI hypermutated, copy number low endometrioid, and copy number high serous line. Now, if you look at first group here, poly ultramutated, characterization in these 4 groups was based on mutational burden and presence of some mutations like poly, P10, and P53, and histology and tumor grade was also taken into account. So if we look at first group here, which is poly ultramutated, it was characterized by high tumor mutational burden and very high number of poly mutations. It had some other mutations, P10, like P10, but less likely to have P53 mutations as well. Most of this tumor had endometrioid histology, and they were often high grade. And if you look at last group here, which is copy number high, serous-like, they were characterized by prevalent P53 mutations. They were almost all high grade and had serous histology. Other two groups, MSI hypermutated, was characterized by high mutational burden, but not as high as we saw in poly ultra mutated. And the other group, copy number low, had very low mutational burden. So I'll draw your attention to another thing here, the panel C, which shows that the group, which was very novel finding in this analysis, poly ultra mutated group, was demonstrated to show significantly better progression-free survival, and copy number high, serous-like, had bad outcome. Now, TCGA used quite high-end genomic methodology, which of course is not feasible to use in clinical settings. So following discovery of those 4 molecular subtypes, proactive molecular risk classifier for endometrial cancer, abbreviated as PROMISE, it was developed and validated for clinical use to replicate TCGA classification in clinical practice. This uses combination of targeted sequence for pathogenic polymutation and immunohistochemistry for MMR and P53 status to assign endometrial cancer to one of the 4 molecular subtypes. They are not identical, but very similar to TCGA groups and are called polymutant, MMR deficient, P53 abnormal, and no specific molecular profile groups. And these are the names you will find in your new WHO Blue Book. And now this molecular classification has been shown to be highly reproducible. That is why WHO 2020 5th edition recommends integration of these molecular classes into your standard carcinoma reporting. But the problem is around 3 to 5% of all endometrial cancer will show more than one of these abnormalities. So it's really important to interpret them in a particular way. And this algorithm suggests how we should interpret these tests. First test is poly. If you get pathogenic variant in poly gene, then tumor is classified as polymutant endometrial cancer. If poly is wild type or shows known pathogenic variant, the next thing to look at is MMR status. If MMR is deficient, tumor is classified as MMR deficient endometrial cancer. If it is proficient, then P53 status will decide whether the tumor will be classified as P53 mutant group or no specific molecular profile, the group which is the diagnosis of exclusion when you have excluded all the 3 abnormalities. So TCGA clusters can be replicated in clinical practice using just 3 tests, immunohistochemistry for MMR, P53, and poly sequencing, which is at the moment is done by Sanger sequencing or next generation sequencing. So because of stronger prognostic significance of these molecular subtypes, these have now been included in updated European guidelines for management of patients with endometrial carcinoma. So what we are interested in this slide is the right side of this table here, which shows if molecular classification is known, then the prognostic groups are a little bit different from when they are known, rather significantly different. So if the group assigned according to molecular classification is either MMR deficient or no specific molecular profile, further stratification is still based on our conventional parameters, histotype, grade, stage, and LVSI. And if you have a P53 abnormal tumor, they are all high risk except for very rare stage 1A tumor without myoinvasion. And polymutant cancer, if they are stage 1 and 2, they are classified as low risk prognostic group. So let's dig a little bit deeper into molecular testing tools, starting with poly. So first of all, what is poly? Poly is a gene that encodes a subunit of DNA polymerase epsilon, which has a role in proofreading newly synthesized DNA. It removes errors essentially as they are introduced into the new strand. So if there is a problem with poly gene, there is loss of polymerase epsilon function. That means lots and lots of errors will be accumulated across the genome, and this will lead to heavily mutated genome and thus cancer predisposition. So now the question is, how do you inactivate poly? I'm sure we all know the answer is mutations. We also know as variants. So in clinical practice, there is a very small number of variants known to knock out function of poly gene, and those are the ones we are interested in. So endometrial cancer with any of these 11 variants mentioned in this table should be classified as polymute cancer. About 2/3 of all polymute cancer will show either of these two mutations, and about 80% will show one of the top 5 variants highlighted in bold here. So polymutated cancer in general account for 5 to 10% of endometrial cancer, really depends on the series you're looking at. In TCG analysis, they constituted about 7% of the cohort. There appears to be no significant association with histological subtypes, but on the whole, the polymutated cancer look high grade, but they are shown to have indolent behavior. So this is important. Why? Because if the tumor looks bad histologically, historically they are regarded as high-grade tumors which require extra treatment. But paradoxically, now we know that if your endometrial cancer shows adverse histological feature, that means if they look bad but are demonstrated to show pathogenic polyvariant, they are likely to have indolent behavior, and therefore adjuvant treatment may be omitted. So huge management impact there. So things are not always that easy. And that's the case with poly, because cost and access to poly testing currently presents the major challenge. So BAGP and BGCS have laid down a very comprehensive guidance on poly testing. And there's a nice flow chart available on the website. I think it's open to all and anyone can refer to this. So according to this, it is recommended to test your biopsies irrespective of histological subtype with MMR, with immunohistochemistry for MMR, P53, and ER. If either or both of MMR and P53 are abnormal, then poly-NGS testing is recommended on biopsies. After surgical staging, patients are divided into 3 groups, and the group where it is recommended is the one here, group 3, which comprises of stage 1 and 2 non-endometrioid tumors, grade 3 endometrioid, stage 1A with no or focal LVSI, or any grade endometrioid which show any of these 3 features, ER negative, stage 1A with substantial LVSI, and 1B and 2 stage 2 tumors. This group is selected for poly-NGS testing because based on one or the other factor, adjuvant treatment may be considered in these, and knowing poly-mutant status will alter management. So let's look at a case now. These are photomicrograph of endometrial tumor, which is quite solid looking, but has heterogeneous appearance in different fields. So it's quite solid looking in upper panel here, have abundant eosinophilic cytoplasm, high grade looking nuclei with prominent nucleoli. And the other field here, lower left, shows quite hyperchromatic blue look with easily identifiable mitotic figures and areas of necrosis evident here. Elsewhere, tumor had very focal glandular morphology and some mitotic figure, I'm sure you can spot. So this was regarded histologically to be a tumor, high-grade endometrial tumor, which was ambiguous subtype, and immunohistochemistry was carried out, which showed diffuse and strong expression of ER. This is immunohistochemistry for MMR proteins, which we will deal with later in the presentation. But for the purpose of this case, it shows intact expression of all 4 proteins. So a tumor is regarded as MMR proficient. P53 shows most of the tumor showed on the left side here, wild type expression as we interpret this, with some foci showing increased nuclear expression. So based on this pattern of P53 abnormal expression, poly testing was sent for this case, and lo and behold, poly was detected. So ambiguous histotype, molecular subtype, polymutated endometrial cancer. On surgical staging, FIGO stage 2 was assigned to this case. Now, if we go back to the table I flashed a little bit earlier in the presentation, now if we did not know molecular classification of this tumor, this tumor will be assigned a high intermediate prognostic risk group. But now we know this is a stage 2 polymute cancer. The prognostic group changes to low risk, and adjuvant treatment may be omitted in this patient. So again, huge impact on management decision. Next, let's move on to MMR testing. So first of all, what is mismatch repair system? Now, I've already mentioned when DNA is replicated, some errors will happen, and that's a normal thing to happen. So one of those errors is called DNA mismatch. Normally, if you see C binds with a G and T with an A, but here instead of having a G, we have an A. So this is called DNA mismatch. Fortunately, we have a system called mismatch repair system, which corrects errors as they occur. So it's comprised of a large number of protein, and the ones we are interested from clinical point of view are MLH1, PMS2, MSH2, and MSH6. Both of these form these units to function. So when MMR is functional, these errors will be corrected as they occur. But when there is a loss of function of any one of MMR protein, this results in heavily mutated genome and cancer predisposition, just like polymute cancers. So luckily, we have immunohistochemistry to assess the status of this MMR system. So this is how a normal MMR protein expression looks like. In the tumor, it is characterized by strong and diffuse expression, compared to the background stromal cells, which show relatively weak expression. So when MMR system is not functional, it is reflected as loss of expression of those proteins. Always pay due regard to your internal control here, because stromal cells are positive and the tumor cells are showing loss of expression. So internal control is really important while we assess MMR protein expression. So when all 4 proteins tested show intact expression, that means the tumor is MMR proficient and there is no immunohistochemical evidence of deficiency. If it is abnormal, then you can get some combination. And first and easier of those scenarios is loss of MLH1 and PMS2. This pattern is likely to be sporadic, but can also be due to Lynch syndrome. The further clarification is done by testing for MLH1 promoter hypermethylation, which is, if returns positive, then tumor is almost always sporadic. The other combinations are loss of MSH2 and MSH6, isolated loss of MSH6 or PMS2, and the combination we just saw, loss of MLH1, PMS2, but without promoter hypermethylation. These patterns are associated with Lynch and related syndrome, and patients should be referred to clinical genetic services. Important to know that less than 50% of these will turn out to be Lynch, but remainder are still sporadic. This brings us to our case 2. This is a photomicrograph from an endometrial tumor. I'm sure you can appreciate very crowded glands here with back-to-back arrangement, complete stromal exclusion, and some cribri forming as well. Just a little bit attention to scanty stroma present here. It is showing increased tumor infiltrating lymphocyte. So the first clue may be because sometimes you see these tumor infiltrating lymphocytes in your MMR deficient tumor. So histotype endometrioid, of course, and MMR IHC revealed loss of MLH1 and PMS2 expression. Internal control always pay due regard is positive and tumor cells are negative. So loss of MLH1 and PMS2, but intact expression of MSH2 and MSH6. Hypermethylation was sent and which came back as positive, so likely sporadic. Additionally, ER was positive in this tumor, P53 was wild type, and no polymutation was detected. So tumor is classified as MMR deficient endometrial cancer according to molecular classification. Why we are interested in this category, there are three reasons. One, because endometrial cancer is more usually the first and sentinel cancer in Lynch syndrome. So it provides opportunity for screening in a particular family so that surveillance and appropriate preventive measures can be taken to avoid development of more nasty tumors like colorectal. Secondly, now we know that it is advised to do molecular classification of endometrial cancer. So this particular category has great prognostic implications, and all MMR deficient tumor of all size are now eligible for immune checkpoint inhibitor therapy. So very important to pick up this category in routine practice. So let's talk about P53 immunohistochemistry now. It's very important to be aware of various patterns of normal and abnormal expression of P53 staining. This is how a normal wild type, as we interpret these, they look like. Nuclear staining ranges from a few positive cells to almost all cell staining, but with variable intensity. If it is abnormal, you can see three patterns. The first and most common of these is overexpression, which is defined as strong nuclear staining in at least 80% of tumor cell nuclei. Usually you'll find 100% tumor nuclei staining, but 80% cutoff has been set to account for technical artifacts and rare mosaic pattern, which you may encounter. The lesser common pattern is complete absence or null pattern. It's defined as no staining in tumor cell nuclei in the presence of wild type staining in normal background, that is intrinsic control. Always pay attention to that while interpreting this pattern. The least common pattern is abnormal cytoplasmic pattern, which is defined as predominantly cytoplasmic staining in the absence of strong nuclear staining in more than 80% of tumor cell nuclei. It means nuclear staining can be absent or weak, but never strong, as you see in overexpression pattern. So with that, let's have a look at case 3. So I'm sure you can appreciate the predominantly papillary pattern of this tumor with areas of necrosis, cell exfoliation here within the lumen, and tumor nuclei look high grade. I'm not sure if you can appreciate mitotic figures, but there were very increased mitotic activity in this tumor. So clearly high-grade papillary pattern, I'm sure it's the easiest group, I think, to pick up. So immunohistochemistry, ER, very focal and weak. P53 shows most common pattern of aberrant expression, that is overexpression, and MMR proficient. Poly testing was sent, but no mutation detected. So P53 abnormality assigns this tumor into P53 abnormal tumor and serous histotype, as we saw on H&E. So it has important treatment implication because P53 abnormal serous like endometrial cancer are chemoresponsive, and HER2 positivity it was identified in TCGA cohort, and this is being looked at as being potential for targeted therapy in future. And this category usually requires combination therapies, including immune checkpoint inhibitors. So with that, while we are at it, let's look at case 4. This is a MyoSure excision specimen showing you fragments of endomyometrium. At this part, I'm sure you can appreciate the glands look very crowded. And if we go to high part, they indeed are back-to-back arrangement. There is fusion of glands with possible cribriforming. So, but quite low-grade looking nuclei. Immunohistochemistry shows intact expression of all 4 MMR proteins. ER was strong and diffuse throughout the tumor. P53 shows wild type and poly, no mutation was detected. So the group, which is diagnosis of exclusion after we have excluded all 3 abnormalities, poly mutation, MMR deficiency, and P53 abnormalities, endometrioid histotype and molecular subtype, no specific molecular profile. Now, this group again it's the largest group, even in TCGA cohort. Otherwise, this is the largest group of endometrioid cancer and very heterogeneous, comprising of cases with intermediate to excellent prognosis. Further, as we understand better. Hello, can you hear me? As we understand this class better, further molecular classes are likely to emerge. For now, histotype and grade remain prognostically important, and they are most likely to respond to hormonal treatment. And this is a nice table from WHO Blue Book summarizing key features of all 4 molecular subtypes. I'm not going to go into the details of this because we have discussed them in just the slides we went through. So, but a good one for you to go back and read from your WHO. So this concludes molecular subtyping of endometrial cancers. Before we dive into the new entities, let's quickly go through already known histotypes and if subtle changes, if any, introduced in new edition. So majority of endometrial cancer, we know, are comprised of these endometrioid carcinomas. Diagnostic morphological criteria remain the same, and so is grading. FIGO grading is still based on assessment of architecture, less than solid component, less than 5, 6 to 50, and more than 50% defining grade 1, 2, and 3. Now, sometimes this kind of pattern where it's micro-SNR, confluent arrangement, it sometimes causes problem in the grading. And I think pathologists differ in considering whether this presents a glandular architecture or solid one. So now, based on ISCHIP recommendation, that is International Society of Gynepathology, WHO also endorses interpretation of these confluent micro-SNR arrangement as solid architecture. Furthermore, binary grading is recommended, where grade 1 or 2 constituting low-grade endometrioid and grade 3 constituting high-grade endometrioid. Further, this particular peculiar pattern of invasion has been recognized and correlation with LVSI has been demonstrated. So important one to identify under the microscope. On low magnification, this is identified by fibroinflammatory response and fibromyxoid stroma around them. And if you go to high power, you can see characteristic microcystic elongated and fragmented glands. Further, for distinction between focal and extensive LVSI, a cutoff of 5 vessel has been suggested because it has been shown to correlate with risk of metastasis and guides clinical management. Guidance to aid the conundrum of synchronous ovarian and endometrioid carcinoma has been provided, and it has been advised that if 4 criteria are met, which are both tumors, endometrial and ovarian tumors, are low grade, endometrial tumor shows less than 50% myometrial invasion. There is no involvement of any other site and absence of extensive lymphovascular invasion at any location. So if all these 4 criteria are met, such tumor can be managed as independent low-stage primary tumors of uterus and ovary, because in the literature, in spite of being clonally related, they have been shown to have indolent behavior. Second most common endometrial cancer is serous carcinoma. We all know is characterized by diffuse cytonuclear atypia, high grade. Morphological criteria remain the same, but now we understand them better because they are demonstrated to show P53 mutations and some additional common genomic changes that have come to light in over the last decade are PIK3CA and a couple more mentioned here. About 1/3 of cases show HER2 amplification, as I mentioned before, and this is being looked at as potential target for therapy. With regard to molecular class, all serous carcinoma included in TCGA analysis were classified as copy number high, and we have an immunohistochemical surrogate for P53 mutation, and they almost invariably show aberrant mutation type P53 expression, which we discussed a couple of slides, some slides earlier. Clear cell carcinoma, relatively rare carcinoma. Morphological criteria remain the same. And we know that HNF beta positivity is recognized in these tumor, but in addition, new addition also endorses positive NAPSINA and MCAR to be diagnostically useful. In terms of molecular profile, these tumors are heterogeneous and contain a mixture of TCGA subtypes. Undifferentiated and dedifferentiated carcinomas, they are aggressive histotypes. These two differ from each other by the presence of low grade, mostly grade 1 to 2 endometrioid component in dedifferentiated carcinoma, while undifferentiated is solely composed of solid monotonous looking high grade cells. The only thing I want to emphasize here is these tumors will stain negative for most of the markers you do, like ER, PR, Paxate, E-cadherin. They are typically negative in undifferentiated component. And this negative staining for most marker in conjunction with typical morphology is diagnostically very useful. And another thing to keep in mind in these tumors is they are associated with mismatch repair deficiency in 50 to 75% of cases. So they are MMR deficient in huge number of cases. Regarding mixed carcinoma, new addition endorses that strictly advocates that the two components should be distinct both morphologically as well as immunohistochemically. So to diagnose mixed carcinoma, it's important that you have an ambiguously distinct histotypes. Arbitrary threshold of 5% has been removed, as it is recognized that any percentage of high-grade carcinoma, serous or clear cell, confers a worse prognosis. So if strict criteria are applied, the incidence is very, very low. Carcinosarcoma, I've already alluded to, has been recategorized as pure epithelial malignancy, and nothing else has changed much. Next, move on to talking about new entities. And the first of these is mesonephric and mesonephric-like adenocarcinomas. Now, these carcinomas are very uncommon, constitute around less than 1% of all endometrial carcinomas. Morphologically, immunophenotypically, and molecularly, they are similar to true cervical mesonephric adenocarcinoma, but are not associated with mesonephric remnants. In uterine corpus, now there is ample evidence that they have Mullerian origin. That is why it is best regarded as mesonephric-like adenocarcinoma rather than true mesonephric adenocarcinoma, which is the case in cervix. Once identified, they are regarded as high-grade, and in TCGA molecular classification, most belong to copy number low or no specific molecular profile group. These are characterized by small glands and tubules with luminal eosinophilic colloid-like material, but can also have diverse array of morphology, including papillary, ductal, retiform, solid, and spindle architecture. Nuclei are moderately atypical, often show angulation and overlapping. This is one example here, which shows predominantly tubular and glandular architecture and has eosinophilic colloid-like material within the glandular lumina, and the nuclei show overlapping and at worst moderately atypical, no high-grade atypia. Immunohistochemically, they are usually flat negative for ER and PR and show wild type pattern of P53 expression. They also show typically diffuse GATA3 expression, but variable number of cases showing a staining for TTF1, calretinine, and CD10. GATA3 and TTF1 can sometimes show inverse staining pattern. The same case we saw HNE from. The tumor is flat negative for ER-PR. P53 is wild type. TTF1 is positive and GATA3 showed patchy positivity. So that concludes mesonephric and mesonephric-like adenocarcinoma. Next, let's move on to primary mucinous endometrial cancer of gastric and gastrointestinal type. Before that, just a few points about endometrial mucinous carcinoma according to WHO 2020. So I have mentioned before in the first initial slides that now endometrial cancer with any amount of mucinous differentiation are just termed endometrioid carcinomas. You can say in the comment that tumor exhibits mucinous differentiation. Importantly, they are ER and PR positive, which is the key distinction point from mucinous carcinoma of gastric and gastrointestinal type. So old 50% rule no longer applies. In endometrium, category of mucinous carcinoma is now reserved for gastric, gastrointestinal, and intestinal type carcinomas. Now, this was the first big study of which described endometrial gastric gastrointestinal type mucinous lesion by a group led by Professor Glenn McCluggage. Similar to cervix, they identified spectrum of benign, premalignant, and malignant endometrial mucinous lesions exhibiting gastric and gastrointestinal type morphology. Immunohistochemistry showed positivity for CK7, CEA, MUC6, which was considered to be a good gastric marker probably when it was described, but more we know about this this marker, the more non-specific it looks. So the truth is currently we do not have a good gastric marker, but nonetheless, if you have access to MUC6, it can be used. They are usually, not always, positive for Paxate. CK20 and CDX2 can be positive or negative. And they are typically ER negative, as I have already mentioned. P53 can be mutation type or wild type. P16 is negative or mosaic type. Again, just like mesonephric-like adenocarcinomas, mucinous carcinoma are automatically regarded high grade, even if they show very banal, bland adenoma malignant-like morphology. So just an example here from our archive. This is an endometrial tumor, which at this part, I'm sure you can appreciate, is glandular looking with lots of mucin. Closer look confirms that this is a gland-forming tumor with a lot of extracellular and intracellular mucin as well. Nuclei do not look that bad except for these few scattered large nuclei in this field. They are flat negative for estrogen receptors. That's what it differentiates it from conventional endometrioid carcinomas. Usually positive for CEA, positive for CK7. 20 is patchy positive here in this example. CDX2 is focal positive. I think a sharp demarcation and negativity here is probably related to fixation artifact, but CDX2 is not mandatory, can be positive or negative. Paxate is usually positive, as is the example shown here. P53 in this case shows wild type changes. I've already mentioned can be mutational type as well. So correct recognition of this is very important. Firstly, because to exclude cervical or gastrointestinal tract origin where it is more common. Secondly, they are known to show aggressive clinical behavior and should not be misdiagnosed as low-grade endometrioid carcinoma. And estrogen receptor is your friend there. So this brings us to the last subtopic of today's talk, FIGO staging of endometrial cancer 2023. Now, over the last decade, we have been using FIGO 2009, and this is pretty much it. It's very concise staging. As we used 2009, over the last decade, it revealed some limitations, which were there were insufficient attention to histotype of endometrial cancer. LVSI were nowhere in the staging criteria, and we know they have great prognostic significance. There was no differentiation based on nodal metastasis size in node-positive tumors, and ambiguous staging assignment for patients with synchronous endometrioid tumors of endometrium and ovary. And of course, molecular classification was not there at the time, so wasn't included. So FIGO, an update was well warranted. So experts have sat down and put together this new staging system, which is very comprehensive, and all the limitations I've mentioned have been taken care of. So I'm not going to give you a great deal of this because this is very comprehensive update and you can go through it in your own time. But suffices here to say that the conundrum I explained earlier has been taken care of here, and the low-grade endometrioid carcinoma limited to uterus and ovary have been assigned a stage of their own if the 4 criteria, as we discussed before, are met. Furthermore, aggressive and non-aggressive histological types have been defined and incorporated into staging. Non-aggressive is mostly low-grade, grade 1 to 2 endometrioid cancer, and aggressive includes everything from high-grade endometrioid, serous, clear cell, mucinous, mesonephric, all bad histotypes. So they have been incorporated in the staging now. Furthermore, LVSI also has a bearing on staging, and substages have been introduced, taken into account one or more of these criteria. Micrometastasis and macrometastasis, they have been separated based on size of nodal size of metastasis in nodal positive diseases. Further, when feasible, it has been advised that FIGO staging is changed based on molecular classification. Just like molecular subtyping, I think this new FIGO staging system 2023 has its challenges in widespread implementation, and we suspect the implementation will be really slow because there are challenges in terms of incorporation of molecular subtyping and other criteria as well. So immediately after this staging system came out, BAGP and BGCS in the UK had sent out a survey to all the core members of multidisciplinary team, MDT. And as a result of this survey, the decision has been taken to continue the use of 2009 staging system for now, and it is not recommended to shift to 2023 FIGO staging at the moment. Having said that, molecular subtyping, ER/PR, P53, and MMR immunohistochemistry will be performed on all endometrial cancer and poly testing when required. And cancer alliances have been given responsibility to see how to implement results of molecular testing into MDT practice for both surgical and clinical oncology management. And this decision will be reviewed after 12 months. So to conclude, molecular subtyping is the most fundamental change in endometrial cancer classification. As we have seen, it has huge impacts on therapeutic decision. Important to keep in mind, it is only an adjunct to classical histopathology and not a substitute, and should be incorporated in cancer subtyping, endometrial cancer subtyping, if resources are available. While challenges persist, particularly in regard to execution of pathogenic polymutation tests, it is more likely to be more accessible and clinically actionable in the near future, and there is ongoing work on that. The comprehension of endometrial cancer continues to expand with the integration of molecular classification into FIGO 2023 system. And as we progress, close collaboration between pathologists and clinicians is imperative for effective implementation of these advancements for the benefit of patient outcomes. Thank you very much. I'm happy to take any questions, if any.
Is this, ma'am, can you see this token of appreciation, ma'am?
Thank you. Oh, thank you.
Mhm.
Thank you so much.
Now I request Dr. Josna ma'am, head of the Pathology Department, AIMS Mangalagiri, to felicitate the chairperson. Thank you, ma'am. Dear delegates, since we are running short of time, we are not breaking the session for the tea because the online speakers are in waiting for the next session. So those who are in need are requested to have tea and come back. Certainly, in the next session, we are about to discuss on what is new in melanocytic lesions. For this session, with great pleasure, I would like to invite our chairperson, Dr. T. Aritha ma'am, Additional Professor and HOD, Department of Dermatology, AIMS Mangalagiri. Ma'am has published multiple research articles in various national and international journals. Ma'am has interest over areas such as connective tissue diseases, vasculitis, leprosy, and medical education technology. She is a member of Special Interest Group Pediatric Dermatology, Indian Association of Dermatologists, Venereologists, and Leprologists. Special Interest Group of Dermatology Clinical Research, IADVL. We welcome you, ma'am. Next, I feel privileged to welcome our next chairperson, Dr. Prabhakaran sir, Associate Professor, Department of Dermatology, AIMS Mangalagiri. Sir has various publications in national and international journals. His area of interest are HIV and inpatient dermatology. Welcome to the stage, sir. Now, I request our chairpersons to take over the session and introduce the next enthusiastic speaker. Thank you.
Thank you. It's my privilege to introduce Dr. Rajendra Singh. He is Director of Dermatopathology and Digital Pathology at Summit Health and serves on Salzburger Grand Committee of American Academy of Dermatology. And he's founder of Path Presenter. This is a very famous online digital platform with 50,000 plus users in 170 plus countries across the world. And he has got Lifetime Achievement Award from College of American Pathologists, and he's chief editor of Surgical Pathology Reimagined. And right now he's professor of pathology and dermatology at Northwell and Icahn School of Medicine at Mount Sinai. We welcome you, sir. And
yeah, thank you very much.
Share your screen, sir.
Yeah, I will share my screen. Yeah, can you see my screen? Hello.
Am I audible? Am I audible, sir?
Yeah, I can hear you.
Yes, sir.
Yes.
It is visible, sir.
Thank you very much. So thank you very much to the esteemed organizers for the opportunity to present on this topic, what is new in melanocytic lesions. I'm just going to put this at the bottom. Okay. So I'm going to go ahead and start. My name is Raj Singh. I'm a pathologist. I work in Summit Health in New Jersey as the director of DermPath. I was also part of the WHO editorial board for the skin tumors. This was the last meeting that was held in 2017. The 2022 meeting was not possible to do in person, so the whole meeting with this group happened online. So these are the group of people that actually did a lot of work to get the WHO Blue Book place. A mentor, Dr. Victor Prieto, who is the chair at MD Anderson, and standing with him in the same photograph was a big pleasure, actually. So when we talk about the melanocytic lesions in the WHO Blue Book, the group tried to come up with a new classification that could help direct the therapy and prognosis. They also try to see if we can grade the dysplastic nevi in a way which could bring more similarity in multiple departments. And then they introduced a new group of tumors which was known as melanocytomas. So when we look at the classification of melanomas, they are typically classified into these 4 categories, which is the lentigo-maligna type, the superficial spreading type, the nodular, and the acral lentiginous type. And this classification has been followed for more than 30 years without much changes. And it is a pretty good classification, but the only issue with this classification is it does not give any prognostic significance. So if I have a melanoma that is superficial spreading type that is 2 millimeters in depth, and I have a lentigo-maligna that is 2 millimeters in depth, there is no prognostic significance for the patient or for the clinician. And that was one thing that was not very useful when you provide the classification. So whether you say malignant melanoma superficial spreading type or lentigo-maligna type, it doesn't give any useful information to the clinician. So that was the reason they tried to come up with a new classification that was based more on epidemiological, clinical, histological, and more specifically on the genomic attributes of the lesion. And this was a way to actually try to see if they could provide some more useful information to the clinician so that they could treat the melanoma in a better way. And this whole classification was started off by Boris Bastian from the University of California in San Francisco, where he tried to divide the tumor, where he tried to divide melanomas based on first on the location and then second on the genomic aberrations within the lesion. And in the new WHO Blue Book, now the melanomas are classified into these 9 different categories. And each of these categories, they try to see if there is a pathway where they could explain the benign, borderline, and then the malignant, and then what underlying mutations are there in each of these pathways. So for the genetic evolution of melanocytic tumors, it is now pretty well proved in multiple studies that usually you have a normal melanocyte and then you have one genetic alteration that leads to building of the nevus. Then another genetic alteration leads to development of these intermediate tumors, and then this leads to development of the melanoma of uncertain malignant potential and finally into the melanoma. And for each of these categories, they divided them into benign, borderline, and malignant. So when you look at the types of sun exposure that people are exposed to, basically, so the first criteria was the degree of sun exposure. And the sun exposure was divided into either chronic sun damage or non-exposed skin. And in the chronic sun damage, there were 2 categories, which is just chronic sun damage and then non-chronic sun damage. So the sun damage that was supposed to be chronic was the head and neck, which was that because that is not covered by any clothes. So that was put in the category of the chronic sun damage. And then the non-chronic sun damage was the back and the extremities, which were sometimes exposed, but mostly not exposed. And then the unexposed areas are the legs and the genitalia. So, and when we look at the classification, it actually matched with what we originally had. So in the chronic sun damage, which was the head and the neck, the most common lesion was the lentigo-maligna type. In the non-chronic sun damage, which was the back and the upper extremities, the most common melanoma that was seen is the superficial spreading type, and that correlates with the underlying genetic mutation. And then the unexposed were the acral melanomas and the mucosal melanomas. So that was based on the sun exposure. The second criteria that they took to put the melanomas in these 9 categories was the topography of the lesion. Am I audible right now?
Yes, sir, you're audible, sir.
Okay, sorry about that. I'm in a hotel in Dubai, and this whole thing just shut down. The whole hotel shut down for just a minute, actually.
No issues, sir. Thank you.
Oh, it's coming back to the PowerPoint. Okay. So the other criteria in the classification was the topography. So like you had the mucosal melanomas that had a very different kind of mutations. You had the acral melanomas that have a very different kind of mutation. And then the uveal melanomas that had different kind of mutations. And then there were other melanomas that did not fit into these categories. Those were the melanomas that arised in a congenital nevus and the melanomas that arised in a blue nevus. So the context was also taken to like see where we could fit these melanomas into basically. And then finally there were some melanomas that did not fit into any of those, whether it is sun exposure, topography, or content, but they had very specific morphology like you have in the Spitz melanoma. So then that was a completely separate category that was put in the Spitz melanoma. And then finally, each of these melanomas, if they had an underlying genetic mutation, it was associated with that. And if it did not have the genetic mutation, then it was put in a separate category. So based on all of these, they tried to integrate the epidemiology, the genomic alterations, the clinical features, the histopathological features, and they came up with this new classification that had 9 different classes. And this classification actually has a lot of reproducibility because it is now following very, very specific features. But the most important part is because each of this category has very specific genomic alterations, it actually provided a good context for selection of therapy because there are many drugs that can affect specific underlying mutations. So this allowed a better way to like use targeted therapy directed against oncogenes and this immune therapy that was directed against new antigens. So this is just like the starting of the work in progress where they're moving away from a classification that had like 4 different categories without any prognostic significance to a different new class set of classification which might become much more mature by the next blue book, but which is now moving towards a place where it can actually help the clinician in providing a better diagnosis so that they can select the right therapy. So that was the first one, that was the first new thing that you saw in the WHO Blue Book for skin tumors. The second big thing that happened is the introduction of the classification of melanocytomas. So melanocytomas were initially, it was not a new concept because this paper actually came out in 2011 where Arthur Zembowicz and Richard Scollier came out with this paper where they talked about this term melanocytoma and they said, is there a group of borderline or low malignant potential melanocytic tumors? And this was the first paper actually that Arthur had actually published with Dr. Martin Mim, and that was way back in 2004, where they had introduced this term which was called as pigmented epithelioid melanocytoma, which was a low-grade melanocytic tumor with metastatic potential. So now the WHO has actually put in a definition for what does a melanocytoma mean. So it is in the WHO Skin Book 4, that melanocytoma was classified as a tumorigenic neoplasm of melanocytes that generally had increased cellularity and or atypia, and we will see a couple of examples in the next few slides when you compare that with a normal nuclear nevus, but they have an increased probability of neoplastic progression. Although it is generally still low, but they still can metastasize to at least to the lymph nodes, and many of these have actually metastasized to the lymph nodes, although they never kill the patient. So they don't kill the patient, but they still have a probability of neoplastic progression. And when you look at the underlying genetic alterations, in the nevus you had 1 hit, and in the melanocytoma it normally shows 2 genetic alterations. So there is a second hit that happens that leads to the progression of the lesion from a nevus to a melanocytoma. And if you look at the current 2023 WHO Blue Book, there are these 4 categories that have been put into the melanocytoma category. The one that was originally described in 2004, which is the pigmented epithelioid melanocytoma. The second one is the deep penetrating nevus, which is now given a new name, and is called WNT activated deep penetrating melanocytoma. Some of these deep penetrating also have a plexiform pattern, and those ones are called WNT activated plexiform melanocytoma. The third one was the BAPOMA that we have seen in the last couple of years, but now instead of calling it BAPOMA, they want to call it BAP1 inactivated melanocytoma. And then the atypical Spitz-Nevers, which we have been diagnosing for years and years, is now being categorized into a new name, which is called Spitz melanocytoma. So let's say if you look at the first one, pigmented epithelial melanocytoma, I'm going to try to see if the slide opens up. Otherwise, I'll just go back to the description. Okay. Can you see the slide? Do you see the whole slide image?
It's visible to us, sir.
Okay.
Now
So
it
this
is.
is sorry?
And now it is visible, sir.
That's good. Okay. So here is an example of a pigmented epithelial melanocytoma, where you can see that this is a nodular lesion in the dermis. These can sometimes have a little bit of infiltration at the periphery, but not always, but they can definitely have some infiltration in the periphery. And if you look at the epidermis, like 30% of these lesions can have some kind of an epidermal component, but in the 70% of the cases, there is no epidermal component. It is predominantly a dermal lesion. And if you look at the cytology of these lesions, this is composed of these large pigmented cells that you see here. So like the differential diagnosis, are these melanocytes or are these macrophages with pigment? But in a pigment, when you stain them with melanocytic markers, actually these pigmented cells, they stain as melanocytes. So that is the very characteristic feature of this lesion, where you have this large epithelioid melanocytes that contain a lot of pigment, and then admixed are these spindle melanocytes that you see here that also contain a lot of pigment. And if you do the staining, they would actually stain with the melanocytic markers. So all these large pigmented cells, epithelioid cells, are actually melanocytes, which give it the name pigmented epithelioid melanocytoma. So it is composed of these epithelioid and pigmented cells. Sometimes you might see rare mitosis. In this one, I didn't see any mitosis, but you can sometimes see rare mitosis. And if you look at the actual cytology of the cells, like if you go quite high power, you can see like there is a lot of pigment around them, and then you have a big nucleus, some of them having a prominent nucleoli. And like I said, they could sometimes have a little bit of infiltration at the periphery. Coming back to our PowerPoint. So we already described a heavily pigmented, predominantly dermal tumor with an inverted wedge or bulbous configuration, epidermal proliferation in 30% of cases. Sometimes they can have infiltrative borders. They're composed of these epithelial and dendritic melanocytes admixed with some melanophages. And then we talked about some nuclear pleomorphism. So these are actually images that I took from the same slide in case the whole slide image did not work. So these are the same images where you can see the epithelial and the dendritic pigmented melanocytes. How do you make the diagnosis is also like you look at the underlying gene activation. So the PRKRA1 is inactivated in most of these lesions. And why are we calling them a melanocytoma? Because again, they have a low to intermediate malignant potential, because in up to 46% of cases, they can actually spread to the regional sentinel lymph nodes. But very, very rarely do you see any distant metastasis. And the patients there has never been a single death that has been described with a pigmented epithelial melanocytoma. So even when they can metastasize to the lymph node, the prognosis is pretty excellent. And that is the reason they have been categorized in the class in the melanocytoma category. One is because of the better prognosis than a melanoma, And secondly, because they have the two hits, one is the BRAF initial hit that happens for the nevus, and the second is the PRKRA1 hit that happens for the pigmented epithelial melanocytoma. Moving on to the next one, which is BAPOMA, which was previously described as BAPOMA, which is now being classified as a BAP1 inactivated melanocytoma. So the BAP1 inactivated melanocytoma is characterized histologically by, again, the inactivation of the BAP1 gene. They also have epithelioid cell morphology. We will look at the actual slide. They also have the epithelioid cell morphology. These can sometimes occur sporadically, but most of them occur with the underlying BAP1 tumor predisposition syndrome. And that is the clinical significance of making the diagnosis. Because if you can make the diagnosis of BAP1 or a BAPOMA or a BAP1 associated melanocytoma, then the patient can actually be followed up for any other tumors that are associated with the BAP1 predisposition syndrome. There are a lot of tumors that these patients can develop at an early age. So if you can make this diagnosis when the patient is a teenager, then the clinician can follow them up and make sure that the other malignancies that are seen in this syndrome do not, like you can catch them at an early stage and the patient does not die because of the other malignant lesions. Here is a slide. We'll come back to the slide. Let's go back to it. We'll look at the images. So these are images that have been taken from the same slide. So what you see here is another predominantly dermal proliferation. Very rarely you have any kind of epidermal component. Like this is even less than the pigmented epithelial melanocytoma. These are mostly intradermal lesions. So when you look at this, it is predominantly an intradermal lesion. When you go down and look at the cytology, these are composed of these large epithelioid melanocytes that you can see here. If I go a little bit high power, you can see that these are large epithelioid melanocytes. They have sometimes eccentrically placed nucleus, sometimes a centrally placed nucleus, and most of them have a prominent nucleoli. The other very characteristic feature in them is many of them are going to show you this binucleation or multinucleation. So the binucleation and multinucleation is a very characteristic feature that is seen in most of the BAP1 associated lesions. Again, here you can see like some of them could be a little bit pleomorphic, some of them have multinucleation, and some of them have binucleation. And also the other very characteristic feature is there are scattered lymphoid aggregates throughout the lesion. You can see here there are scattered lymphoid aggregates throughout the lesion. So this is another very characteristic feature of the lesion. And if you do the BAP1 stain, BAP1 is a nuclear stain, so you can see the positive nucleus here in the epidermis, and most of the melanocytes, especially the large ones, are negative for BAP1. Many of the BAP1 can also have a associated regular intradermal nevus admixed within the large epithelioid melanocytes. And when you do the BAP1, it will be positive in the smaller melanocytes, that is the regular nevus, but it will always be negative in the large epithelioid melanocytes. So again, this one has an indolent course. It will never kill the patient. It can sometimes go to the lymph nodes, but will never metastasize beyond the lymph nodes. But the important thing is it can often precede the onset of other tumors that are associated with this syndrome. And those are like the uveal melanoma, acute mesothelioma, cholangiocarcinoma, and renal cell carcinoma. So if you let the clinician know that this patient has a BAPOMA or the BAP1 inactivated melanocytoma, and these are usually in the age of less than 20 years of age, so then the clinician can follow the patient up for all these different other tumors and make sure that if these tumors occur, they are caught at an early stage and the patient does not die, because all of these are pretty aggressive lesions. The next one is the WNT activated deep penetrating or the plexiform melanocytoma, which is previously called the deep penetrating nevus. And all of us have seen a deep penetrating nevus, but now we are given it a new name. These are usually young adults. Most of these lesions occur on the upper body, and usually they are a combined lesion. We call them combined because, again, like the BAPOMA, many of them are going to have an associated benign intradermal component. Here's a slide. We won't go into the slide. So these are these are usually composed of these. We'll just go to the slide here. So these are images taken from the slide. So again, if you look in the deep penetrating nevus, most of them will have an epidermal component. So there will be always be some associated epidermal component in most of the deep penetrating nevus, which is in contrast to the blue nevus, when the blue nevi mostly never have an epidermal component. And the deep penetrating nevus, which is the main differential diagnosis of blue nevi, especially the cellular blue nevi, you will definitely see most of them having at least some kind of an epidermal component. So that is one feature that you can use. They often have this wedge-shaped growth pattern, and they often then follow either the eccrine duct. This is following an eccrine duct, or they can follow a hair follicle down basically. So they will follow the hair follicles down or the eccrine duct down, and that is what it gives it the name, the deep penetrating nevus. But if you look at the cytology, it is pretty bland. It doesn't have any ugly cytology that you would normally see in a melanoma. They are composed of these bland looking melanocytes. Most of them are a little bit epithelioid. Some can be a little bit more spindled. There is a variation in the deep penetrating nevus where most of them are spindled, and those are known as the plexiform melanocytoma. But the regular ones mostly are composed of these epithelioid melanocytes, which have a very normal looking cytology with no hyperchromasia and no angry looking nucleus, not very prominent nucleoli, and they go deep into the dermis. Again, very rare mitosis might be seen, but mostly it will be a benign looking mitosis. It won't have the atypical mitosis. One very useful immunohistochemistry that can help in making the diagnosis of a deep penetrating nevus is beta-catenin. So if you look at a normal nevus and you stain it with a beta-catenin, it will actually stain like the HMB45, where you will see the positivity in the superficial part of the lesion. But as you go deeper, it will lose the beta-catenin in a regularly appearing nevus. But in a deep penetrating nevus, the entire lesion is going to stain positively with beta-catenin. It is almost like HMB45. And the HMB45 will actually stain diffusely like it would stain a blue nevus. So if you take a blue nevus, or if you take a deep penetrating nevus, you don't see the zonal positivity that you would normally see in a regular nevus. In a regular nevus, the HMB45 only stains the superficial part of the lesion, and as you move into the mid dermis and the deep part of the dermis, HMB45 is normally lost. But in a blue nevus and the deep penetrating nevus, there is actually quite a bit of diffuse HMB45 even in the deep part of the lesion. But it is the beta-catenin will also stain the entire lesion in a deep penetrating nevus. And then you can do the P16, and the retention of the P16 and the negativity for the PRAME can sometimes be useful if you are really worried about a melanoma. So this was the paper that came out of France that actually talked about the beta-catenin nuclear expression. And again, it has to be nuclear positivity, not cytoplasmic positivity. So you have to be very careful of what you're talking about positivity when you look at the beta-catenin. So here you can see like it is positive in the deeper part of the lesion and also the superficial part of the lesion. So then coming to the atypical Spitz nevus, I'll just straight away go to a slide here because I don't have a description of this one. Okay. So when you talk about a Spitz nevus or a atypical Spitz tumor, or you talk about a Spitzoid melanoma, the most important thing is the Spitzoid cytology, basically. So like what do you mean by a Spitzoid cytology? So when you look at any of these lesions, they tend to have these very large epithelioid cells with a nucleus that is where there is a big increase in the nuclear cytoplasmic ratio. So there is a big increase in the nuclear cytoplasmic ratio because the nucleus is pretty large, and most of them will show a prominent nuclei, whether it's a benign nevus, that is a benign Spitz nevus, whether it's an atypical Spitz tumor or now a Spitz melanocytoma, or whether it's a Spitzoid melanoma. The cytology of all of them is pretty similar actually, where you have this big melanocyte, increased NC ratio, and prominent nuclei. All of them are going to show the same cytology. So you can see these epithelioid big nest within the epidermis that are composed of these epithelioid and a little bit of a spindle morphology. And when you look at the epidermis and you look at the periphery also, you start seeing a little bit of pagetoid spread at the periphery actually. So when you're looking at a Spitz lesion, what are the features that you want to look for to differentiate a Spitz nevus from an atypical Spitz nevus versus a spitzoid melanoma? So the way where you start from the top, the one thing is whether the epidermis is acanthotic or atrophic. So in a regular Spitz nevus, the epidermis tends to be quite acanthotic. And as the lesion progresses to an atypical Spitz nevus to a spitzoid melanoma, the epidermis starts to become a little bit atrophic. And in a spitzoid melanoma, you might even see some ulceration that is happening because the epidermis has become very atrophic. So that is the first thing that you see when you are looking at the lesion on low power, whether the epidermis is hypertrophic or atrophic basically. So in the benign Spitz nevi are usually associated with a hypertrophic epidermis, and the spitzoid melanoma are associated with an atrophic epidermis. Then you are looking at these melanocytes that are within the epidermis and sometimes within the dermis. You look for the spitzoid morphology that we already talked about. And then you also look for pagetoid spread. So even a benign Spitz nevus is going to show you pagetoid spread in the epidermis. So pagetoid spread does not always equate to a melanoma. You can see it in a benign Spitz nevus. But in a benign Spitz nevus, the pagetoid spread tends to be more in the central part of the lesion. And as the lesion becomes more towards the atypical side, the atypical Spitz nevus or the spitzoid melanoma, the pagetoid spread starts coming also at the periphery. So here you can see there is a pagetoid spread at the periphery basically. Then in most lesions, they talk about the pleomorphism of the melanocytes. Now, pleomorphism is in the eyes of the beholder. In a spitzoid melanoma, what do you call pleomorphism? Because when we talk about a spitzoid cytology, we're already talking about a large cell. We're already talking about an increased nuclear cytoplasmic ratio, and we're already talking about presence of prominent nucleoli. And when you look at any other tumors like a squamous cell carcinoma or very atypical looking melanoma, these are the features that you want to look for when you talk about pleomorphism. So then, does that mean that every Spitz nevus is pleomorphic or every atypical Spitz nevus is pleomorphic? No, because in pleomorphism in Spitz nevus, the definition is variation in the size and the shape of the cell. So here, if you see all of these cells are big, all of them have a high NC ratio, and all of them have a very similar looking nucleus, then it is not called pleomorphic. But if I see a big nucleus here and a smaller nucleus here and a spindle nucleus here, like you can see a little bit of spindle, when you start seeing variation in the size and the shape of the melanocytes as well as the melanocytic nuclei, then we start thinking of this being pleomorphic. But in a Spitz nevus, most of them are very monotonous looking. Even if they are big, even if the nuclear cytoplasmic ratio is high, there's a lot of monotony within the melanocytes. But when you start seeing, you start losing the monotony within the melanocytes, then you call it a pleomorphic cell, the melanocytes actually. So when you are thinking about pleomorphism in a spitzoid category, you want to look at the variation in the size and the shape of the cell. Then you want to look for mitosis. If it is if you have a dermal component, you want to look for mitosis, and the presence of pigment. So again, if you see a presence of pigment that is irregularly distributed, then again it starts falling into the atypical versus the spitzoid melanoma. So there is no one feature that can help you make a diagnosis of an atypical Spitz nevus versus a spitzoid melanoma versus a Spitz nevus. You have to take all these criteria together, and then also the like the Ki67. How is it high? When I do the HMB45, do I start losing it in the deeper part of the lesion? Do I see atypical mitosis in the deep part of the lesion? So you take all of these in and then like try to figure out where your lesion is going to fit into. And many times, in spite of doing all the histology, you still need additional molecular testing like FISH and CGH to make the diagnosis of a spitzoid melanoma, especially when if the patient is a young patient. So those are all the features for a atypical, spitzoid, melanocytoma. So we talked about all the four categories of a melanocytoma. Now the next new thing that was described in the 2023 WHO Blue Book was the dermal melanoma. Now this is a very hard category to diagnose because there is no specific criteria to call something a dermal melanoma. But what the book is describing in the WHO Blue Book is that you call something a dermal melanoma if there is an absence of a prior history of melanoma and you have excluded clinically and radiologically any suspected melanoma at any other site. And now what you currently have is a predominantly dermal lesion. There is no epidermal component. So there is no intraepidermal involvement, and those are the lesions that they are now calling a dermal melanoma. But it is a very difficult diagnosis because how do you distinguish this from a metastatic melanoma? There is no way to. There could have been a melanoma 20 years ago, and we have seen cases like that later on develop a metastatic lesion, and now there is no history of the primary melanoma. But as many of the authors that were on the WHO Blue Book have seen a lot of these lesions that actually present as a dermal melanoma, and the difference was the prognostically these lesions tend to behave a little bit better, and that was the reason they specifically wanted to bring in this category so that more and more people will start looking for dermal melanomas when they see a very atypical lesion in the dermis and not call everything a metastatic melanoma when they do not have a history of a primary melanoma in the past. So this diagnosis is very easy. You can see this is very, very pleomorphic. The cells have this very the very angry looking nucleus, very prominent nuclear variation in the size and the shape. So this diagnosis quite a bit of mitosis. So the diagnosis is very easy, but to call this dermal melanoma is not easy. But they want to at least bring this category into the new book because they have seen that the prognosis is significantly better than metastatic melanoma and better than melanoma of similar breast thickness. So, although they can show recurrence, although they can show distant metastasis and death has also been reported, but compared to a similar melanoma of same breast thickness, these have been shown to have a better prognosis, and that was the reason they brought in this category of a dermal melanoma into the 2023 WHO Blue Book. And then the last lesion that I'm going to talk about that has been brought in the melanocytic category is the CRCT1 TRIM11 cutaneous tumor. Although it has not been put in the melanocytic chapter, but it has some degree of relation, some relation to the melanocytic tumors. Again, I have a slide. I won't go into the slide, but here are pictures that I've taken from the same lesion. So these again present predominantly as a very well circumscribed dermal nodule. In all the cases that have been described so far in literature, there no epidermal component has been described. So these are predominantly intradermal, nodular, apigmented. They don't show any pigment. So these are apigmented lesions that you see in the dermis. And when you look at the cytology and you go high power, these are composed of these epithelioid and a little bit of a fusiform cells. And they can have scattered mitosis. They can show some scattered mitosis, and sometimes they can also show binucleation. So binucleation and multinucleation is a common feature, and these lesions are important to recognize because these look very much like the clear cell sarcoma. So if you look at the histology, it is predominantly like the clear cell sarcoma, and the clear cell sarcoma can also show mitosis. They can also show multinucleation, although the multinucleation in a clear cell sarcoma tends to be more wreath-like versus the binucleation and that you see in these tumors actually. So when you actually go and do the stain, these are very strongly positive for SOX10, but they are negative or partially positive for the other melanocytic markers. So they have some linkage to the melanocytic markers, but they are not all positive for melanocytic markers. The only one that is truly positive is SOX10. But if you look at the HMB45, it is pretty negative. The MART1 here is pretty negative, and then the PRAME and the P16 are also pretty negative. So these are dermal and spindle cell tumors. So this is a dermal neoplasm that is composed of spindle cell and epithelioid cells, and they have partial melanocytic differentiation, But the one thing that they all commonly have is this translocation. So when you do the genomic studies, all of them are going to show this translocation, which is the CTCR1 and the TRIM11 translocation. The 50 cases that have been described in literature, most of them have been on the extremities, and then some of them have been described on the trunk and other parts of the body. They are usually slow, painful. They can be painful, and they are slow growing lesions. But the important feature is they are diffusely positive for SOX10, and then S100 can be positive in 50%, but not all of them. And then the other melanocytic markers are usually either focally present or mostly negative. And there is an immunohistochemistry for the TRIM11 right now available, and that will typically be positive in the nuclei and the periphery of the nodule. But if you all the follow-up of the 50 lesions that have been described, there have been one case of a metastasis and one case of a recurrence. The rest of all of them have shown an indolent behavior. So right now it is still, all these are like not very commonly described lesions. So in the next edition, there might be different, they might be put into a different category, but currently they are put in the more benign to atypical lesions that behave in a more indolent behavior compared to other lesions. And they do not show the typical translocation that you would see in the clear cell sarcoma, but they show their own translocation that is seen in the CRCT1 TRIM11 cutaneous tumor. That's it. Yep. So these are all the new things that came up in the WHO Blue Book in the 2023 one.
You can continue, sir.
Yeah, so I'm done with the presentation. If you have any question, I can answer any question actually.
So that was a very informative, enlightening session on melanocytic lesions. So, sir, I have a small doubt, sir. Can I ask?
Yeah, please.
Sir, what is the use of this electrical impedance spectroscopy on regarding detecting this maybe are you using any of this pigmented lesion essays, something like this, which I have gone through recently? Pigmented
No,
lesion.
like we are not using them at our institution. What we use is more confocal and dermoscopic imaging and all that, but not any kind of electrical impedance. We haven't used any of that in the institution as of now.
Okay, sir. So, in a setting where, in a resource poor setting like India, so it's really difficult to get all these marker studies done, sir. So, in that case, how should we go about?
Like the histology is going to be the most important feature, like to make the diagnosis. And if you look at all these lesions that we described today, like if you look at the CRDC1 and then the bapomas, all of them are not killing the patient or not doing anything harmful to the patient. It is the only thing is important is to like recognize them so that you can help the patient for future, for any other associated diagnosis that might be related to that diagnosis. So if you don't really need immunohistochemistry for most of these lesions, like for a bapoma, we never do the BAP1 because the BAP1 doesn't stain very nicely.
Okay.
So we just, when we look at the histology, we see a dermal nevus, we see binucleation, we see the associated lymphocytic infiltrate, we see the big epithelioid cells. We tell the clinician this is most likely a BAPOMA, but if you think that you need a very definitive diagnosis, then we will get you the immunohistochemistry and do the stain. But most of the times we are not actually going ahead and doing all these immunohistochemistry for every lesion that we get here, basically.
Okay. Thank you, sir. Any other questions?
Any other questions from audience?
Yeah, sorry about the 1 minute thing that happened, but I'm in a hotel in Dubai because I'm presenting at a conference here. So it's not in my control here at all, basically.
Thank you for the presentation, sir.
I've talked about every single aspect in detail. Now I request Dr. Arundhati Ma'am, Department of Pathology, AIIMS Mangalagiri, to felicitate the chairpersons. And sir, we request you to accept our token of gratitude sent to you by the post.
Thank you very much.
I request Dr. Arundhati Ma'am, Associate Professor, Department of Pathology, AIIMS, to felicitate the chairpersons. Now I request Dr. Prabhakaran sir to receive the token of gratitude. Thank you, sir, and thank you, ma'am. Finally, yet importantly, we are going to explore on the final topic of the session, diagnostic updates and molecular profiling in hepatobiliary and pancreatic neoplasms. Following this session, cultural events will be beginning. For this session, I would like to invite our chairperson, Dr. Shushma Ma'am, Associate Professor, Sri Atal Bihari Vajpayee Institute of Medical Science and Research Institute, Bengaluru. Ma'am has multiple publications in various national and international journals. Ma'am has presented multiple papers and posters in various conferences and also won first prize in National Annual Conference of IMA for oral paper presentation, Bengaluru, in the year 2018. Her area of interest are oncopathology, soft tissue pathology, and molecular diagnostic work. Welcome, ma'am. Now I'd like to welcome our next chairperson, Dr. Sagna Gupta, ma'am, Associate Professor, Department of Surgical Gastroenterology, AIIMS Mangalagiri. Ma'am has multiple publications in national and international journals and also contributed for several book chapters. Ma'am has interest over areas such as hepatobiliary and pancreatic surgery. Welcome, ma'am.
Good evening, everybody. It's an honor and privilege to introduce our next speaker, the last speaker of our day one of our conference on the international pathology, Dr. Manoj Jain, Professor, Department of Pathology from SGPGIMS, Lucknow. He has 160 publications in his credit, and he's renowned resource person recognized as a former president in the Indian Society of Renal and Transplantation Pathology, and also served as a former vice president in the Indian Society of Organ Transplantation. Over to you, sir. So he's going to talk on the diagnostic update on the molecular profiling in the hepatobiliary and pancreatic neoplasm. Over to you, sir.
No. Thanks, Chairperson, for a kind introduction. First of all, I congratulate Dr. Jyotsna and Dr. Jyoti for making this conference so comprehensive and including molecular updates in this conference and connecting all stalwarts in the field. So after listening all, everyone is exhausted, so I'll be not taking much detail. So if you see the hepatobiliary and pancreatic neoplasms, they are less common cancer. They are not among the top 5 cancers as listed. And there we have very high mortality rate among the leading cause of the cancer death. And detection at early stage is important for the effective management. And this molecular profiling may help in the early diagnosis, in prognostication, in therapeutic decision making, and in targeting therapy. And there are markers which are pan-cancer and tumor-specific biomarkers which may be useful in the management of hepatobiliary pancreatic neoplasm. They can be divided: tumors of the liver, tumor of the bile duct, in which intrahepatic bile duct, extrahepatic bile duct. In intrahepatic, smaller, larger bile duct variant, WHO 2019 has introduced this. Then tumors of the gallbladder and tumors of the pancreas. Pointer is there. You can make pointer in this. So if you see the tumor of the liver, there are benign tumor of the liver. There is focal nodular hyperplasia and hepatocellular adenoma. They are the common one. They has to be differentiated because of the prognostic significance. In focal nodular hyperplasia, they contain abnormal muscular vessels and lack associated bile ducts. And glutamine synthetase is MAP-like staining is that I'll be coming. Okay. If you see the hepatocellular adenoma, they occur most frequently in So they have benign clonal proliferation of mature hepatocytes in non-cirrhotic livers. And previously they were classified based on the IC marker, LFABP, beta-catenin, glutamine synthetase, C-reactive protein, serum amyloid A. Or now they have corresponding molecular signatures for that. So HNF alpha inactivated hepatocellular carcinoma, they have morphologically, they have steatotic hepatocytes and prominent interstitial and loss of cytoplasmic LFABP. Whereas well-differentiated hepatocellular neoplasm, they are beta-catenin activated. They have got homogeneous staining for glutamine synthetase. Whereas in focal nodular hyperplasia, they show MAP-like staining. And inflammatory hepatocellular carcinoma, there will be inflammatory cell infiltrate. So if you see the molecularly, they are defined HNFA inactivated HCA, which comprises major chunk 30 to 50%. They have got low risk of complication. In which beta-catenin activated HCA, they have highest risk of malignancy, especially in exon 3 beta activated. They may convert into hepatocellular carcinoma. Then beta activated inflammatory, they have got also risk of malignancy. Then sonic hedgehog hepatocellular adenoma, they have got highest risk of bleeding and low risk of malignancy. So if you see the hepatocellular carcinoma in 2019, they have been graded well differentiated, moderately, and poorly differentiated. If you see the histological typing, there can be serous type, fibrolammellar, steatohepatic, clear cell, lymphocyte rich, neutrophil rich, microtubular, chromophobe, and sarcomatoid variant. In trabecular, more than 8 to 10 thick liver cell plates will be there. In pseudoglandular SNI, they have to be differentiated from the cholangiocarcinoma, especially in the hilar region. Then solid growth pattern can be seen. Serous variant can be seen. Steatohepatic variant can be seen, which will be having fat in that. If you see them on molecular signatures, in these carcinoma, steatohepatic carcinoma, they have activation of interleukin-6 JAK-STAT pathway. They have got good prognosis. Metabolic syndrome, hepatic steatosis can be seen in this. Then beta-catenin mutated hepatocellular carcinoma, they can be on the hepatitis B related, they can be. Then mutation of CTND1 gene and WNT pathway, signaling pathway is seen in this. They are well-differentiated tumor in microtrabecular, pseudoglandular pattern, cholestasis. They have got good prognosis. Then microtrabecular massive, there's a TP53 mutation and amplification of FGF19. They have got worse prognosis. Then serous type, there can be tuberous sclerosis 1, tuberous sclerosis 2 mutation, TGF beta signaling activation can be there. Then dense intratubular fibrous, more than 50% tumor can show serous area. They have got decreased survival. Then in fibrolammellar variant, there is microdeletion of chromosome 19 with DNAJB9 PRK CA fusion. this entity has been introduced in the 2019 classification. They have got more favorable prognosis and normal AFP level. If it's the integration of hepatocellular carcinoma with histological features and transcriptomic classification and genetic alterations, so they can be non-proliferative type of tumors, proliferative tumors. In non-proliferative, they have got good prognosis, well-differentiated tumor. They can be CTNNB1, this beta-catenin pathway subtype, then steatohepatic type. Then in poorly differentiated, ischirus type can be, and they are G1, G2, G3 in different molecular subgroup. Different publications have labeled it S1, S2, S3, G1, G2, cluster A, cluster B. Then in genetic alteration, there can be TP53 mutation, FGF19 mutation. So they are actionable gene, and they have got some treatment. Then oncocytic pathway upregulation of cell cycle genes, TGF beta can be seen. RAS-MAPK, PIK3, AKT pathway can be seen in this. Whereas in well-differentiated JAK state and W and T beta-catenin pathway is seen. If we try to correlate on morphology, then highest incidence is of the CTNB beta-catenin BSCC hepatocellular carcinoma, and they have 10 to 20%. Then microtubular massive MTM hepatocellular carcinoma, they're 10 to 20%. Then steatohepatic, around 10%. The ischirus type, 5%. Progenitor PG SCC, less than 5%. Then lymphopathia like, they're less than 5%. So if you see the hepatocellular carcinoma, as per guidelines, there is no actionable genes in this targetable treatment is available for the hepatocellular carcinoma. Then tumor of bile duct, they can be cholangiocarcinoma. It's the second most common tumor of the liver, originating from the biliary system. Then the biliary tract cancer are very heterogeneous tumor with respect to localization, pathologic subtypes, and various genetic defects. Carcinogenesis of cholangiocarcinoma is a multi-step process beginning with transformed biliary epithelium cell from stem to progenitor cell. Based on growth pattern, mass-forming, periductal, infiltrating, intraductal, undefined, mixed type are differentiated on histological basis. So sometimes there is difficulty in, especially in the hilar region, to differentiate mass-forming cholangiocarcinoma with hepatocellular carcinoma. Then immunohistochemistry can help arginase, glypican-3, HepAR1, CK7 that can help in differentiating these tumors. If you see that cholangiocarcinoma, they can be intrahepatic, they can be hilar region, then common bile duct, they can be. Even gallbladder also shows some molecular similarity with cholangiocarcinoma. In small duct variant, there will be small duct, they have to be differentiated from pseudoglandular type of hepatocellular carcinoma. They are cholangiocarcinoma usually so dysplasia, marked dysplasia. There will be no capsule, peritumoral capsule will be there. So if we see intrahepatic cholangiocarcinoma, this can be small duct type and large duct type. This has been differentiated in WHO 2019 classification. If we differentiate, they are peripheral liver parenchyma, they are proximal to hepatic hilum. Their non-biliary cirrhosis, chronic viral hepatitis can be seen in small duct type, whereas primary sclerosing cholangitis, liver fluke infiltration, hepatolysis predisposing factor for large duct type is intrahepatic cholangiocarcinoma. There will be periductal infiltrating. Small duct will be, there will be mass forming. Then histogenesis small bile ducts, they are intrahepatic large bile ducts. Then they are mass forming tubular or ductular pattern with desmoplasia. Central scarring will be non-mucin secreting cuboidal gland will be seen. Tumor borders will be expansile or pushing in a small duct type, whereas in infiltrative type, they will be infiltrative type in large duct. In immunohistochemistry, CD56 and cadherin CRP will be positive. S100 and TFF1. Here, molecular diagnosis is important in differentiating because of their prognosis and their therapeutic actionable treatment. Molecular feature-wise, they are IDH1, IDH2 mutated and BRAF mutated. FGFR2 fusion can be seen in this. Whereas in large duct type, KRAS and T53 mutation, SMAD4, COX2, GNAS mutation can be seen. Here, this imatinib tyrosine kinase inhibitor can be taken as a treatment. They have got good prognosis as compared to large duct type intrahepatic carcinoma. So if we see the National Comprehensive Cancer Network guideline, latest guideline, in which there are the, molecular targets which are pan tumor specific, just like NTRK gene fusion, MSIM mismatch repair, and tumor mass burden, and then BRAF mutation. They should be done in gallbladder, intrahepatic, extrahepatic. Whereas FGFR fusion, IDH1 mutation, HER2, they are recommended for the intrahepatic cholangiocarcinoma and extrahepatic cholangiocarcinoma. If we see the percentage wise, they can be 1 to 30% if all tumor are taken together. So their incidence varies for these markers 1 to 30%. Now coming to this gallbladder adenocarcinoma, they are significantly more common in parts of India. Many parts of India, they are significantly more common. Just like in North India, there is a belt of adenocarcinoma. Then Latin American countries, Eastern Asia, and Native Americans. Tumor, they are typically CK7 positive. So the same, just like in cholangiocarcinoma, they are also CK7 positive. Apart from that, in gallbladder adenocarcinoma, they can be CK20 positive, MUC1, MUC5AC, TAG, and CA99 can be expressed in this. There are more than half the gallbladder carcinoma show T53 molecular alterations. Other common alterations involve CDKN2A, CDKN2B, ARID1A 13%, PIK3CA 10%, then CTNNB beta catenin pathway 10%, then HER2 in 16%. The incidence of KRAS oncogenic mutation and loss of SMAD4 protein expression are far less common than in pancreatic tumor, and microsatellite instability can be seen less than 10%. So if you see the gallbladder carcinoma, this HER2 and KRAS, they are actionable, then their treatment can be done. Then coming to characteristics of pancreatic epithelial cells and corresponding neoplasms, they can be, I am touching the common one. Then ductal, there's a pancreatic ductal adenocarcinoma, acinar adenocarcinoma, and then neuroendocrine carcinoma. If you see light microscopically, there will be glands, papillae, lumina, and mucin. On immunohistochemistry, glycoprotein markers, CA99 can be positive. In genetic alteration, in pancreatic ductal carcinoma, there are common 4 gene mutations, that is KRAS, T53, CDKN2A, SMAD4. Along with that, DPC4 and P16 can be positive. In which KRAS mutation is seen approximately 90% of pancreatic duct adenocarcinoma. In acinar adenocarcinoma, there can be beta catenin pathway. In neuroendocrine tumor, morphology will be characteristic neuroendocrine tumor, nested trabecular gyriform pattern. Then cytological uniformity, salt and paper chromatin will be there, and chromoganin synaptophysin will be positive in pancreatic neuroendocrine tumor. Then MEN1 gene, ATRX gene, mTOR pathway can be then. Then they can be graded based on the NET classification, NET1, NET2, NET3. So if KRAS mutation is seen in more than 90% cases of the pancreatic ductal adenocarcinoma, and T53, CDKN2A mutation can be seen, SMAD4 can be seen. Then these mutations activate signaling pathway that promote cell proliferation and survival, contributing to tumor growth. So in CAP guidelines in 2023, these are the recommendations for the predictive biomarkers in pancreas, biliary, and hepatocellular carcinoma. In KRAS negative cases, other driver mutations are commonly detected, including some druggable one in which treatment can be given, just like fusion of FGFR2, NRG1, and TKR3 and ROS1 mutation, and BRAF V600E mutation, and ERBB2 amplification. Then germline alteration are also important in pancreatic duct adenocarcinoma, especially genes involved in DNA damage repair. BRCA1, 2 altered pancreas are sensitive for this platinum-based therapy. So see the CAP guideline for the molecular diagnosis and targeted treatment of pancreatic biliary tumor. So these above these markers are pan tumor, pan cancer marker, NTRK123 gene fusion, MSIH and mismatch repair, and tumor mass burden. They should be done in pancreatic duct carcinoma, intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder carcinoma. In hepatocellular carcinoma, they are not recommended because they don't provide, they can be used for the diagnostic purpose. Then FGFR2 fusion, IDH1, IDH2 mutation, they are recommended for the cholangiocarcinoma, extrahepatic cholangiocarcinoma. HER2 overexpression amplification is also recommended for the intrahepatic and extrahepatic cholangiocarcinoma. And red gene fusion, BRCA, can be done in pancreatic duct